optimal loading. So this is the terminology which you use as a conservative management. Like protection, you protect the joint. Keep it a joint of comfort, ice application, compression, elevation. Whatever the movements the patient can do it, that is called as optimal loading should be done to these patients. So this is actually examples of different things. And we always say avoid IM injection. You don't have to write a big like bold letters. The patient in surgery get an IM injection and hematoma. That's most commonly we see in hemophilia patients. We have to avoid IM injections and we have to avoid the difficult IV tricks, especially pediatric patients. You can see two patients here. One of them is about at the age of 1 year had an IV blood collection and patient had a compartment syndrome, had to undergo surgery. See the scar, it's such a huge surgery patient has got. And this is also post-IV collection patient had a compartment syndrome. So that's the reason we always tell better you should avoid cubital vein. We never teach the parents to put in a cubital vein because of this problem. Whole night they bleed and parents will not even realize the next day morning is such a very bad complication of requiring the compartment syndrome surgery. So the next one is everybody likes cricket in India. So avoid contact sports. This patient, after playing with cricket, he had a trauma with the ball and he had a see how bad his eye is. You know, they did not go to the doctor for almost 2-3 days and he has lost the eyesight. So you have multiple times to tell them we have at least about 4 to 5 patients who have lost their eyesight because of the bleeding in the eye. So we always have to counsel. See, it's not a one-time job. So keep on counseling them multiple times. So regarding avoid contact sports, aspirin, they take diclofenac, they take about 2 days of diclofenac, they get in shock because hemoglobin drops to 2-3 grams. So that's a common phenomenon we see patients actually. So you avoid MSADs and trauma by adjusting the lifestyle. Once it becomes the small child becomes an adult, they avoid trauma, they adjust their food weight, they adjust their so lifestyle like that, they avoid, they will not breathe. So I only told what to be avoided. I'll tell what is to be done actually when the patient has got a problem with hemophilia, ice application at the site of bleed. Early factor correction, as you have in the golden hour in cardiac like MI, we have hemophilia patients also. We to treat the patient within 2 hours of bleed, they have better outcome. So that's the reason we always stress the NHM National Health Mission to make centers all over the Maharashtra, different states. Every state, every district should have a hemophilia treatment center because earlier factor correction, we have hemophilia patients entire bleed comes to KM hospital traveling 8 hours. So that is illogical, no? So that is the reason early factor correction is important. All procedures should be done under IV correction. All immunization, just because they are hemophilic, we should not avoid any immunization. All immunization can be done subcutaneous except DPT. So DPT can be small, maybe 26 gauge, maybe can be given without any factor correction. And regular exercise is very, very important for the muscle power. Dental hygiene, we have a dentist, a professor, she will talk about dental hygiene. So we encourage them to do swimming, cycling, badminton, and table tennis because swimming is a very good exercise for all the muscles and they can get a good power. And when the school they start school, we always give a letter to the principal stating that patient's hemophilia. Otherwise, in the past, we had actually problems with they had to try and stay to carry so much. And these are not small issues, but it's made a huge difference. No, the patients get a physical punishment that does because they don't do the physical class. So you tell them to encourage the indoor games rather than the outdoor games. So these are all things which you can adopt to for a better outcome. So how should we apply ice? You can see here, there is an ice pack. You can get a gel pack. No, nowadays you can gel pack. Just apply over the joint gel pack for about 15 to 20 minutes and give a gap of 4 to 5 hours. That is how you can decrease the pain. You know, some of the management for the pain we can do in hemophilia patients. If somebody don't have an ice, you can apply any ice in the towel and you can put it around the joints. And immunization, as I told, all immunization should be given for hemophilia patients and you have to apply pressure over the 10 minutes. So I told you about something about the factor correction. These are all the factors actually. Hemophilia patient factors nothing but injection. You can see this is a factor, this is a diluent, this is like sterile water. This is sterile water, diluent. This is a lyophilized powder. It's a powder. So which is diluted with the sterile water and you give an injection that is called as factor 8. We get factor 8, factor 9, multiple injections are available. So we can use that. And factor 8 off-life is 8 to 12 hours and factor 9 is 18 to 24 hours. So this means that hemophilia patient when you give factor 8, by about 2.5 days, the factor level goes back to 0% because they are less than 1%. So different types of factors there. You must have seen in your hospital there are different factor, high purity factors are all available. So, and recombinant factors are available in our country also, so which can be used for the management. So for the students' benefit, I put about what is the difference in the recombinant factors. In third generation recombinant factors, there is no blood either in the initial stages or the end product. That is the third generation recombinant factors. So in any of these products, there is no risk of transmission transmitted disease. Especially in conventional plasma factor, because there is a risk of infection. Even with plasma derived factors, because they are such so much of purification undergoes, there is no risk of any HIV, hepatitis B, or hepatitis C. Even with plasma derived the recombinant factors, there is no risk. So you can tell the patient, counsel the patient that you can take the factor which is available in the country. So in our country, so there are the factors which are available. So we have long acting factors are also available. These are the multiple types of factors which is available as of now in our country. So WFH doesn't discriminate between plasma or the recombinant. It only says don't give plasma. Initially, it used to be effective for the treatment of hemophilia patients as a cryo. So now that it says that give factor whatever you have, but don't give plasma as a cryo because of the risk of HIV, HSV, and HCV infection in these cases. So acute hematosis, I already mentioned, this is the classical presentation of acute hematosis. You have a joint swelling, it's in the shining skin, and the patient is keeping the hand in the flex position, movement restriction. This is about the acute elbow hematosis. So how do you correct the factor correction? So the patient has come with the joint correction. So any of you have treated hemophilia patient? Okay. Oh, madam, actually, students, any of the students have treated hemophilia patient? So in acute, different hemophilia patients coming with joint, the muscle, and brain, they have different corrections. You know, this is the WFH guidelines. Usually joint bleeding is about 20% correction, 20 to 40% correction in the joint bleeding. Muscle bleeding is about 60% correction, brain bleeding is about 100% correction. So 40% correction means what? If somebody, the patients usually have a 0% and you make it 40%. I'll let you know how to do the correction also in the next slide. So in hemophilia patient, hemophilia A, you can see here, 1 unit of factor will raise by 2%. So 1 unit of factor rate will raise by 2%. And how will you calculate this desired level? I told you in the joint bleeding there going to be 40%, and in the brain bleeding there going to be 100%. So 40% is this much, and patient level is 0%, and into weight into kg divided by 2, because 1 unit will raise by 2%. So this is how you calculate the dose. In a 45 kg patient, you want to give a joint hematosis. You want to treat a joint hematosis. How much factor you want to give? 45 kg patient, joint hematosis. How much factor we going to give? 45 into 40 divided by 2. So that is how you calculate the dose of factor in these patients. If the patient comes with brain bleed, 45 into 100 divided by 2. That is how we calculate the dose of factor. And after 8 hours, we're going to, after about 12 hours, we're going to repeat the factor. Because in the body, we have, its half-life is 12 hours. If somebody gets 2000 in the morning and 1000 we give in the night, because half-life, half the factor is going to stay in their body. So you 1000 in the evening and again 1000 BD, you continues for 10 days in the intracranial bleed. So you maintain the 100% correction in these patients of hemophilia with this factor correction. So factor 9, how do you calculate the factor 9 is 1 unit will raise by 1%. So you have to calculate like 45 into 40, no division by 2, because 1 unit raised by 1%. That is how you calculate the factor 9 correction in these patients. So this is a patient, one more case I'll show you. 8-year hemophilia patient coming with headache and vomiting, went to pediatrician. Pediatrician gave them paracetamol and NSAID, and patient went home, and next day severe headache came with, and again patient has come with CT scan has been done, and patient has massive intraparenchymal bleed and extradural hematoma. Patient was intubated and a ventilator referred to KM hospital. See, this could have been avoided when the patient has come in the first day only. They could have done the CT scan and treated the patient. This stage could have been avoided. That is the whole purpose of this talk is actually. So see, this such a massive bleed, this patient survived, but is in a very debilitated status. So that complication we can avoid when you treat the patient earlier. No, this is such a massive bleed in this patient. So what are the don'ts in this cases? Headache and vomiting in hemophilia patients always intracranial unless otherwise proven. So it's dictum that it should always be intracranial bleed. Don't wait for CT scan the patient. You might lose the patient in CT scan department only. So they might die in CT scan department. So give factor correction, full 100% correction you have to give them.
At least you don't have factor 100%, at least give whatever you have in your hospital and send the patient to the center wherever they have a full correction. And you have to continue factor correction at least for 10 to 14 days. We get patients, they receive 1 dose of factor and the next day headache worsens and they come to the hospital. So you have to correct at least up to 10 to 14 days. You have to correct the factor correction in these patients of intracranial bleed. This is the same thing I mentioned again and again, how much correction should be done. And in this patient, how do you calculate the dose? I have mentioned here for 25 kg patient, 100% divided by 2. So 1250 you give on the first dose. Next dose you give usually 650 or 750, round up to 750. After 12 hours, we give 750. And third dose and also we give 750 IU, BD we give for 10 days. And always test for the inhibitors, because how do you know that the patient is responding to the factor whatever we are giving. So test for the inhibitors usually on the 5th day in these patients of hemophilia with who's get the continuous factor correction. The other drugs which can be given is the drugs which can be given. Patient come with oral bleeding, dental bleeding. We don't give sometimes factor also. We give only tranexamic acid in this patient. Except for hematuria, everywhere else you can give tranexamic acid in this patient of hemophilia. DDIP is not available in our DDIP is available in our country for the diabetes insipidus because the concentration is very less. Here the concentration required is very high, so that concentration is not available. So we are not using the DDIP, but it can also be used. So we need to give an intranasal spray. 150 microgram per nasal spray is the strength we require, but it's not available in our country for that. So this is one more case who has come with chronic synovitis. The patient is on factor once a week therapy, but still the chronic synovitis is worsened. So how should we treat? There's something called target joint. Target joint is if the patient has got more than 3 bleeds in the same joint over the next 6 months, consecutive 6-month period, they're called as target joint. So how do you treat? You can give them factor correction for intermittent prophylaxis you can give, or you can give them something called as intra-articular synovectomy. So both our doctors will tell about that. So this is about this patient. The treatment we are giving for hemophilia patient, that's called episodic therapy, is that does not change the natural history of hemophilia. We have to give something else that is called as prophylactic therapy. So episodic therapy has shown this from the study which has shown from the CMC Vellore. If you give patient whenever they bleed and give factor, the joint function is worse. You can see if somebody has got more than 3 bleeds in a year, the joint function is bad, actually. So that's the reason we give something called as prophylactic therapy. If the patient has got more, we don't understand. Patient will tell, I will apply ice and sit at home, but they'll apply ice and but the long-term joint damage is going to happen in these patients. So whatever the treatment we are giving, episodic therapy is worse for the joints. The patient joint damage, radiological score and functional score is going to worsen. So this is how it happens, actually. You can see hemophilia, acute bleeding, chronic synovitis, early arthritis, and the chronic end-stage arthritis happens in these patients. So how can we prevent this? That is called as prophylactic therapy or regular replacement therapy. You see, keep on replacing the factor, even if the patient don't have a bleed. That is called as regular replacement therapy. So this is World Hemophilia 2023 theme is access for prevention of bleed. So we have to prevent the bleeding. That is the aim of our treatment in the hemophilia patients. So what is the principle? Initial slide I showed you about severe hemophilia patients and moderate hemophilia patient. Moderate hemophilia patient bleeds occasionally, spontaneously. So when you raise the factor level from less than 1% to more than 1%, the bleeding becomes less. Spontaneous bleeding is less. So that's what the principle of prophylaxis is, converting a severe hemophilia to moderate and a mild hemophilia. So the spontaneous bleeding is prevented and joint damage is reduced in these patients. So every time I talk about prophylaxis, they wonder, what do you mean by that? It is nothing but factor concentrate we have to give. It's given regularly about 2 to 3 times per week and 10 to 40 units per kg. We usually in our country, we give something called low dose factor prophylaxis. 10 units per kg twice a week give them and continuously we give them, and we in between we test for inhibitor. That is called as regular replacement therapy. So there are multiple new definitions for, initially we only talk about preventing the bleeding, but now new definition is hemophilic should live a normal life. It's comparable to non-hemophilic patient. That is a new definition of prophylactic therapy in hemophilia patients. Depending on when you start, if you start in a pediatric patient, it's called as primary. If you start in an adult patient, it's called tertiary prophylaxis because joint is already damaged in this patient. But see, in our country, only 9% patients on prophylaxis. So that is the status, means hardly anybody is on prophylaxis in these patients. So again, I mentioned different intensity of prophylaxis. You can give small dose or high dose can be given prophylaxis in these patients. This is from a Chinese study which is shown when the patients on episodic therapy, they had so much of bleeding. When they get prophylaxis, the bleed is drastically reduced. So that is the principle of giving prophylaxis. And again, school. Nobody concentrates on hemophilia. They don't go to school many times because of the bleed. So when you give low dose prophylaxis, you can see the patient, the school absenteeism also reduced. See, we don't concentrate. We have hemophilic patients who are doing MBBS, MD pediatrics. We have a resident who was an MD pediatrics, and there are at least 6 students who is doing MBBS in different colleges in Mumbai because of the better treatment options are available to them. Actually, so you can now. Initially, they were hardly educated. Now they were all depending on their parents. So now many hemophilics are getting educated because the better treatment options are available to them. And this is again, it shows the prophylaxis is better than the episodic therapy. And we should see what is the outcome. When you give treatment, whether the patient is bleeding or not, that you can keep an assessment, you can keep data, you can keep in your center to see that whether treatment is working or not. So in our hospital, we also sometimes give home therapy where the parents are taught to give injections. So major issues for starting prophylaxis is lack of awareness among the physicians. Many times, physicians are against to give prophylaxis, and next to patients are also sometimes they're scared of inhibitor development. So you should always counsel. Inhibitor development is less in prophylaxis compared to the on-demand therapy. Compliance, fear of inhibitors, sustainability of the programs, all the problems we face with the prophylactic therapy. So just to go through, how did we start prophylaxis in our hospital is, initially, we started counseling the patient in hemophilia, World Hemophilia Day celebration. And we called my parents to come for the meeting. Only about 10 or 15 parents came for the meeting. That when we counsel multiple, it's in 2015, we started counseling the parents regarding prophylaxis. And we started, again, we taught, resident taught about which IV line to use, which is not to use. Importance of physiotherapy was taught to them. And the nurse taught them regarding how to give injections. All the parents learning dilution of injections was taught actually. And this all the booklets we distributed to them to learn about hemophilia in Hindi, Marathi, and English. So this is what is done. And you can see these are some of the gadgets we have used to teach them IV injection to our hemophilic patients. You can see the parents learning, no? So this is actually, they're all giving the IV injection. They're all well trained now to give IV injections to their parents. So that is the quality of life they can get it. Whenever the patient is at home, they can get the factor injections. So that is the self-infusion program can be trained, and this is a record. As soon as the patient gets injection, they will send a message to us that the patient has been given successfully without any problems. So they should not waste the injection also. So that can also be done. And disposables, no, they cannot waste, they cannot dispose the biomedical waste at home. So they have to get back to the hospital when they use after a month's stock of factors, and they have to get back to the hospital to the nurse, and nurse will dispose the factors. And about after a year of first meeting, you can see how many patients has come, because the sheer importance and the betterment of the patients was not bleeding, and many parents wanted to start the prophylaxis. In the next meeting, we had a lot of parents who are attending the meeting for the learning regarding the prophylaxis. So that is how education is very important, and then we can increase the prophylactic in our patients. Words about inhibitors. When patient comes with knee hematorosis, patient, you keep on giving the factors, patient is not responding. That's where you test for inhibitors. We have an entire lecture on inhibitors. So what is inhibitors and all? Inhibitors is nothing but an antibodies against there are allo antibodies. Factor 8 is not there in these patients. There are allo antibodies against the factor 8 or the factor 9. And it neutralizes the factor 8, whatever you are giving. So that is what inhibitors is. So these are all the times you should test for inhibitors. After initial exposure, before surgery, every patient should be tested before, even for dental extraction, you have to test for inhibitors. But if you don't test for inhibitors, do a dental extraction. You have to have a FEBA and over 7 to treat these patients. So always test for inhibitors before any procedure. This is the principle of treatment of hemophilia with inhibitors. And you can give hemophilia with inhibitors. You can give bypassing agents like FEBA or Novo 7 can be given. These two injections are not usually available in enough stocks in many of the hospitals. So it's important to test for inhibitors before you cut the tissue. So this is the concentration. This is the dose of FEBA which we recommended. 50 IU per kg is, but we usually don't give up so much of FEBA because the stock is always less. We give, depending on the type of bleed, we reduce the dose. The recommended dose of Novo 7 is 90 microgram per kg. Each milligram of Novo 7 costs 45,000 rupees. So think of the cost and then treat the patient actually. So it's very important to always think of the cost also. The other treatment option called is you tolerize the patient with immune tolerance induction therapy so that the patient will respond to factor 8. So you keep on giving the factor 8 to the patient and patient becomes inhibitor negative. So you continuously give them every alternate day for about years and 1 year or 1.5 years. That is how patient gets respond to the factor 8. This is the principle of immune tolerance induction. So this is actually I only talked about these things, which is factor 8 and factor 9. So a lot of new development has happened in hemophilia patients, extend of the factor, gene therapy, and there's something called as non-factor therapies. It's a monoclonal antibody which can give once a month. Thus, factor 8 half-life is 8 hours and monoclonal antibody half-life is 28 days. So that is a new advance in happening in hemophilia patients. So I will talk in the next lecture regarding this part of the treatment in hemophilia patients regarding newer advance in the management of hemophilia. So to conclude, acute bleed should be treated with adequate factor for optimum duration. You should, especially in patient with a life-threatening bleed like psoas bleed, intracranial bleed, should be treated optimally. Otherwise, patients will have a bad outcome. And prophylaxis is the only treatment which will change the natural history. At least some patients, you cannot start for all the patients you have in your center. Select about 5 patients and start them prophylaxis and show the results. And you can ask the government to give more factors. And you can start with other patients. So that's how prophylaxis can be started. And we always want the patient not to bleed. With the newer therapies like non-factor therapies, the patients usually don't bleed at all. For years and all, they don't bleed. So that's why we are moving towards the zero bleeding in hemophilia patients. And the prophylaxis should be started as early as possible. The one notion is they always ask the doubt. Can we start prophylaxis at 15 years? You can start prophylaxis whatever the age at least. So you can prevent the further joint damage can be prevented. It can be better to start early. But if you not start early, you can start in the later also. And prophylaxis also depends on the muscle. So you simultaneously continue physiotherapy. Physiotherapy factor treatment goes hand in hand. So the physiotherapy has to play a very important role in the management of hemophilia patients. So these are all our patients who is on prophylaxis. They all started in 2015. They're all grown up. So we don't even sometimes identify these patients. They are such a well-grown with us. You can see the joints. So I showed you in the initial pictures how the joints were actually fixed section deformity. You can see these kids, how they're folding, they jump from this wall and all. Sometimes they're so naughty, they don't know pain because they're on prophylaxis, they don't know pain. These patients never experience the pain of hemarthrosis. So that is the advantage of giving prophylaxis in these patients. Thank you.
I think it was an eye-opener for all of us. But I would like to highlight, ma'am, that this being a very costly therapy, like at least World Federation of Hemophilia should now aim at making factor 8 available at each district hospital, I feel. Because here in Nagpur, we have only at Lata Mangeshkar Hospital and at Daga Hospital, which are very far off. We have orthopedicians sitting here, we have other people sitting here. We know how difficult it is for us if we have such patient of hemophilia to get the factor. And as you said, FFP is not nowadays indicated. And I agree that FFP, the transfusion related infections and everything are the major risk. But availability of factor 8 and cost of factor 8 is the most inhibiting factor for any hemophilic to get factor 8. Access to factor 8 is very difficult.
Yeah.
And you're talking on prophylaxis. We don't get it for treatment. Where can we aim for prophylaxis?
Yeah, that's very, very important, madam, actually. So to consider the cost of hemophilic factors, initially when we started treating the patient, the factor 8, each unit costed 25 rupees. Each unit costed 25 rupees. Now the rate has come down to 6 rupees. It's a tender rate has come so low, actually, Plasma factor, recombinant factors, last time the lowest tender cost was 6 rupees, actually, That is one thing, the cost is much reduced because you're getting the newer therapies. And other one is MJPGY, Mahatma Jyotiba Phule. Actually, we have included all the treatments we have included now. In the new GR, we also included Hemlibra, we have included in that new GR. So it may go into roll out in next 1 or 2 months. So there the patient is going to be well covered, actually. You can admit the patient, start the treatment. And government of Maharashtra also has, last meeting you must have heard, each district will have a centers, hemophilia treatment centers. So they're going to give factors. So these are all the things which has happened recently in the last few months actually, so everybody will get factors. But you got other resources. You cannot depend on WFH because WFH is a temporary resource for the factor rate. So we have to ask the government. National Health Mission is the one which is going to support us. So you can ask the government to make it available, because if you have enough patients, you ask them, you're going to start a center. And simultaneously, you can have WFH, and MJPG is a very good resource to start factors. We, in our hospital also, we cannot give prophylaxis to everybody. The patient is from Nagpur. What we do is, we admit the patient for 2 days, get the factor, and we send the factor with them, because the patient has got a brain bleed. We give them prophylaxis for 3 months. So every month come and get admitted, get the factor, whatever they can get through MJPGY, and then we give them factor. So there are many resources which we can use for this management of these patients. You start with low dose. 10 units per kg is a very reasonable dose. You can start. So 10 kg patient, you combine 2 patients together, 250 IU. So that's how we started. We also, KM also troubles a lot. There are a lot of problems because number of patients is high, factor we get is less. But we started with 10 patients. We started with 10 patients. Now we got 70 patients on prophylaxis. So it's not going to happen one day. It's going to happen slowly. But there are resources which you can opt and use it for patients, better management. That can be done. Hemlibra is a very good resource. In the next lecture, I'm going to talk about that also. Thank you, madam.
Ma'am, could you highlight on desmopressin dose and IV dose?
IV
is available as per Dr. Anju. So if we can use that, so
actually IV is available, but it has to be used only in patients with moderate and mild hemophilia, and it can be used in patients with VWD who is only we can use on type 1 VWD patients, because type 3 anyway they have 0%. And what we have to is, we always have to test for it. See, if your patient comes with a bleed, if you don't know that patient will respond or not respond, you cannot do trial and error at the time of bleeding. So if the patient has already tested, some patient says usually the dose is 0.03 milligram per kg, and you give it, and after 24 hours you test the factor level, how much it's going to raise. And you cannot use it for more than 3 to 4 days, because tachyphylaxis is going to happen. So that's why you have to use only for a short time, especially in menorrhagia patient. Menorrhagia comes in the females coming with menorrhagia. At the time of menorrhagia, you can use it for a small few days. And mild bleeding, you can use for dental extraction. Mild hemophilia, dental extraction can be used. It's about 0.03 milligram per kg is the one which is dose recommended.
Thank you so much, ma'am. It was really enlightening for all of us.
Thank you. Thank you.
Thank you, Anjali ma'am. Thank you, Chandrakala ma'am. Now we will proceed to our inaugural. Today's topic of CME is hemophilia. Hemophilia is also known as the royal disease, as Queen Victoria of England was the carrier of the gene, which passed to several royal families.
The history of hemophilia has progressed from the time of little understanding and no effective treatment to great strides in understanding everything from genetics to how to protect bleeds by administering concentrated forms of clotting factors. In our quest to update our knowledge regarding major advances happening in hemophilia and many more therapeutic options being developed, this CME promises to be another remarkable platform for advancing knowledge and sharing insights in the field. The program has been designed to include diagnostic and clinical hemostasis aspects and multidisciplinary approach to the management of these conditions, including musculoskeletal and dental care. This CME has been organized in association with KEM, National Institute of Immunohematology, Mumbai, under the in-country training program by the World Federation of Hemophilia.
It is an honor for us to have galaxy of faculties. It is an honor to have with us Honorable Vice Dean Sir, Dr. Devsthale Sir, Medical Superintendent and Vice Dean Clinical, NKP Salve Institute and Medical Science and Lata Mangeshkar Hospital. I request Dr. Pradeep Hazare Sir to welcome Vice Dean Sir with a planter. So please come to the dais. Thank you, sir. I would like to invite another distinguished guest, Dr. Thombre Sir, Vice Dean Sir, Dr. Himanshu sir to welcome Vice Dean sir with a planter. Thank you, sir. We have another special guest with us, Dr. Usha Radke Madam, Dean VSPM Dental College. I request Dr. Anjali Madam to welcome Madam with a planter. We are delighted to have with us an esteemed. Thank you, ma'am. We are delighted to have with us an esteemed professional in the field of clinical hematology. She is further specialized with fellowship in leukemia and bone marrow transplant. Currently, she graces the position of professor in the Department of Clinical Hematology at SAIT GS Medical College and KM Hospital, Mumbai. I request Dr. Barik sir to welcome her with floral bouquet. Dr. Chandrakala ma'am.
Another distinguished faculty present today is Dr. Subhranshu Mohanty. He is professor and unit head in orthopedics at KEM Hospital, Mumbai, and he specializes in primary and revision total hip and knee joint replacement. I request Dr. Madhur Gupta ma'am to welcome him with a floral bouquet.
Thank you, ma'am. Please escort them to the dais. We are honored with us to have Dr. Bipin Kulkarni, who is scientist and Deputy Director Head, Department of Homeostasis and Thrombosis, ICMR, NIH Mumbai. He has several publications, textbook chapters, and award to his credits. I request Dr. Sabia ma'am to kindly give floral bouquet to the sir.
We have with us Dr. Nanda Pai, who is oral and maxillofacial surgeon, professor and head Department of Dentistry at KEM Hospital, Mumbai. I request Dr. Anju to please welcome her with a floral bouquet.
We also have with us Dr. Sheetal Pawar, Associate Professor and in charge Department of Nuclear Medicine at SAIT GS Medical College and KEM Mumbai. I request Dr. Ann ma'am to please welcome her with floral bouquet. नहीं है ये बनाना ये भी हम वर्चुअल है ये बनाना
I would also like to welcome Dr. Kirti ma'am with a floral bouquet. I request Dr. Himanshu sir to welcome her with a bouquet. Dr. Kirti Gargi ma'am.
Mrs. Kirti Mrs.
Oh, sorry.
We would also like to acknowledge presence of Dr. Tanuja Manohar Madam, HOD Medicine, Dr. Girish Nanoti, sir, HOD Pediatrics, Dr. Sabia Madam, HOD Pathology, Dr. Mankar, sir, HOD Orthopedics, Dr. Manisha Deshpande, Madam from Physiotherapy, Dr. Sanjay Deshmukh, sir, in charge of Hemophilia Day Care Center at Daga Hospital. Thank you all. And Dr. Devashish, sir, also.
ये वाला
Two of our faculties will be joining online. So I acknowledge the presence of Dr. Rucha Patil. She is a scientist at Department of Thrombosis and Hemostasis, ICMR, NIH, and Dr. Kirti Patil. She will also be joining online. She is occupational therapist working with Comprehensive Care Center for Hemophilia at KEM Mumbai. I also acknowledge the presence of Dr. Madhur Gupta ma'am. Now we'll begin with the traditional Samay lighting ceremony. So the Samay lighting ceremony is a tribute to Mother Saraswati, the goddess of knowledge.
Shubham Karoti Kalyanam, Arogya Dhan Sampada, Shatru Buddhi Vinashaya, Deep Jyoti Namastute. This means I bow down to the light of the lamp that does good, welfare, maintains health and wealth, and destroys negative thoughts. With this noble saying, I take the privilege of requesting our Honorable Vice Dean Sir to come forward and other dignitaries and begin the ceremony of lightning of Samay.
Yes.
Thank you, everyone. A big round of applause for our distinguished guest today. Now I'd request Vice Dean Sir, Dr. Thomre Sir, to address this august gathering.
Secretary Hemophilia, Nagpur branch, Dean Dr. Radke Madam, eminent speaker, and dear friends. I really congratulate all the participating departments for organizing this important CME on a really a topic which everybody is concerned because of so many reasons. Here also, this will help us or boost us to get the patients from this area so that the patients will be benefited with this. I again congratulate all those who have organized this and I wish a grand success to this CME. Thank you.
May I request Dr. Devasthale sir to address the gathering?
Dignitaries on the dais, Honorable Dean Radke Madam, Vice Dean Thomre Sir, the distinguished faculties for today's academic event from CME Hospital, and my dear friends. Let me first congratulate the Department of Pediatrics, the Hemophilia Society of Nagpur, especially under the presidency of Ayushi Madam, and Secretary Anju, who is taking a lot of efforts for this event, and everyone to for arranging this particular academic event in our institute. As you know, hemophilia is basically a bleeding disorder with deficiency of the clotting factors, and because of that, the patient gets bleeding at various sites. And one of the sites, I being an ENT surgeon, we face the patients having epistaxis. So for that, we need to evaluate the patient. And I'm told that the diagnostic tests for these particular conditions, they are costly. Also, the treatment is costly. You need to supplement the clotting factor. So patient has to wander everywhere for the treatment. So I just wanted to highlight, because as there are distinguished faculties are there from KEM, and I was told that KEM is the nodal center for this society. So I want that this particular hospital, Lata Mangeshkar Hospital, which has got all the facilities available. So you can say our hospital is a kingdom of Central India. We don't compare ourselves with your institute, but definitely it's one of the best medical college in the Central India. So I want that for the people in the Vidarbha region, or we are training also the patients from MP and Chhattisgarh. So this can become a nodal center. So we want you to recommend our name to the World Federation so that we get the patients. The patients are benefited. They don't have to go to Mumbai every time. So it is my request that you pursue our case in front of World Federation. As far as this particular condition is concerned, I was told that many of the cases are under MJBJY scheme also. And for your information, a day before yesterday only, we got the best performing hospital award. It's a private hospital award by MJBJY. It is a government declared award and it was given to us by Divisional Commissioner of Nagpur. So amongst almost 40 plus hospitals, private hospitals in Nagpur, we got the first award, first hospital award as far as MJBJY patients are concerned. So we have got, in short, what I want to tell is we have got all the facilities. So we can be a nodal center and we have got all the good faculties with us so they can be utilized. Thank you. Thank you very much.
Thank you, sir. Now I request Dr. Usha Radke, ma'am, Vice Dean, BSPM Dental College, to say a few words.
Good morning. Vice Dean Dr. Devasthale, Dr. Kumbre sir, all eminent speakers, those who have come from, I think, CME Hospital, Mumbai, and one of the speakers is the oral surgeon, I think, or visual surgery, and all participants, delegates, Dr. Anju, secretary of this association. And really, I welcome you all in this rainy season and in VSPM Dental College Pride Hall. This is the hall belongs to the VSPM Dental College, which is now named as the Ranjit Deshmukh Dental College. And it is a matter of pride that this workshop has been organized in our hall. As rightly said by Dr. Devasthale, hemophilia is a disorder, blood dyscrasia, and as far as the dentist is concerned, it's very difficult to manage the extraction or any treatment in the dentistry for the hemophilic patient. I think there is one lecture on the dental management of the hemophilic patient, so it will be helpful for our participants also. PGs are also coming for that lecture. And Dr. Anju told me that more than 500 patients are registered with this association in Nagpur and 50% are children. So if we can do any research with the association, with the dental college, so we welcome you and we will be sending some research topics or some short-term projects to the Hemophilic Society so that it can be a joint endeavor. So once again, I congratulate Department of Pediatrics, Association of Hemophilia, and the Commissioner Hospital for organizing this workshop on a very important topic. Thanks a lot.
Thank you so much. Thank you so much, ma'am. We would like to invite Mr. Saurabh Nalamwar, Regional Council Secretary and Youth Representative of West Region Hemophilia Federation, India, for his opening remark.
So very delightful, happy morning, everyone. Myself, Saurabh Nalamwar. I'm representing Hemophilia Federation India. So Dean Sir, Vice Dean Ma'am, respected Dr. Devasthale Sir, and also all the respected guest speakers who are with us today, and all the esteemed doctors, students, and healthcare providers. It's a grand welcome to you all. Today, as we gather here for the WFH HFI in-country training project, CME workshop, and tomorrow there will be a laboratory workshop also. So I'm filled with the gratitude and inspiration. Thank you for showing interest and joining us. So there are two IHTCs in India. IHTCs mean International Hemophilia Treatment Centers. So those are KEM and CMC Vellore. And right now we have Twent, Nagpur, hospital with the KEM. Okay, so the Lata Mangeshkar Hospital technically twinned with the KEM Hospital, and for that I really thankful to the Dr. Kajal Mitra sir, Dr. Ayushi Deshmukh ma'am, and Dr. Anju Mehrotra ma'am for putting time and efforts to manage all these twinning activities and putting themselves in front of everyone. So thank you so much for the lovely collaboration with the government organization and private organization. That's a wonderfully, beautifully conducted. So all the communication and knowledge sharing is happening all the way, and I'm really graced to be at this event. So about the HFI, Hemophilia Federation India, is our slides up? Achha. So until our slides get up, I would like to give a brief introduction about what is HFI, Hemophilia Federation India, and what we do. So we founded in 1983, just like 40 years back. And we are the only national umbrella organization working tirelessly for the welfare of people with the hemophilia, also abbreviation called PWH, person with hemophilia. So right now across country, we are having 92 chapters distributed in 4 regions, and our reach is both extensive and effective. Our founder is late Mr. Ashok Bahadur Verma. So he was himself a hemophilic. Once he had a non-treatable knee surgery to be done in India, which was not actually possible. So unko pata chala ki there is some place in Italy where hemophilia treatment can be done, and he went there. It was 50 years back. उन्होंने वहां पे देखा कि क्या एग्जाम्पलरी हीमोफिलिया ट्रीटमेंट अवेलेबल है, काउंसलिंग हो रहा है, फिजियोथेरेपी हो रहा है. सो व्हाई दैट कैन नॉट हैपन इन इंडिया? And that ignited him from inside, and एक vision उन्होंने लिया कि let's do it in India. और वो जब वापस आए ठीक होके, they started with the Hemophilia Federation in 1983. So our only vision is that every hemophilic in India, regardless of their socio-economic background, they deserve the proper treatment. And at HFI, we have another 2 visions, which are one country, one treatment. It is our dream that every hemophiliac in India has access to the equal treatment. And we envision a future of hemophilia without disability, where children are free from agony. And we have seen in the past, it's a future where every hemophilic child is happy, healthy, and unburdened by the painful legacy of this condition. So that's our vision. Over the years, our efforts have been multidimensional, from the identification of PWDs to affordable treatment. We have made stride in every domain. Our endeavors range from providing clotting factors, conducting training program like this we are sitting right now, and also doing the psychosocial care, economic rehabilitation. Okay. So this is our founder, late Mr. Shri Ashok Bahadur Verma sir, what I was talking about. So yeah, moreover, we are playing an active role with government for hemophilia policy making. Also, we are trying to get hemophilia disability included in RPWD Act, so more benefits can come in, and awareness campaigns we are doing to show, this shows the unwavering commitment to the hemophilia community. Recently, sir talked about getting 36 districts equipped with the hemophilia care. Like we did the advocacy with MLM Umatai Khapre ma'am, and she raised a question in Rajya Sabha. So there, Mr. Tanaji Sawant, who is health minister right now for the Maharashtra, he replied that we are totally aware of what's happening, and we are really want to improve hemophilia care, increase the number of treatment centers, and they are committed for that. So this is how we are conducting our advocacy activities within India. So hemophilia is just more than the, sorry. So hemophilia is more than just a bleeding disorder. Okay. So it's an iceberg effect. While bleeding might be a tip, underlying pain, mobility issues, depression, and social anxiety, which encompass the larger portion of the challenges faced by the hemophiliacs. So with the leadership of Dr. Bipin Kulkarni sir, we are having today with us, with the ICMR scientist team of ICMR scientists. World's first made in India Indian hemophilia testing kit was launched in a grand program by the Ministry of Health. So thank you so much to their relentless work and the support of ICMR scientists. Diagnosis is becoming super easy, quicker, affordable, and widely accessible. So technology develop करना एक अलग बात होती है. West में कई सारी countries, developed countries ये बनाती रहती है. But making it affordable and accessible to everyone, ये जो काम होता है ना, that is the main core of this medical care. और ये हम हमारे इंडियन साइंटिस्ट कर रहे हैं, and really appreciate and huge round of applause to them. So these are the problems. I will just skip this. So this is something interesting. Hemophilia Federation come up. Harnessing the power of technology, we introduced a WhatsApp helpline. Okay, so crafted with the advanced AI. I was the project in charge for this. I was the lead in charge, and I developed this entire software. Actually, no human is involved. This is a chatbot, and this is a beacon of hope in emergencies, a guide to self-care and educational tool for everyone. So it can pinpoint the nearest hemophilia hospital whenever the PWH is in need. So suppose कोई PWH travel कर रहा है, कोई दिल्ली गया है या फिर मुंबई गया है और उसे पता नहीं है कि यहाँ पे मुझे कहाँ जाना है. So he simply have to go to this chatbot and say कि मैं यहाँ पे हूँ, मुंबई में हूँ, मुझे nearest hospital बताइए. So chatbot will look into the database and simply send where this exactly with the Google Map location and address, available timings, and a whole lot of information is there. Even it can calculate the factor doses. आप अगर इसमें weight डालो तो इसमें आपको factor dose मिलता है, which is a suggestion. आप इसको एक ओवरव्यू के लिए या लेआउट की तरह यूज कर सकते हो, बट नॉट डॉक्टर्स एडवाइस. So we have right now 27,000 hemophilics registered in our national hemophilia registry. And we day-to-day basis, we share whenever required the stats with the government. And it plays a crucial part when we have to procure the medicines, right? So it's really important that we should gather these undiagnosed patients. And for that, I need your help. So how can you help us? So to these all dedicated doctors we are having today, I urge you, please guide hemophilics to our local nearest chapters. That way we can add them into the NHR, and together let's weave a network of care and understanding and support. So I would like to conclude here. Our journey of 40 years, the HFI Hemophilia Federation India, has been a profound, filled with challenges and innovation and countless success and so less failures. But there are more to achieve and more parts to carve. Together we can create future for hemophilia, which does not dictate a life, but is a chapter in a grander story of triumph and resilience. Thank you for being a part of this journey where we will create a better future for everyone. Thank you so much.
Thank you, Mr. Saurabh Nalamwar. Before we begin, we would like to inform that the venue of lab workshop tomorrow is at IMA Annex. Now the lecture is on orthopedic problems in patients with hemophilia by Dr. S.S. Mohanty sir. And I invite Dr. Debashish Barik sir and Dr. Joshi sir to be the chairperson for this session. Mic. So, Shubham mic.
Good morning, Dr. Mohanty.
Good morning.
Welcome to our institute, and we can see a lot of distinguished speakers from KEM here. We also have a good bond with KEM. I am pursuing my FEMER fellowship from the FEMER Institute at KEM, and
three of our senior staff members from here have also done the FEMA fellowship from KEM. I have heard your talks on management of orthopedic complications in hemophilia long back when I was a student myself. So it'll be a good, refreshing talk again for me. So we welcome you again and please start your talk.
Thank you. I'll just share my screen. Can you just allow me to share the screen? Okay. So, good morning to all. It's a pleasure and honor to be here to talk about orthopedic manifestations of hemophilia. And I'm really grateful to ICMR, IAH, and hemophilia chapter of Nagpur chapter for inviting me here. Now, it is always there is some reluctance by orthopedic surgeons to treat a hemophiliacs. And this same reluctance was there in way back in 1998 when he started treating hemophilia patients. But as we grew on and we gained more and more confidence how to manage these patients. And so we have learned all this management by the process of evolution rather than a process of revolution. So gradually, once you start developing in the knack of managing hemophilia patients, then you will know your way out that how to handle the problems associated with hemophilia and try to manage it. And at the end of it, when you see the follow-ups, then you will enjoy that and you will develop a passion for treating hemophiliacs. Friends, already, Dr. Chandrakala has told you the problem of hemophilia. But remember, India has got second highest hemophilia A patients globally, if you see, country-wise. And considering the prevalence of hemophilia 1 in 10,000 live birth, and considering the current birth rate of 34.5 per thousand, approximately 3,000 new hemophilia cases are added each year to our existing 50,000 cases. This is 2014 literature. And that time in 2014, only 11,586 cases have been registered by the Hemophilia Federation. But recent data I got from Prem Alva, president of HFI, that right now 28,080 patients has been registered by HFI. But we do not have a national policy for prevention and control of genetic disorders. That is where the problem lies. And that is why, what Saurav was telling you, that we are trying through the politicians, at least the hemophilia care should be comprehensive and treatment for all, and prevention of hemophilia is important. Now, how orthopedic surgeons are involved? The problem is 80% of the PWS develop bleeding into the joints, what is known as hemarthrosis. And usually the larger joints like knee, ankle, elbow, and shoulder, they are affected in that particular order. Knee joint is the commonest joint, and spontaneous bleed develops in severe hemophiliacs where the factor level is less than 1%, and in moderate and mild hemophiliacs, it usually follows a traumatic episode. So the role of orthopedic surgeon lies, first I'll just cover up superficially, like in each part I'll show one example on what we have done. So first thing is acute hemarthrosis. When a patient comes with acute bleed, of course the hematologist gives the factor correction, but whether to aspirate this joint, that is a confusion among orthopedic surgeons, because if you aspirate, then that may lead to further bleeding and prevent the tamponade effect associated, so that further bleeding is prevented. But on the other hand, contrary to this, the rehabilitation gets delayed and joint becomes stiff, and restoration of function also gets delayed. So what we did a prospective randomized control trial where we took two groups of patients, 60 patients we gave only anti-hemophilic factor, rest, elevation, ice compression and tranexamic acid orally, and group B patient we aspirated once only after giving the factor correction, followed by of course the ice application, rest, elevation, tranexamic acid, and started in earlier mobilization. And there was significant improvement in the VAS and all the hemophilia joint associated scores. And hence, right now the norm is if factor is available, then you just give a factor cover and aspirate the joint so that rehabilitation becomes earlier. What Dr. Chandakala told you that police, optimal loading and mobilization of the joint. We published it also in Indian Journal of Orthopedics about these findings. Next important thing is the fractures. Most of the patients they present with fracture or dislocation of the joint, and the difficulty is that again the factor correction is required. So we try to conjure, if possible, with a plaster cast like this, manipulate and give and the plaster. But sometimes in plaster also the fracture gets displayed and requires internal fixation. The problem is that here the bones are very narrow and very osteoporotic. Hence, you have to be extremely careful while fixing this fracture with some kind of nail or plate, and nailing is preferable. This nailing has been done in this fracture tibia. But you don't see that fracture alone. These patients are associated with other deformities also. For example, this particular patient in the opposite limb has got a equinus deformity, and we tried to correct that deformity and give the sutures, but unfortunately the patient didn't agree. But at least you suggest from your side that these contractures or deformities can be corrected, so that will prevent the further episodes of joint bleeds and further episodes of arthritis into the joint. We have written a chapter on this, how to manage fractures in hemophiliacs, in a book which was edited by Tariq Sohail from Pakistan, and one can go through it in further detail how to manage fractures. The third thing which comes is a hemophilic synovitis. Now this is, I will describe a little bit more about this because most of the patients they present with synovitis. How synovitis develops after an episode of acute hemarthrosis or bleeding into the joint that leads to diffuse hematoma in the joint, and that hematoma induces an inflammatory response in the joint, and due to that there is a proliferation of the blood vessels, and because of proliferation of blood vessels there is recurrent hemarthrosis or bleeding into the joint, and because of recurrent hemarthrosis the hemosiderin particles gets deposited in the joint, and that induces an intense subsynovial inflammatory reaction, and that reaction leads to a hypertrophy of the synovium. Again, this hypertrophic synovium gets crossed between bony ends during the movements, and further episodes again bleeding continues, and hence this vicious circle continues in a persons with hemophilia. And because of recurrent hemarthrosis, there is a release of an enzyme called metalloproteinase, which is very detrimental for the cartilage, and that causes erosion of the cartilage. And because of the inflammatory response, there is reflex muscle spasm or atrophy of the muscles. And because of erosion of the cartilage and muscle atrophy, that leads to a condition what is known as hemophilic arthropathy. And hence, the hemophilic arthropathy is a point of no return. Once cartilage is destroyed, then you cannot go back to normal. And hence, to prevent the hemophilic arthropathy, one has to treat these patients with the level of chronic synovitis level so that they can go back at least to a normal joint function. And hence, you have to do synovectomy. You have to take out those hypertrophic synovium. Initially, patient tried with conventional surgery by putting incision, but that led to a lot of joint stiffness and a lot of factor correction. So people tried with arthroscopy, but arthroscopy doesn't take out completely the entire synovium. The posterolateral, posteromedial corners of the joint is not addressed. So what most of us will do now, either a radioactive synovectomy or a chemical synovectomy. Hence, the term is known as synoviothesis. The process of injecting into a joint known as synoviothesis or chemical synovectomy. Initially, people tried with corticosteroids, but there was no long-lasting efficacy. Osmic acid was very effective, but it was painful and it caused cartilage damage. Hence, nowadays people are doing with rifampicin and oxytetracycline. It is very effective and long-lasting. Why rifampicin or oxytetracycline? Because of proteolytic and antifibrinolytic activities causes synovial sclerosis and fibrosis of the synovium. So it prevents further episodes of bleeding, or at least it controls the bleeding inside the joint. The advantage that anti-hemophilic factor coverage is very less. There is no drawbacks of surgery, and it's a simple OPD procedure and very much cost effective. The disadvantage is that its availability. So rifampicin we used to get earlier, but nowadays it's not available. It is not approved by the Drug Controller General of India, though the tablets are plenty available, but injectable form is not available. So we tried with oxytetracycline, but oxytetracycline injection is also, it is very cheap injection. One vial costs only 18 rupees. It is manufactured by Sarawai Chemicals, but nowadays also we are not getting oxytetracycline. Only some chemist in Nasik that has a stock of oxytetracycline. So whoever wants oxytetracycline, I just refer to that, chemist in Nasik. So they get it and we inject oxytetracycline. The literature shows that these injections were effective only in hemophiliacs in about 70 to 90% of patients, but it showed poor results in rheumatoids and other rheumatological conditions. But there are no objective assessment to prove its efficacy. So we did a study way back in 98-99 that we did the X-ray, followed the Patterson criteria, did the RBC level bone scan using the nuclear medicine department, and studied the synovial circulation, ultrasonography to see the synovial thickness, and also an MRI to measure the synovial thickness. And 20% factor correction before each injection, then joint is aspirated, rifampicin about 300 milligram injected into bigger joints like knee and shoulder, and 150 milligram into smaller joints like elbow and ankle, followed by a cold therapy for about 20 minutes, then followed by factor correction, then cold therapy, then give compression pads, and followed by rehabilitation by our occupational therapy department. Those who have developed this special kind of splints which they have manufactured, which is helpful for hemophilia patients. The procedure is repeated weekly for 6 weeks. That means 6 injections are required, and we followed up the patient in due course. The criteria for evaluation of the joint caviglia criteria: excellent when there is no hemarthrosis, no pain; good when pain persisted; and poor when both pain and hemarthrosis persisted. This is a patient grade 2 synovitis or persistent synovitis. This is after injection, complete range of movement and completely went back to normalcy. Ultrasonography showed the reduction in the thickness of the synovium. Pre-injection and post-injection film shows that the reduction in the uptake of the this bone scan, and MRI showed that there is a reduction in the thickness of the synovium as well. There are some joints which are deformed. They also improved with these injections. So this is after, before injection and after injection. RBC bone scan showed the decreased uptake, and also MRI showed decreased thickness of the synovium. There are some patients who had got persistent effects. This is a patient who had got MRI in 1999, then 2000. This in 2002, it still showed the further reduction in the thickness of the synovium. So probably there is some persistent effect in this kind of patients. In 2002, we presented in the World Orthopedic Congress, and it was the best paper of the conference during that time. Nowadays, we are using radioactive synovectomy. Dr. Swetal is here. She will tell you in detail about this. We are injecting yttrium-90 to bigger joints and lutetium-177 into elbow and wrist. We are procuring this material from BRIC in Mumbai, and with a very less cost, we are able to do this. This is a patient, 27 years, severe hemophilia A. And this is the process of injection where it has to be done under specialized conditions inside the nuclear medicine department. And this is using 3-way cannula. This is the radioactive material being injected into the joint, then flushed with a normal saline, and then sealed it. So then give a pressure bandage. Then we check it with the camera, radioactive camera, to see that the distribution is proper all throughout the joint. And these are initial 65 patients. Average age is 24 years. We saw that a significant reduction in the joint bleeds in 3 and 6 months follow-up, very short follow-up. But a reduction in the thickness of the synovium has not been very significant. Though there is significant improvement in the joint scores like hemophilia joint health score, VAS scores, and FACE scores. And definitely it helps in improving the quality of life in persons with hemophilia. 2 patients had developed a skin necrosis in the ankle joint. We admitted them, then subsequently dressing was done and completely healed after that. So one has to be very careful that there should not be an extravasation causing skin necrosis. We have published about synovitis and synovectomy in Hemophilia Journal along with other international authors. So one can go through it in detail if you want. And there is a chapter written on rifampicin synovitis with a book which was published by European authors on rifampicin synovitis in the ankle joint. Next important condition comes hemophilic contractures. As you know, in 30% of hemophilia, there is muscle bleeding. Usually the bulkier muscles like iliopsoas, gastrocnemius, quadriceps, forearm plexus, these are, they get the bleeds. There may be subcutaneous bruising or periarticular bleeding. If there is a intra-compartmental bleed inside the compartment, that leads to increased compartment pressure. There is neurovascular compression, necrosis and fibrosis of the muscles that leads to contractures. But if the bleeding develops inside the substance of the muscles, then there is no nerve compression. There is a massive hematoma which doesn't get absorbed completely, and there is subsequently it is walled up by the fibrosis, what is known as pseudocyst or a pseudotumor formation. So initially we try with non-surgical treatment by repeated passive stretching, give continuous traction, sometimes manipulation or general anesthesia, or we use some kind of splints to gradually correct it, or manipulate it under anesthesia, or what we do serial cast correction. And if there is no improvement, surgery is indicated. For example, this is a patient who has got a contracture both hip and knee joints, and under anesthesia it was tested that hip joint is actually free. When you took the patient to the edge of the bed, only knee joint contracture was there. So we percutaneously released the gastrocnemius tendons and then did a serial cast correction and could make him stand with some kind of splint which was given by occupational therapy department. So initially 10 degrees is compatible for walking, 15 to 20 degree non-surgical treatment is tried. In severe cases, you require a supracondylar osteotomy in order to make them straight and then give continuous traction. We have published it, the management of arthropfibrosis in hemophilic arthropathy along with other international authors in Journal of Hemophilia also. Next important condition comes hemophilic pseudotumor. There was no classification how to treat these pseudotumors properly beforehand. We first developed a classification and presented in the World Federation of Hemophilia in 2010, and that is now worldwide accepted classification. Type 1, when there are small bones of the hand and feet are affected, where you just require aspiration under factor cover and inject a fibrin glue or inject a rifampicin into the joint and give factor cover for about 25% for about 4 to 6 weeks, and subsequently it heals. The next group, where the pseudotumor is only confined to soft tissues and bone is not involved, they are only excised the pseudotumor, that is 10-year follow-up of this patient, that no further development of pseudotumor and restoration of the complete function for this patient. The third group, where there is a bone erosion and because of the pressure effect. So this is a patient who has got erosion of the bone because of pseudotumor. Always we take a MRI to see that how far the pseudotumor is extending. After excision, we put calcium sulfate pellets or stimulant, packed it inside the bone so that you can put bone grafts as well. Because if you put bone graft, then in hemophilia there will be another morbid site which may start bleeding. So prefer bone substitutes like stimulant, and that is 2 years follow-up of this patient. And we published it as a case report because we first used the bone substitutes in the pseudotumor in bone defects in hemophiliacs. Next is type 4, when there is imminent fracture or there is already a fracture because of pseudotumor, like this is a supracondylar fracture because of a huge pseudotumor there. So after excision, what we require with pack with the bone grafts and bone substitutes and some kind of internal fixation like plating is required. And that is a patient 9 months after the surgery, and that is a function of this patient after 9 months. And this is a next patient, a typical patient is a pseudotumor, 11 years old male. He presented with this because of lack of factor availability. It increased the pseudotumor and subsequently it was burst open on the foot. And it was suggested that to amputate this foot, but we tried to restore this foot because if you see the X-ray, there is no bone stock available there. But in children, always there is a periosteum which leads to bone growth. So what we did, along with this patient also had got both knee swelling and flexion deformity. There's a prochoroidum deformity with arthropathy. So what we did, we just took on the table under anesthesia, we took out all the evacuated the pseudotumor, and there were always a beautiful capsule which is there in the pseudotumor. You can just excise this capsule, very thick fibrosis capsule. So we couldn't save 2 toes, so we have to amputate 2 toes, and at least 3 toes we could retain. Then we did the closure. This patient post-operatively, they develop a lot of, wound problems. So we have to brace that wound, lot of swelling, and subsequently it heals. This is 7 months down the line. And as you can see here, because of persistent periosteum, all the bones could be seen in the X-ray. They are reforming there. And it could be mobilized with some kind of splint after correcting the knee contractures, of course, with a sutures and some kind of splint that this patient could be mobilized afterwards. And finally is a hemophilic arthritis. When there is a cartilage destruction, a point of no return. So you have to do a joint replacement surgery. This is a B, hemophilia B with a left hip arthritis, where he has got opposite knee arthritis also. So with bone grafting, we did a hip replacement surgery in this patient. This is another patient, 32 years young man with 120-degree flexion deformity, severe hemophilia less than 1%. He was walking with one leg, and because he was walking with one leg, he was putting more force pressure on the right leg, the other leg, and it was bleeding recurrently. So we planned a 3-stage procedure in this case. In the first stage, we did a percutaneous tendon release and did a serial cast correction. So we could achieve until about 80-degree of flexion deformity from 120-degree. Then we opened up the joint and did the knee replacement surgery using a specialized, constant type of implant. But there's a gross flexion extension mismatch and still 40-degree of flexion deformity after the knee replacement surgery. And gradually we did a serial cast correction after the knee replacement. And this is in February, April, and this is in June, and this is in September 2012. We could achieve a full correction of this leg, almost 120-degree to full correction. That's a 9-year follow-up of this patient. So the patient could walk with, his both limbs, and we got reasonably good range of movements also, almost about 100 to 110 degree of flexion in this patient. That is after almost a 9 months treatment in this patient. And this we also published as a case report in a Journal of Hemophilia that a 120 degree patient. The patient has got also HIV and tuberculosis, as well as the resistant tuberculosis, HIV and hepatitis C co-infection. So with multiple medical problems that could be achieved. On the other hand, besides stiff joint, you get a very unstable joint. This is a 42 years old male, factor VIII deficiency, severe hemophilia, both, mediolaterally as well as the anteroposterior instability. And we did a CT scan. This is how the lower end of the femur looks like a claw-like thing. Both epicondyles were intact. So we tried to do, joint replacement surgery. So in this patient, after taking the bone cuts, we used the constant type of implants and got a good range of motion in the table. And that is a patient who came with both the axillary crutches, both knee involvement and right hip involvement. So after replacing all the 3 joints, this is 4 year, 3 months follow-up of this patient, could be mobilized independently after all the 3 joints replacement. Of course, after about 7 to 9 years, I think after surgery, we lost this patient because of some medical problems and complications. This patient was from Madhya Pradesh. And finally, bilateral stage, single stage total replacement also we are doing. And this is a patient from Uttar Pradesh that we did both the knees together. That will consume less of factor when you do both the joints together. And that is a function of this patient after doing both the joint replacement surgery in hemophilia. Sometimes you require special type of prosthesis. This is a 28 years young man, supracannular fracture, severe hemophilia, neglected for almost 1 year with a gross instability. Almost whole of the lower femur is not there. So here we have to replace the lower end of the femur, completely. That is the lower end of replacement prosthesis. This is a post-operative, condition on the table has got a good range of movements. The problem with results are that in hemophilia, there's a high infection rate, 13% in HIV negative patients, and survival is also less compared to normal patient, about 77% at 10 years. I thank you for a patient hearing, and I thank the entire team of KM Hospital and Institute of Immunohematology, Dr. Manisha, Dr. Ghosh, Dr. Deepika Mohanty, Dr. Bipin is here, and Professor Chandrakala, Dr. Farah Jijina from Hematology, Dr. Shwetal and late Professor Tilo from Nuclear Medicine, and Professor Nanda Pai, who is here also, Dr. Mahadev Garade from General Surgery, Dr. Kirti Keni and Dr. Kale from Occupational Therapy, Dr. Patkar from MRI Department, Nanavati, and Dr. Devilas of Hemophilia Federation of India, Maharashtra chapter. I thank you for a patient hearing, and we all dance according to a tune of the hemophilia patient. Thank you,
sir. Thank you for very enlightening and illustrative talk. All your examples were case-based. Thank you. Though we have not operated too many cases of hemophilia, but yeah, they are very challenging.
But at least you can start
Yes,
injecting
yes.
the synovitis
Yes,
patients.
yes.
That is how we develop. Injection to a synovitis patients, and gradually when they come for follow-up, then you will see gradually you can do small contracture
Yes,
releases and
yes.
all these things. Of course, the factor has to be available.
Correct.
And Dr. Anju and team should provide
Yes,
adequate
we
factor
will.
so that we can get more and more confidence. And anytime I am available, of course,
Yes.
for anything, any help is needed.
Thank you. Thank you very much. Any
Yes, madam.
questions?
Yes.
Sir, excellently told, sir. You have explained you can do the acute expiration in the acute bleeding conditions. So we have the center in a government hospital. So can we do in the UAG guided by the medical officer, or you have to take the help of orthopedician only there?
I think it is better an orthopedic surgeon does the aspiration, because the medical officers first thing they don't maintain sterility. As an orthopedic surgeon, at least we are concerned with the sterility. We prepare the knee properly, then we aspirate and do it. And we do it in the theater only. We don't do it in the casualty and all. We take it to theater, emergency theater, and do it. And number two, as an orthopedic surgeon, sometimes the joints are not freely mobile. There may be some deformity. Suppose suprapatellar aspiration is not possible, then we can go for intrapatellar or parapatellar and aspirate the joint, which a medical officer doesn't know. So if he doesn't aspirate, then he may do multiple punctures and that may lead to further complications. So ideally, I would recommend the orthopedic surgeons should be available for aspiration.
Not recommended as per standard guidelines, should not do joint aspiration should not be.
Joint aspiration is not recommended for the actually standard of care unless you expect that compartment syndrome about to rupture. So otherwise, it's not the standard of care to the joint aspiration as of the WFH guidelines, and many standard guidelines mentions. This sir has done the study and we do it. Sir also don't do it regularly. Sir, you don't do it regularly.
Yeah,
actually.
regularly, because sometimes patient comes from awkward timings, and if we are not available, then we don't do.
Because remote settings, you are working in the rest of the hospital, KM hospital. So you have proven that aspiration has increased the decrease the morbidity. So that's one I asked
Early
question.
factor
If everything is available, early factor correction, if a therapist available to take care of the mobilization schedule afterwards, and one should follow up, not only aspiration, give a pressure bandage, next day again you take out that pressure bandage, and your therapist should take care of the mobilizing early with guarded, prognosis that one should do.
Preferably at 99% times you don't do aspirate, 1% of the patients you do the aspiration, but it's a very rare actually chance of doing an aspiration, because to do aspirate also post aspiration the patient should get proper hemostatic cover. If they don't have proper hemostatic cover, they bleed in the joints again.
Yeah.
So that has to be very, very careful. So treat with the factor concentrate. If the patient doesn't respond, test for inhibitors. If the patient is inhibitor negative, then only you try to aspirate. Otherwise, usually it's not recommended to aspirate the joints. Yes, sir.
Ma'am, what if we aspirate after correction?
Sir, again, you're putting some sort of procedure, no? So post procedure also, the patient is going to bleed in the joints. The factor is going to stay for about 8 hours. So post procedure also, unless you correct for about at least 2 to 3 days, they will bleed.
What happens is that temporary effect also prevents the bleeding.
Yeah.
What ma'am is telling, if factor is not available adequately, you just inject once. That's all. But after that, then some further bleeding develop. Then you don't have factor. Then it becomes a problem.
So I get the point, sir.
Yeah.
My concern as an orthopedic surgeon also is that a hematorosis is likely to get infected secondarily.
It's not going to happen. It's not going to infect it, because secondarily also they're all sterile actually, So if unless you're not poking the needle or infecting, it does not going to happen, because 80% of patients come with hematorosis. Every day we see about 20-30 patients of hematorosis. None of the joints get infected unless some surgery is done. Unless some surgery. As such, hematorosis, because the closed joint space, sterile space, it's not going to get infected. So just treat with the factor concentrate, and then it will take some time to resolve, maybe about 2 weeks to resolve. But if the patient doesn't respond to factor correction, then only you should do the aspiration. Otherwise, it should not be attempted. Thank you.
Thank you. Sir,
Yeah.
second question.
Yeah. Okay.
You can ask.
So it's regarding the chemical cyanovectomy that you've talked. So first thing is like oxytetracycline that you've already told. We get it often. We tried in 2 patients and worked wonderfully well. Third, sir, the rifampicin. So what is that molecule that you procure and from where you're getting the access of that rifampicin? That's one question. And second, following the chemical synovectomy part only, once we did with the pediatric orthopedician, Dr. Nimade. So, I mean, is it recommended to aspirate some amount of synovial fluid and then inject the amount of oxytetracycline? And how much of flush we give with that? With chemical one, not with the radioactive. So,
Okay. So regarding first question, rifampicin is not available in India. Number two, it is not recommended by Drug Controller General of India also. So when we did the study, we had to take special permission from them, from DCGI, and then only we did the things. So I used to carry rifampicin after going abroad. I used to carry from in my baggage, and then I used to inject. I procured somewhere from Vienna once a couple of vials, from UK also a couple of vials. And but right now it's not available, and I tried also to get it even with through the all the big pharmacies. They are not able to procure it. There is difficulty in that. There is some issues about procuring it. So we have forgotten also rifampicin. We are not getting it. But some patients, they have some relatives abroad. If they get it, then through their relatives, then we can inject it. That is the thing. Oxytetracycline, regarding the injection, yes, you have to aspirate the joint. Sometimes joint may not have any fluid, but if the joint is there is synovitis, there is fluid inside the joint, better to aspirate it. Because when you aspirate and then inject the oxytetracycline, it becomes less painful. Because the capsule is already distended and you are replacing the fluid which you have aspirated. That is number one. Number two, the drug which you are giving, if you don't aspirate, it gets diluted in the synovial fluid. So effect may be less. So if you aspirate it, at least the drug may not get diluted and it will have more effect on the joint. So try to aspirate it. If something coming out, take out whatever fluid is coming out, then you inject the oxytetracycline.
sir, how was your experience with elbow?
Yeah, we have done elbow also. We have done elbow, ankle, all the almost shoulder, every joint.
Sir,
Elbow also on posterolaterally we go through this, and then we aspirate, but we don't get much of fluid from those small joints. We just inject, but there we give less amount of fluid because in knees we give suppose 5 ml of oxytetracycline, knee and shoulder. Elbows we give 2.5 cc like that. Because if you give more, then the capsule gets distended and patient becomes very painful. Injection itself becomes painful. Thank you.
What about the union of fracture in hemophilia?
There's no literature suggesting that the union gets delayed in hemophiliacs because union it's just a blood factor is not there, but once you give factor and all, union should not be a problem. But as soon as the patient comes with a fracture, they give a factor correction, so at least blood should clot there, so that the process of union starts from there. Thank you for all the questions, and it's a pleasure again to be here.
Thank you, Mohante sir. May I request Dr. Barik sir to please hand over the memento to sir. Thank you. Thank you, Barik sir. Thank you, Joshi sir. Next one to me. Now moving forward to our next lecture, lab diagnosis of bleeding disorders by Dr. Bipin Kulkarni sir, and may I request Dr. Sabiha ma'am to chair this session. May I request Wilkinson ma'am also to join Sabiha ma'am for sharing the session.
Good afternoon, all. We are running behind schedule, but I guess the lectures are so informative and elaborate that I think we are all enjoying them and learning a lot from them. So our next one is on the lab diagnosis of hemophilia, and the speaker here is Dr. Bipin Kulkarni. He's Director, International Hemophilia Training Center, Mumbai. It is a board certified he's a board certified senior genetic counselor and elected member of National Academy of Medical Sciences. And he has, to his credit, a lot of many publications, 3 chapters in 3 textbooks, and has also won many awards. And right now he is a PhD guide in the University of Mumbai. So I ask him to please begin his talk.
Thank you, Madam, for the introduction. So till my slides are loading, it is an absolute delight to be here to interact with you all and share our experiences. So so this is the first in-country twinning program with the ICMR, National Institute of Immunohematology, KEM Hospital, with the Lata Mangeshkar Hospital. And I thank the World Federation of Hemophilia for making it possible. And I also thank Lata Mangeshkar Hospital for taking up this responsibility in this part of the country. Now, before this, two of the earlier speakers, Dr. Chandrakala and Dr. Mohanty, they have given a wonderful overview of what is hemophilia, followed by all the surgeries and orthopedic surgeries in hemophilia. I'll be talking mostly the laboratory part. So why it is important is like if you have seen the data which Dr. Chandrakala also kind of highlighted. So there is a big gap in the diagnosis of hemophilia in our country. So the projected number in the country is approximately 140,000 hemophilics we have. But under all the 91, 92 chapters of Hemophilia Federation of India, we have only about 28,000 of the patients registered. So there is a huge gap in the the number of patients yet to be diagnosed. So that is where the laboratories come into action. And that is what is missing in our country. So we need to have more specialized laboratories for the diagnosis of bleeding disorders, particularly hemophilia. And our goal is to encourage more and more centers to develop the diagnostic facilities for hemophilia. So if you are doing APDT, it's very easy to upgrade to doing factor assays, doing inhibitor screening, and then eventually the quantification of inhibitors. So I'll talk about all these aspects in my talk. So we are ready to go? Yeah. So the topic is labs in bleeding and coagulation. So now we all know what is hemophilia, but then as I know that we have a mixed audience here, I would just start with a brief introduction of what is hemophilia, or rather what are bleeding disorders, or how the physiology of coagulation works and where the problems can arise. So as we know that hemostasis is a delicate balance between bleeding and thrombosis. And what normalizes this balance is the major components are threefold. That is the vascular system, which is comprised of the endothelial cells, smooth muscles, and the connective tissues, which make up the blood vessels and the connective tissues. Then the cellular components, non-cellular components, that is the coagulation factors, as we know, the fibrinolytic system, and the serine protease inhibitors and the regulators. And the third component is the cellular component, that is the platelets, which bring about the primary hemostasis. So talking of hemophilia, before we come to hemophilia diagnosis, it is important to look into the platelet part as well, because hemophilia is deficiency of factor VIII, but then factor VIII deficiency can also be there in von Willebrand disease. Now, von Willebrand disease is something which is also related to platelet function. So that is why the platelet function and the coagulation always goes hand in hand. So particularly when you are dealing with a new patient with bleeding disorder who is not diagnosed, it is very important to look at it holistically. So we know the major components of hemostasis after a vascular injury is vasoconstriction, followed by the primary hemostasis, that is the platelet activation and the platelet plug formation. Then the coagulation proteins get activated, the coagulation factors get activated, and then we get the fibrin clot. And once we have the fibrin clot, which is stabilized by the factor 13, then we have our natural anticoagulant system that gets activated, which slows down further clot formation. And once the tissue is healed, the connective tissues are healed, the blood vessels are healed, the last step is the fibrinolysis. So whatever the clot is there in place, it gets dissolved and it gets excreted out of the system. So these are the major components of hemostasis. So let's just brush up and look at it one by one, and just looking at it one by one, we can also think about where the problems can arise. So this is the cross-sectional view of a blood vessel, which shows the endothelial layer and the subendothelial collagen. So when there is a breach in circulation, so what is the subendothelial collagen is exposed. So the first protein that adheres to the subendothelial collagen is the von Willebrand factor, shown here in the green peaks here. Now, when von Willebrand factor adheres to this subendothelial collagen, the platelets which are in the microcirculation, they will adhere to this the von Willebrand factor through the glycoprotein 1b9 complex. So on the surface of the platelets, there are several glycoprotein receptor complexes, and each one has a particular role to do in bringing about the primary hemostasis. So the role played by GP1b9 is to adhere to the von Willebrand factor. Then there are other receptors called the GP2b3A or glycoprotein 2b3A, which bind to fibrinogen, and to this fibrinogen, the cross-linking happens with other platelets which bind to this fibrinogen through their GP2b3A receptors. And this process is called the aggregation. So this is the agglutination, and this process is the aggregation. So altogether, this forms the primary hemostatic plug. So during this process, what happens is there are several sub-steps that happens. Once the platelets adhere to this von Willebrand factor, the platelets bring about shape change, and then the granular release. There are certain granules inside the platelets, the alpha granules and the dense granules. So the granules secrete their contents, and from there it brings about a kind of a permanent platelet activation. So if there is a defect in the granular release, that's a secretion defect. If there is a problem with the adhesion of the GP1b9 with the von Willebrand, that itself is another problem. So it could be a problem with the receptor itself, or it could be a problem with the protein ligand, that is the von Willebrand. So or the GP2b3A, if it is defective, that also becomes a platelet disorder, which we know as glandular thrombocythemia. Now coming to this secondary hemostasis. So once the platelet plug is formed, these platelets, they will secrete or externalize on their surface the negatively charged phosphatidylserines. So this phosphatidylserine, it will activate the intrinsic pathway or the contact factors. So what are the contact factors? The high molecular weight kininogen, prekallikrein, Fletcher factor,
then these contact factors, when they get activated, now all these coagulation factors, they are in a native conformation which are not active while in circulation. So once they are activated, the factor that is activated will activate the next one and the next one and the next one. That's why it's called the cascade pathway. Now, if you look at it, it is divided into, for the laboratory, ease of laboratory diagnosis, it is divided into the intrinsic pathway and the extrinsic pathway. So all the factors that you see here, right from the contact factors to factor 12 to 11 to 9, 8. So this all comes under the intrinsic. But if you look at here, this is factor 7, which is not in this line. So this falls under the extrinsic pathway. Now this is activated by the release of tissue factor. So once there is an injury, the endothelial cells, it will release the tissue factor, which will activate the factor 7. Factor 7 will activate factor 10. It will also activate factor 9 here. So factor 8 plays the role of a mediator. So if you, now everybody knows about probably emicizumab, the new drug. So what it does is it holds the activated factor 8 with one arm, and it holds the factor 10 with the other arm, so that we can see here how it does. So factor 8 is in between this. Now factor 8 is carried by von Willebrand factor. So factor 8 is very much related to von Willebrand factor. So without von Willebrand factor, the factor 8 will not be circulating in the blood. That's how it is important. It's very important to know this fact. So when you are diagnosing a factor 8 deficiency, it is at most important to also ascertain that the von Willebrand factor is normal. Otherwise, it becomes a different disorder altogether. So now this pathway from here, factor 10, 5, 2, and 1, this is in the both the pathways. So it is called the common pathway. So the factors that come in the common pathway are factors 10, 5, 2, and 1. Now, if you look at these factors which are highlighted in yellow, they require vitamin K, which is a dietary vitamin, for their maturation in the liver. So if there is a vitamin K deficiency, or if there is a liver disease, these liver dependent factors are deficient. So if you are dealing with a patient who has a liver disease, and then you are sent that his PT-APDT is deranged, you please do all the factors. So you need not necessarily do all the factors, because you can just look into 1 or 2 of the vitamin K dependent factors. If they are low, it's obviously it's because of the liver disease or the vitamin K deficiency. So it is not necessarily a coagulation factor defect, but it's arising because of these disorders. So this is kind of an overview. Now, once the prothrombin gets converted to thrombin, thrombin is a very potential coagulation factor. It is also involved not only in coagulation, but it is also involved in the feedback mechanisms of the coagulation cascade. So this thrombin will activate the fibrinogen, which will convert the fibrinogen to fibrin. And this fibrin clot is then stabilized. Now, again, this factor 13 is also activated by thrombin along with calcium chloride. This fibrin clot is stabilized by the last factor in the coagulation cascade, that is factor 13. Now, if you see this factor 13, it is neither there in the APDT pathway nor in the PT pathway, or the intrinsic pathway or the extrinsic pathway. So if there is a factor 13 deficiency, you don't get it by doing PT-APDT. That is the reason. So factor 13 comes at the very end, at the time of stabilizing this fibrin clot. So what it requires is a fibrin clot formation. So the test is also very simple. You make a fibrin clot, and then you see if factor 13 is present or not. We'll come to that test, how it is done. So before we go to the test, it is important to understand how the mechanisms work. Then it becomes very easy to understand how to go about. So the 4 steps in complete hemostasis investigation are a complete history. If you know the patient's history, the patient has a history of bleeding diathesis, you know that probably you are looking at a bleeding disorder. Then the physical examination, which to evaluate whether the bleeding is superficial bleeding, the mucosal bleeding, or if it's a deep muscle bleeding or joint bleed. So it will give you an idea whether it is a platelet kind of a disorder or it's a coagulation factor deficiency. Then when it comes to investigation, it is important to start with the basics first. So the complete blood count, as we saw that how the primary hemostasis is closely related to the secondary hemostasis. So the platelet function, before we go to the platelet function, it is important that the platelets are there in numbers. So the platelet, the complete blood count, including the platelet count, peripheral smear, and then comes the screening coagulation test, that is the PT-APDT. So it will give you an idea if there is anything underlying going on with the coagulation cascade. Then you come to the special test to define the precise nature of the defect. And the clinical approach, what the clinician should see is the bleeding significant, because many times we get a request for a complete coagulation profile, all the factors, because there is some minor bleeding, like a child comes with a nose picking habit and he gets frequent kind of little bit bleeding. So whether that bleeding is really significant, whether it should be investigated for the disorders, what is the BAT score if you have looked into that. So all these things should be looked into by the clinician before sending for specialized investigations, because the lab may not always necessarily have all the details of the patient. Many times only the sample would be sent to the lab without any clinical details. Now, whether the bleeding is local or systemic. So if it is a local bleeding, probably it is some local cause. If it's the underlying bleeding disorder, then the bleeding is generally systemic. It's not from one localized site. Then we saw the platelet versus coagulation disorder. So platelet bleeds, generally they manifest like mucosal bleeding, menorrhagia in women, and the coagulation factor disorder, you will get deep muscle bleeds and joint bleeds and so on and so forth. So, and whether it is an inheritor or an acquired disorder. So if you look at the history of the patient, bleeding history, if it's from the childhood, you know that probably you are looking at an inherited disorder, which is congenital. Now, all these details should be filled up in a clinical pro forma, along with the history and the family pedigree also. So if there are other family members which are affected, having similar bleeding manifestations, probably you are definitely looking at inherited bleeding disorder. Now, what all details should be there? When we spoke about the type of bleeding, and so the transfusion history is also important. Like if a patient is having a bleeding disorder and he has received some factor, and then that is not informed to the lab. After receiving the factor, the sample is sent to the lab. Lab will do the investigation. Everything will come normal or near normal. So if the lab doesn't have the information that this was a post-transfused sample, that time, and if that report is seen by a hematologist or a clinician a month or 2 months down the line, he will put the blame on the lab, that lab has given a wrong report that it's a normal sample. So the lab should always be kept informed about the transfusion status of the patient, if the patient has received anything. Paternal consanguinity is important to look into, particularly when it comes to autosomal disorders. If you are, if you suspect an autosomal disorder, you should look into the paternal consanguinity. Always draw a family pedigree. So if there are only males affected, or if it's a males and female, both are affected. So if it's only males affected, you know that probably you are looking into an X-linked recessive disorder, probably hemophilia. Or if it males and females both are affected, you probably it could be a von Willebrand disease or any other autosomal bleeding disorder. Response to treatment is important, because when you are suspecting an inhibitor development, if the patient is not responding well to the treatment, probably he has developed an inhibitor and you should be sending out for an inhibitor screening. Age of presentation, again, to ascertain whether it is a congenital or an acquired bleeding, which is recently acquired. Now, we saw the different components of hemostasis in the beginning. So it starts with the vascular formation, the vascular integrity. So if it is a problem of vascular integrity, generally it is not picked up by the coagulation laboratory, because it's not a problem of the blood per se. It is a problem of the vascular tissues, the connective tissues, the collagen disorder. So if you do all the screening coagulation platelet disorders, probably it's all normal. So the diagnosis is mostly clinical, and then you should probably send out for other investigations rather than doing hematological or the coagulation investigations. Disorders of platelets, it could be a problem of platelets, numbers and function. So first thing, as we saw, that you should be always starting with a CBC and a smear. Why smear? Because as we know, some of the disorders, the platelet morphology could be different. Like for example, if you are looking at the Bernard-Soulier syndrome, the GP1B9 receptor defect, generally they present with thrombocytopenia with giant platelets. Thrombocytopenia on the automated counter with giant platelets. So if you are seeing that kind of platelet morphology, probably you are looking at a Bernard-Soulier syndrome. So that way it helps to quickly come down to what investigations you should be sending to the lab. And the platelet, second is the defect of the platelet function. Now it could be acquired as well as congenital or congenital. So acquired could be because of the antiplatelet drugs. If the patient is on aspirin and it will abrogate the cyclooxygenase pathway, and obviously the platelet function will be suppressed. So, or if it's a congenital defect, then the history or the consanguinity and other things should point at a possible congenital defect. Now, we saw the primary hemostatic pathway. So there are different sub kind of areas of platelet activation and the primary the plug formation. So those are the areas like adhesion, secretion, and aggregation. So where the problems could be. Now, the problems of adhesion are like Bernard-Soulier syndrome. We saw the GP1B9. So what is the ligand of GP1B9? That is the von Willebrand factor. So there the adhesion happens with the von Willebrand factor. So if that is a problem, it falls under the adhesion, or if it's a platelet type pseudo von Willebrand disease, it's again the GP1B receptor problem there. Or if it's a collagen receptor deficiency, that is the glycoprotein 6. So these all come under the adhesion defect. Now, secretion defect, we saw the platelet granules. So the platelet granules, if they are absent or if they are not secreting properly, then you don't get the secondary wave of aggregation. So the platelets do not aggregate properly and they are not activated sufficiently, and you get the platelet secretion defects. Now, the third is aggregation defect. We saw that the platelets bring about the aggregation through the GP2B3 receptor and they're binding to the fibrinogen. So if it is a congenital defect of GP2B or 3A gene, then it will not adhere or it will not bind to fibrinogen, its ligand, and it will not bring about the platelet aggregation. So this defect is called Glanzmann's thrombasthenia. And then just when we went to the secondary hemostasis part, we saw that the phosphatidylserine, which is externalized on the primary platelet plug. So if that phosphatidylserine is not externalized on the the primary platelet plug, that disorder is called the Scott syndrome or the platelet procoagulant activity, which is very, very rare. So there you don't get sufficient expression of phosphatidylserine on the primary platelet plug, and that affects to some degree the activation of the secondary coagulation. So how do we see or how do we look at the platelet disorder? So I will not spend much time on this. I'll just explain the principle. This is the light transmission aggregometry. So it measures the transmittance of light. So we have the suspension of platelet-rich plasma. There is a light source and there is a photodiode which measures the light that has passed through. So when we put the platelet-rich plasma and then we activate it by using agonist. Agonist is a substance that will activate the platelet through different mechanisms. So for example, if you use adenosine diphosphate, it will activate the platelets through the GP2B3A complex. So if it's a Glanzmann's thrombasthenia, probably you will not get a sufficient aggregation induced by ADP and collagen. If it's a von Willebrand disease, there is an antibiotic called risocytine sulfate. I'm sure most of you have heard about it. So risocytine sulfate will bring about the agglutination. If there is proper agglutination happening between the GP1B9 complex and the von Willebrand factor, you will get an appropriate aggregation or agglutination response to risocytine sulfate. So if there is a defect in that aggregation response, it could be a problem of the receptor itself, or it could be the problem of the ligand, that is the von Willebrand factor. So how to distinguish that, we'll come to that part. So this is how a typical platelet aggregation graph looks like. So this is the light transmission aggregometry. Initially, the transmittance of light is 0, and then when the platelet aggregates, it reaches to 100% transmittance of light. This is the point where you add the agonist. This is the response it starts giving you. So we have that, we know from the primary hemostasis pathway that once the platelet adhesion happens to the von Willebrand in the plasma, it brings about a shape change. Then it shows the primary aggregation which is induced by the agonist by itself. At this point, the granular secretions take place. So if the granules are normal, the platelet aggregation, this is a secondary wave that comes through. So if this secondary wave doesn't come through, if this goes back to the baseline, it probably a defect of secretion. But again, one should keep in mind that the platelet aggregation or the platelet function test by platelet aggregometry is a screening test, and it is very easily affected by n number of drugs and even food that the patient has. So if the screening is abnormal, it is not diagnostic. Either you have to repeat after a while to look at the consistency, or you have to do further investigations or associate with the coagulation factor defects, or do a flow cytometry to come to or to do a confirmatory test for this. And these are the actual pictures of the aggregation that we have. So this is a healthy control, and this is a patient with glandular thrombasthenia, where you don't get the aggregation response to adenosine diphosphate and collagen, whereas the risositine sulfate induced agglutination is there to some extent. And then always you have to do the confirmation by flow cytometry. Here, the confirmation is that you don't get this positive peak on the right side, showing that this is the case of glandular thrombasthenia. Now we come to the coagulation proteins. That is the most, the blood coagulation factor deficiencies, which Dr. Chandrakala and Dr. Mohanty sir has spoken about. Hemophilia A, the most common one, about 80 to 85% patients have hemophilia A, and about 10 to 15% of hemophilia B. And von Willebrand disease is again another very common bleeding disorder. As we discussed about this, the role of risositine sulfate induced agglutination and the factor VIII levels. Now, again, the coagulation factor disorders, it could be inherited or acquired. We again briefly spoke about this, the liver disease and the vitamin K, or if the patient is on oral warfarin, or if it's a case of DIC, which is consumptive coagulopathy, everything will be consumed, and you can get a deficiency of clotting factors as well as the platelets. Now, what are the clinical indications for doing factor assays? Obviously, if there is bleeding, if the patient has to undergo surgery, and if he has any bleeding history of bleeding, or pre-surgically PT, APDT, mostly PT is done, but always a PT should be complemented with APDT, because we saw that how the intrinsic and extrinsic pathways are very much related. You cannot just do PT and leave aside APDT. You have to always do a PT, APDT both. Now, factor assays are also done when there is therapy monitoring. If it's a patient of hemophilia who is on therapy, you have to keep monitoring his factor level, his recovery. So you have to keep doing the factor assays in that. Now, blood banks require factor assays to look at the factor levels in their FFPs and the cryos. It is also considered as one of the thrombophilia markers, though it is not a very useful marker in most situations. Or if you are suspecting any other acquired causes of factor deficiency, you can look into it. Now, what are the laboratory indications? When should a laboratory decide to do factor assays? Obviously, if there is a prolongation of PT, APDT, also the thrombin time, or if the coagulation pathways are showing PT, APDT is normal or near normal, but the patient has clinical symptoms of bleeding, then also you should still go ahead and do the factor assays. Why? Is because of this slide. Now, if you look at the reference ranges of these coagulation factors and the levels at which you can get a normal APDT or near normal APDT. Now, if you look at these factors, now factor VIII, you can get a normal APDT or near normal at just 35% of factor VIII. So you can get a normal APDT. Still, the patient can have a mild factor VIII deficiency. If he's going for a surgery, then the patient will definitely bleed. So if there is any clinical indication or history that the patient has bleeding disorder, even if you get in the laboratory normal or near normal screening coagulation, you should still rule out mild moderate disorders by doing the factor assay. Now, coming to the hardcore lab part, how to choose your reagents. When you are doing the APDT, then there are different types of APDT reagents, like the high phospholipid containing reagents, which are lupus insensitive, and there are some reagents which are lupus sensitive. There are now many reagents which are specific to specific extended half-life products. Now, Dr. Chandrakala also spoke about the extended half-life products. So there are some APDT reagents which either underestimate the factor level, or some which will overestimate the factor levels. So you have to be very aware of what extended half-life the factor the patient is receiving. So you have to use the appropriate APDT reagent. Now, why the phospholipid? Because the APDT reagent has phospholipid. If the patient has antiphospholipid antibody, then which is, in many, even normal healthy individuals, we can have a transient lupus antibody. So that can, it will mop up the phospholipid present in your APDT reagent itself, prolonging your APDT time and falsely giving you an indication that, you should do factor assays. But, in that case, you have to choose your reagent, which has, if you are looking for a bleeding disorder, you should choose a reagent which has high phospholipid content in it, so that you don't non-specifically end up diagnosing high APDTs, which has nothing to do with bleeding disorder. Now, there could be artifactual prolongation of APDT. One is lupus that we saw. Another one is CRP. If the patient has very high CRP, it is an acute phase protein, as we know. It has affinity for, again, phospholipids. So even if LA is negative, it could be because of high CRP. So you should always take into consideration why you are getting a very high APDT even when your LA is negative. Now the mixing studies. So why do a mixing study? Now mixing studies are done in two situations. Like, one is to see if there is an inhibitor in your plasma. So if your APDT is getting prolonged, so you have a normal control, you have the patient, you do APDT is coming prolonged. So if you want to ascertain that if there is whether there is an inhibitor to any of the factors present, so you do a 50-50 mix of the normal and the patient. So if that mix is showing a prolongation, it doesn't correct your APDT, probably there is an inhibitor which is prolonging the APDT despite mixing it with 1:1 normal control plasma. Second situation where you can do the mixing is to quickly ascertain if it's a factor 8 deficiency or a factor 9 deficiency. If the diagnosis, it's not very easily available to you, the lab is not very easily available to you. If you look here, so you have the normal and the patient here, then you do the patient plus normal, which is getting corrected, so which indicates that there is a factor deficiency probably. Now if you add the patient plasma with factor 8 deficient plasma, there is no correction. So when you add factor 9 deficient plasma, there is correction. So there is factor 8 deficiency. So that way you can do the reverse, like you can add factor 9 deficient plasma and see if it's getting corrected or not corrected. So it can quickly give you an idea whether it is a hemophilia A or hemophilia B or factor 8 deficiency or factor 9 deficiency you are looking at. Now, another common thing is high APDT, no LA, no CRP, patient has no bleeding also, but there is high APDT. Now, including factor 12 deficiency does not cause bleeding disorder. Also, there are these contact factors which we saw, high molecular weight kininogen, Fletcher factor, prekallikrein. Deficiency of those, which are called as contact factors, they do not cause bleeding disorder, but they will prolong your APDT. So if you want to quickly rule out if it is that, then there is a simple method. When you do APDT, just give 3 times more incubation time with your APDT. So what is the procedure of APDT? You add the patient plasma, to that you add the APDT reagent, which has phospholipid and the clot activator, either ellagic acid, kaolin or silica. These are the components. Then you give the sufficient contact time, and then you recalcify it because your sample originally was decalcified by taking into citrate. So that is the procedure. Now, if you want to rule out the contact factors, just give 3 times more incubation time there. So you give more time for the contact factors to close that gap and activate your clotting cascade. So if it gets corrected after that, it indicates that it's a contact factor defect that you are looking at. Now, we spoke about extended half-life products. Now, there are some, beautiful publications and guidelines which tell you or which explain where studies are done with different types of extended half-life products. And it has been recommended or suggested which reagents work or perform how if these patients are receiving a certain type of extended half-life product. So this is the table which shows the different types of APDT reagents, the silica reagents, silica activator containing reagents, ellagic acid containing reagents, and the kaolin containing reagents against all the or most of the extended half-life products which are available. So they tell you whether it estimates the factor level correctly, or it underestimates or overestimates the factor level. So you can go back to literature and see, and it is very essential that the lab works in very close unison with the clinical department. You should know what type of extended half-life products are being given to the patient. So according to the lab should pick the APDT reagents, and it's always beneficial to have multiple APDT reagents to suit the purpose that you want to use it for. Now, why it is essential to have a correct laboratory diagnosis of hemophilia A? Now, at ICMR, National Institute of Immunohematology, we also do the molecular genetic diagnosis, the carrier and prenatal diagnosis for hemophilia and all the other bleeding disorders and the coagulation disorders. Now, what happens is that from far off places, now we saw why it is important to do a von Willebrand testing along with factor VIII. So when most of the times we get a call from a distant place saying that a patient is hemophilia A, the proband, but the proband is not alive now. So whenever his testing was done, he was labeled as hemophilia A because his factor VIII was low. Now his sister or some other family member wants to do a carrier test. Now, based on just this information, if we look into the X chromosome, factor VIII, or and if it was a von Willebrand disease, then the whole diagnosis goes wrong. And that is the reason why it is so important to always rule out a von Willebrand disease whenever you see a factor VIII deficiency. Now here, as we see, there are similarities, commonalities with hemophilia A and von Willebrand. There is prolongation of APDT, there is deficiency of factor VIII, and there is bleeding tendency. Though the bleeding tendencies differ a bit because in von Willebrand you can also have mucosal bleedings. But then looking at these commonalities, people label it as hemophilia. Now, what are the differences? There are very stark differences that in hemophilia, it's a deficiency of only factor VIII, and it's an X chromosome linked recessive inheritance, and only males are affected. Whereas in von Willebrand disease, it's a deficiency of von Willebrand factor. It is of autosomal inheritance. It's situated, the gene is situated on chromosome 12, and it affects both the sexes. So it is extremely essential to do a von Willebrand antigen whenever you get a factor VIII deficiency. So what is our laboratory strategy when a new patient with bleeding comes? So the platelet function always goes hand in hand with the screening coagulation. So you do the screening coagulation, the PT, APDT, and thrombin time. Thrombin time is a representative of the rate of conversion of activation of thrombin, fibrinogen. So if you get an isolated prolongation of APDT, you do a mixing 1:1 study. So if your mixing is getting normalized, do factor assays. So if it is APDT related, then you know that it could be a factor from the intrinsic pathway. So if the patient gives a history of hemophilia A or B, then you can directly do the concerned factor. Like if it is a hemophilia, or you do a factor VIII or factor IX. Or if there is no history, then you can go by the most common one. That you do a factor VIII assay, then you go for the factor IX assay. In rare situations, it could be a factor 11 deficiency as well. If there is no bleeding associated, it could be a factor 12 deficiency also. Then you ascertain a clotting factor deficiency. Now, if this mixing shows no or partial correction, then you do a factor assay plus inhibitor screening. You also rule out lupus anticoagulant if there is no immediate correction. So it could be an inhibitor, it could be isolate, it could be only a factor deficiency, or it could be a factor deficiency plus factor VIII inhibitor, or it could be a combination of all. You can also have a lupus interference there. Also, you have to do side by side the platelet function here. So if the ristocetin induced agglutination is normal, proceed with the coagulation workup. You can land up with either hemophilia A diagnosis or any other intrinsic coagulation factor. If there is no agglutination with ristocetin sulfate, do a von Willebrand workup. Now, von Willebrand workup may not be on the same day because of the different methods involved in that. So how do you report? If you only find a factor VIII deficiency and you are either sending it out for a von Willebrand antigen or you are doing in-house but not on the same day, you can say that this patient has a factor VIII deficiency, von Willebrand antigen testing is awaited. So you do not label it as hemophilia A at that point of time. So the reader also comes to know that, okay, now von Willebrand antigen is awaited. So what is he indicating at? So tomorrow we are going to have a laboratory workshop. So I'll not go into the details of the factor assay itself, but factor assay, I would say that it's an extension of the APDT. If you are doing an APDT in your lab, factor assay is an extension of APDT. APDT, we use neat plasma, whereas when we are doing a factor assay, we serially dilute the normal plasma and also the patient plasma, and then we do the assays. Now, there is one more reagent that goes into the assay, that is the factor 8 deficient plasma, if you are measuring factor 8. Now, why we do that? Because when we have serial dilutions of the normal and the patient, when we report, we always say that, so much % of normal. So there has to be some relation with these two. Whereas we know that the normal is not related to, normal is a pool of 20, say, normal healthy individuals, whereas the patient plasma is, you cannot relate these two. So somewhere there has to be a normalization. So when we add a factor 8 deficient plasma, so this factor 8 deficient plasma has all the other factors except for the factor that is in question. So when we add this to all the dilutions, so we are normalizing it. So the only difference in times which is given out by each of these dilutions corresponds to the magnitude of deficiency of that factor in that particular dilution. So then it becomes relatable. So when you plot these on a semi-log graph paper, these two lines come parallel because now we have normalized them. And the difference that you see in each of these points is corresponding to the magnitude of deficiency of that factor in the test plasma. And that's how you measure the factor deficiency. So this is how we do the dilutions, 1:5, 1:10, 1:20. You can go higher dilutions if you are doing new, so that you make sure that your lines are parallel. Sometimes it can happen that you don't get exact parallel lines. So the more the dilutions you have, you are more confident about the points and the linearity, parallelism of these lines. So this is how I have shown in the graph. So this is the graph. I'll explain it in more details tomorrow in the laboratory workshop. So the result is always given out, like either you can give it out in percentage, which is easy to understand, or international units per ml, or IU per DL. So you can give out the results that way. Yeah, so I will wind up. So these things I will explain tomorrow in the lab. So I'll just like to highlight the one thing. Yeah, the quality control forms a very important aspect. These are the equipments that we use in the lab. You don't need all of these. Only having a semi-automated equipment to start with is enough. These are the different workshops that we have done, and this is the kit that Saurabh spoke about, that our department has brought out, and it was launched by the Honorable Health Minister, Union Health Minister, on 3rd of August. So this is to quickly diagnose hemophilia A and von Willebrand disease. So it just requires a drop of blood, and that you can get a line, or you don't get a line if it's a severe to moderate deficiency. So I had made some MCQs, but then I'll skip them in favor of time. So I just, in the end, like to thank our team here, because of all these members of our HCC, we could conduct all these activities. And I thank my laboratory partners or my lab people for being there. One of them is here, Kirti. She will speak a little while later. Thank you so much.
That was an excellently explained lecture, right from the coagulation cascade to the defects in the cascade, correlating it to the various defects, and then understanding the diseases caused by those defects at the various levels. Beautifully explained, sir. I'm sure our postgraduates have benefited, those of who are present over here.
Thank you.
Any questions?
If there are specific questions related to the labs, and if you are attending the labs tomorrow, we can discuss, because now we are running short of time. Thank you so much.
Thank you, sir.
I request Maimoon ma'am and Wilkinson ma'am to felicitate him with a memento. Thank you, sir. Thank you, ma'am. The next lecture is on lab diagnosis of von Willebrand disease by Ms. Kirti Gargi. I invite Dr. Madhur Gupta ma'am, HOD and Professor in HOD Department of Biochemistry, and Dr. Vivek Pandey sir from Department of Medicine to chair this session.
Good afternoon, everyone. I'm Dr. Madhur Gupta, Professor and Head Biochemistry, also the MU Director and a former fellow from GSMC Mumbai. And along with me is Dr. Vivek Pandey. Sir.
I am Dr. Vivek Pandey, Associate Professor in Medicine Department of this college.
Welcome, Kirti, for this presentation. Would like to introduce Kirti, who is the technical assistant in hemostasis and thrombosis department of ICMR NIH Mumbai, and she's involved in numerous trainings which have been imparted in various laboratories. Welcome, Kirti, for this session.
Thank you so much, ma'am. Okay. Good afternoon, everyone. So today I'm going to talk about the lab diagnosis of the VWD. As sir has spoken about the differentiation between the hemophilia and VWD, we will see the next part of that. Once we have gone through the lab diagnosis of hemophilia and VWD, we have to carry out certain tests like PT, APTT. And as sir said earlier, like we have to do the platelet aggregation test also to differentiate between the hemophilia and von Willebrand disorder. Once we do the platelet aggregation, that like ristocetin aggregation with a high dose ristocetin aggregation, and if we found there is a no aggregation in the high dose ristocetin, so we can suspect there is a von Willebrand factor deficiency in those patients. So then there is a next step for the detection of the von Willebrand in the patient plasma, and if there is a von Willebrand factor present, then the activity of the von Willebrand factor. So how we will detect the activity and the antigenicity of the von Willebrand. So there is a brief introduction about the von Willebrand. So that is the, this one is the, So this one is the how the gene look for the VWF, and there are various sites for the binding of factor 8, where the von Willebrand molecule binds to the collagen, binds to the fibrinogen, all the domain they have shown. And there is one site in the gene, in that A2 domain, where the ADAMTS13 cleaves the von Willebrand factor. So von Willebrand factor is a multimeric protein which is stored in endothelial cells and also in the platelets, in the Weber pellet bodies of the endothelial cells and these alpha granules of platelets. It is stored in both the cells. When required, it is secreted in the circulation, and as it is a monomer, and then it is formed in a dimer, and so such dimers are cross-linked to form a multimeric VWF molecule, which is stored in the endothelial cell and the platelets. So this multimer is secreted then into the circulation, where it is cleaved by the ADAMTS13 molecule, which is then functional. So the two major functions of von Willebrand factor: when after injury endothelium is damaged, VWF gets bind to the exposed collagen to initiate the platelet adhesion via GP1B receptors on platelets. and it serves as a carrier protein for the coagulation factor 8, as it protects the factor 8 in circulation and co-localize the factor 8 at the site of vascular injury. So that is the von Willebrand factor is very much important for stability of factor 8 itself. Hence, if there is a deficiency of von Willebrand factor or there is a loss of functionality of the von Willebrand factor, there is also deficiency of the factor 8 that we have to keep in mind. Okay, now we will look into the antigen or the VWF antigen determination by Laurel immunoelectrophoresis. So the principle of the test is a precipitating rabbit polyclonal anti-serum of human VWF antigen is incorporated into an low EEO agarose plate. The wells are filled with the patient plasma and standard plasma. An electric current is applied and the precipitation peaks are obtained. The height of the peaks are proportional to the von Willebrand antigen in the samples. The test is insensitive to the mild to moderate deficiencies of VWF with lower detection limit being 30% of VWF antigen. That means this method is insensitive for the patients with lower than 30% of von Willebrand antigen. So it can the lower detection limit being 30%. So the requirements for the test. So we require the agarose with a low electroendoosmosis. Okay, then a barbiton buffer, EDTA dipotassium salt, HCl. So all these are the reagents which we require in the assay. Also, we need a polyclonal rabbit anti-human von Willebrand factor. Again, the Comasi blue stain to stain the gel and the D-stainer, and our platelet poor plasma of the 100% with VWF and the patient's plasma. So this is our apparatus. So this is our glass plate on which we will be casting the gel. So we require a water bath at 56 degrees Celsius to melt the gel. Also, you can see the low EEO agarose, and that is the antibody, the primary antibody for the polyclonal rabbit anti-human von Willebrand factor from the DACOMIC. So all these are the requirements which we'll read. So this is a barbiton buffer that we will be using in the test. This is a stain Comasi blue. This is a well borer with a 2 mm of diameter. So there is a specific diameter for this well to be created. So this is our horizontal electrophoretic tank. And this is how it looks. The wicks here we will be using, as we are not immersing our gel in the buffer as we do in normal agarose gel electrophoresis, we will require the paper wicks. So we are using here Whatman filter number 1 paper as a paper wicks. So the method for this is that we dissolve the agarose, the low EE agarose in the 1:1 diluted the barbiton buffer, and then we melt the gel and we have to cast the gel on the glass plate. So this is how we have to first keep the glass plate on a completely horizontal surface. So there should be an equal distribution of the agarose. There should not be the unequal areas of the agarose. So then after casting the gel, after melting the gel, we have to add the 30 microliter of anti-serum in the gel, mix it properly to ensure the equal distribution of the antibodies throughout the gel. And then we have to quickly pour the gel on the glass slide for the even distribution. If there is a delay in this procedure, because the gel is quickly solidifying, because it is very low percentage gel, it will solidify quickly. So this procedure has to make quickly. So after solidifying the gel, it will look like this. So then after this, after solidifying, we have to cut the wells in the equidistant well, so that we can load our sample in these wells. And the wells diameter is 2 micro-mm. So, and we have to, after the well formation, we have to add 6 microliter of our normal plasma and the patient plasma. And then we have to put the paper wicks, also our barbiton buffer, 1:1 diluted barbiton buffer. The wicks are pre-soaked in the buffer so that we can run it quickly, because after loading the sample, we cannot wait for all this preparation. As the wells are very nearly placed, the sample can diffuse through each well. So we have to be quick in this procedure. And we run the gel in refrigerator at 120 volts for at least 5 to 6 hours, because it is a long running gel and we have to keep it in a refrigerator. At maximum at least 5 to 6 hours we have to run this gel for a good separation of the peaks. Then you can see this gel is already half run. Okay, after this running the gel for 5 to 6 hours, we have to remove the glass bed and place it into 3% NaCl to elute out any excess proteins or the unbound proteins from the gel. And then we have to wash it in the tap water and distilled water for 3 times. And then here comes the major part. Here it is the gel that we have run. We have to dry the gel. But for this drying, we cannot use the oven. We have to dry it like air dry. The actual method is for air drying, but that takes a lot of time. So we have adapted this method. We use the yellow bulb for drying the gel. We place the Wattman filter number 1 paper on top of the gel, so that it can absorb the excess of water from the gel, and the light itself will help in further drying. So after complete drying, we have to remove the paper and we have to wash the gel with distilled water and stain it with Comasi blue stain for 40 minutes or more than that, till you can observe the developed peaks. So this is how it looks after staining. So these blue peaks, the first well here is my NPP, that is my control, and the further ones are all my patients. So there is a calculating method for this. So we have to first measure the peak. The peak, how we will measure the peak? The wells, we can see the wells, we have to mark the center of the well and the tip of the peak. And we have to measure the distance for both my control plasma and the patient plasma. Then after using this formula, we can calculate the VWF percentage in our patient sample. So by this method, so we can, as I have said earlier, this method is insensitive for the samples which contains the less than 30% of VWF antigen. And in this one, we can see all the peaks are present. That means it is more than 30%. And when it is less than 30%, you will not observe the peak. The well will be the blind. So next step, after this step, we have come to know that some of the samples have less than 30% of the VWF, but how much it is. So we have to quantitate the VWF antigen perfectly. So we have the automated system, the ACL top. So on that machine, we can do the latex immunoassay to quantitate our VWF antigen. So for this VWF antigen determination by automated latex immunoassay, the principle of this assay is the kit, the VWF antigen kit includes the latex particles, enhanced immunoturbidimetric assay to quantify the VWF antigen in the plasma. So basically it is an immunoturbidimetric method. When a plasma containing VWF antigen is mixed with a latex reagent, which is a suspension of polystyrene beads, latex particles coated with rabbit polyclonal antibody directed against the VWF. So here we are not using these beads, polystyrene beads, where the antibody is coated on the surface of the beads. And the reaction buffer includes in the kit the coated latex particles with agglutinate. The degree of agglutination is directly proportional to the concentration of VWF antigen in the sample, and it is determined by measuring the decrease of transmitted light caused by the aggregates. Now, as it is automated system, the system will directly give you the percentage of the calculated percentage of the VWF antigen. And here you can only quantitate the VWF antigen, whether it is functional or non-functional. You will get the reading of how much VWF antigen is present. To see the functionality, the activity of von Willebrand factor, we have another assay, which is VWF ristosettin cofactor activity, which is again done on the automated system. The VWF Rikoff kit is a latex particle enhanced immunoturbidic assay to quantify the VWF Rikoff activity in citrated plasma. The activity of VWF is determined by measuring the increasing turbidity produced by agglutination of the latex reagent. So principle for the both test is almost same. A recombinant, but here the reagent is a little bit different. Here we are using a recombinant fragment of glycoprotein platelet receptor, that is VWF GP1B alpha, is coated to the latex particles by means of specific monoclonal antibodies, which orients the GP1B fragment in proper way to interact with the VWF of patient plasma in presence of ristocetin. Again, for the measuring the activity of the VWF, we need a ristocetin in this assay. The degree of agglutination is directly proportional to the activity of VWF in the sample and is determined by measuring the decrease of transmitted light caused by the aggregates. So principles are both the same. Here the latex particles are coated with the GP1B receptor, which is naturally present on the platelets. So the advantages of this method, which this is suitable for large number of samples. As you could see on my gel, there are at least 50 samples we can run in a one go. So it requires the less amount of sample. For one patient, we just require a 6 microliter of the sample. Patient plasma is just enough. Cost effective, as each batch require only 30 microliter of antibody. But the disadvantages of this method is the long run time. The proper time for this assay is 2 days. So lower detection limit is 30%, below which the peaks doesn't appear. Again, you have to go for the determination by the automated system. And the tedious procedure require number of reagents, because the buffers that we are using and the other things, there are number of reagents in this method. Okay, so I will give you the brief idea about this VWD now, because for the next assay it is required. The von Willebrand disease is characterized by the quantitative and qualitative abnormalities of von Willebrand factor, which is a crucial protein in hemostasis. So the bleeding manifestation in this disease are none to moderate. Means like some patients will bleed, some patients will bleed moderately. So on that basis, we have to classify the disease. In this VWD, we can see the easy bruising, excessive bleeding from injury or after surgery or dental work, frequent nosebleeds. Women with this disease may have the heavy and long menstrual bleeding and excessive bleeding during labor and delivery. So some of the bleeding manifestation are similar with the hemophilia. So that is the thing which gets some confused between the hemophilia and von Willebrand disease. But this treating the VWD patient just with factor 8 is not going to help. So we have to treat it with the von Willebrand factor itself. For that thing, we have to distinguish between the hemophilia and von Willebrand disease. So there are 3 types of von Willebrand. So type 1, which is a quantitative defect, amount of VWF is not enough. Means VWF antigen is there, but it is not present in enough quantity. So the bleeding is none to moderate. Type 2 VWD, which is a qualitative defect, which is a dysfunctional VWF. The bleeding again is moderate to severe. And type 3 VWD, which is a profound quantitative defect, that is a total or near absence of VWD, and the bleeding is severe, which is similar to hemophilia A. So in type 2 VWD, the platelet phenotype, including the presence of circulating platelet aggregates, giant platelets, fluctuating thrombocytopenia, and platelet function defects, we can see in the type 2 VWD. It is characterized by the gain of function mutation in VWF A1 domain. It increases the VWF binding to its platelet receptor, that is glycoprotein GP1B, leading to spontaneous platelet aggregation and thrombocytopenia due to the clearance of platelet VWD complexes from the circulation. Now, in other types of VWD, there is a deficiency or near absence of the VWD, but in type 2B VWD, there is a gain of function. That is, the VWF is secreted excessively in the blood and it will spontaneously bind to the platelet, which causes the thrombosis and the clearance of these platelets from the blood, which will cause the thrombocytopenia. The thrombocytopenia can be addressed with the platelet transfusions. Okay, I'll skip this. The principle of the test, the next step, that is the VWF multimeric analysis, which is required for the classification of the type 2B VWD specifically. So this is the principle of the test is the von Willebrand factor circulates in the plasma as dimers and multimers. Determination of this is essential for subtyping the VWD. The precise subtype of VWD is determined by the electrophoretic separation and visualization of the multimeric components of VWF binding with the radio-labeled anti-VWF antibody, which can be seen by exposure to the X-ray film or any of the imaging system.
Mrs. Kirti, can
Yes.
you just?
Yes, ma'am. Now I'll finish it fast. So these are the there are many buffers and reagents including this assay. I will just pass. So main thing is our rabbit anti-human VWF antibody, which is a primary antibody, and the secondary antibody will be the goat anti-rabbit antibody. So these are the main components of this assay. So there are lots of reagent, and the procedure is also long. It is a 3 days procedure. So I can just go through. So here why it is important to do the multimeric analysis to differentiate between the type of VWD, because as I've seen the type 1 is just a quantitative deficiency and type 3 is a total deficiency of the type VWF. So we can identify type 1 and type 3 by the other laboratory diagnosis method, but the type 2 VWD, type 2 we have to differentiate between the type subtypes of type 2 VWD. We require this multimeric assay. So here you can see we have started the multimeric analysis as a trial in our lab. So we have got such results. You can see the number 1 is my normal plasma samples, where you can see all the bands are present. And second is ADAMTS activity nil sample. That is, as I said before, this ADAMTS 13 is required to cleave the von Willebrand antibody, the multimers, the large multimers of VWD, which will be turned into the functional VWD, the smaller multimers. So when there is absence of ADAMTS 13, we can see all these multimers in higher intensity band. Then third sample is type 3 VWD, where there is a total absence of VWD. And fourth is the VWF antigen is 7.4, that is, it is like a type 1 VWD, where is a quantitative deficiency of the VWD. So on this, by this method, we can just differentiate between the different types of type 2 VWD. So, okay. Thank you so much.
So much, Mrs. Kirti, for the elaborate things which you have told about into the diagnosis of the immunoturbidimetric methods, which are to be followed in a patient of VWF. Pandey sir, in case you want to add something. Thank you. The house is open for any questions. I think this will help them when tomorrow there's a workshop. So when you go into the flow of this, when you elaborate more, then they'll find it more useful. Thank you so much for being over here.
I request Madhur Gupta ma'am to please felicitate Miss Kirti with a memento. Thank you, ma'am. Thank you, sir. Thank you, Miss Kirti. Now we'll have a virtual talk on F8 inhibitors in hemophilia patients, testing issues and interpretation by Dr. Rucha Patil.
So can everyone see the slides?
Yes, ma'am.
Okay. First of all, I would want to say, please ignore this look with the gogs, because today I woke up with conjunctivitis. So that is why this is the funny look. But having said that, we will start with the lecture. That is, today I'm going to speak on factor VIII inhibitors and everything about it. So coming to factor VIII inhibitors, the testing, issues and interpretation. So Dr. Chandrakala ma'am gave a gist, and she told us what inhibitors in hemophilia are, when do they develop, the prevalence and the frequency. So we all know that it is 20 to 30% in severe hemophilia, and it's around less, that is 5 to 10% in mild and moderate patients. And when it comes to the median age of inhibitor development, it's around 3 years of age in severe, whereas around 30 in conjunction with the intense exposure to factor VIII during surgery. And then you have the high responding inhibitors and the low responding inhibitors. And all of us know that the gold standard test for inhibitors is the Bethesda assay, which I'll be speaking on. Coming to hemophilia B, it is very less frequent. It's only 5%, that is less than 5%, and it's mainly associated with allergic reactions. So this too was covered, that is, when should one suspect an inhibitor development? If a patient fails to respond or it has a poor response to clinically to the clotting factors, or they have lower factor VIII and IX levels than expected after infusion, if there are unexpected increase in the number of severity of bleeding episodes or unusual bleeding episodes, this is when one should suspect factor VIII inhibitors. So when they should be screened, these are there in the guidelines. For children, it is once in every 5 exposure days until 20, every 10 exposure days between 21 to 50, and at least 2 times a year until 150 exposure days. We all know this is not done over here. Now, coming to adults, it should be done after every 6 to 12 monthly, or when they have a failure to respond to the adequate concentrate. When any patient is intensively treated for more than 5 days, if they are switched to a new factor concentrate, or prior to surgery, it is very important to check for inhibitors, and even in the post-operative period. Now, we know that there are risk factors of inhibitor development. You have high-risk mutations, null mutations, then you have intense exposure, infection, and the most important is the first 75 exposure days. So, the most important part is prompt recognition of inhibitors is critical, since early therapy can be life-saving. So now coming to the techniques of inhibitor detection. First of all, you have mixing studies, that is the screening assay, 1R, 2R. Then you have the classical Bethesda, the Nijmegen Bethesda, ELISA, and the factor recovery test. So now I'm going to be a little slow so that everyone understands the concept. Once you understand the concept, all the inhibitor tests are based on the same principle. So coming to our incubated mixed test, you have 3 tubes in this test. One tube has normal pool plasma, which has factor VIII. The second tube has the patient's plasma, which may or may not have inhibitors. And then you have the third tube, which has a 1:1 mix of patient and NPP. You put all these 3 tubes at 37 degrees for 60 to 120 minutes. And after 1 hour and 2 hours, you remove them and do a basic APTT. You do a basic APTT of this incubated mix, that is tube 3, and a separate mix. That is, you take 25 microliter from the tube 1, which is only NPP, and 25 from the NPP. So what happens? What is the principle over here? We all know that factor VIII inhibitors are time and temperature dependent. So in this incubated mix, you are giving the factor VIII inhibitors 2 hours time to neutralize the factor VIII which you are giving from the NPP. And thus, this incubated mix APTT would be more prolonged than the separate mix. So to clear it out even more, you have tube 1 with factor VIII, that is the NPP. Tube 2 with the patient's plasma, say the patient's plasma has factor VIII inhibitors. And tube 3 is 1:1 NPP with patient's plasma. After 1 to 2 hours incubation at 37, the inhibitors are time and temperature dependent. So when you do an APTT of tube 3, you've given sufficient time for the factor VIII inhibitor to go and neutralize the factor VIII, and thus the APTT is prolonged. Whereas in tube the second, that is a separate mix, that is, you're taking a 1:1 of tube 1 and tube 2. No time is given. It's an immediate mix, and APTT is not prolonged. Thus, the conclusion is, if the incubated mix is more than 5 to 10 seconds than the separate mix, screening is given as positive and a Bethesda can be done. Now, I put a very big red cross on this slide because according to guidelines, this test should not be done. We do not believe in that because this is the most simplest test that anyone can standardize in their tests. The only flaw of this test is that low Bethesda titer, that is lower than 2 Bethesda titer, may be missed. But if the laboratory and the clinicians very well know about this, it is fine to go ahead with the test. So this is the example of how the seconds look when it is an inhibitor negative. You can see after 2 hours, there's no difference in the incubated mix and separate mix. Whereas in the inhibitor positive samples, you can clearly see that the incubated mix is prolonged when compared to separate mix. So coming to the next test, that is the Bethesda assay. Here, one should know the definition of what is one Bethesda unit. 1 Bethesda unit is that amount of inhibitors which can reduce the factor VIII levels of a defined mixture from 100 to 50%. Having said this, you have a cutoff which has to be standardized in each and every laboratory, but it is around 0.6 Bethesda units per ml. Now, everyone hates the Bethesda test. Why? Because there are so many tubes, there are so many dilutions, but the basic principle stays the same. The only difference is you're taking the patient's plasma and you're making n number of dilutions. To these n number of dilutions, you're adding the same amount of NPP and you're incubating it after 2 hours. And as I said, 1 Bethesda unit is that quantity of inhibitors which can reduce the factor VIII levels to half, that is 50%. So the tube which gives you a factor VIII levels of 50% when compared to the control is your Bethesda titer. So it is the same 2 hours, it is the same time and temperature phenomena, just instead of APTT, you're doing the factor VIII levels in each and every tube. Now we have the classical Bethesda, however, it was modified and it is now Nijmegen modification. 2 things were done over here. One is you're buffering the normal pooled plasma with 0.1 molar imidazole. This is to prevent any pH shift from happening during the incubation. Second, you're replacing the buffer with a factor VIII deficient. Again, all of this is to make the entire condition very stable for 2 hours during incubation. Now, coming to ELISA, we have, and you even get it outside, we have standardized the factor VIII antibody detection ELISA in our laboratory. This is not useful in day-to-day testing, but when we do inhibitor camps, it is very beneficial. We just do the 100 samples on this. All the borderline and positives are then taken up for Bethesda. And the most important test, which is one of the simplest tests to do, is the factor recovery test. You infuse the patient with factor VIII, and after 1 hour, you check the factor VIII levels. So if you're infusing with 100%, a recovery of 66% and more is considered to be normal. This is a simple way of detecting whether a patient has inhibitors or not. Now, coming to the issues with these tests. First of all, if you get the wrong plasma samples, you will get false positive results. Your EDTA plasma is known to give you false positive tests in inhibitors. Your lupus anticoagulant is known to interfere in all the population tests. Then you have other non-specific inhibitors. One high titer inhibitor can give you a false factor reduction of others and even Bethesda positive. So all this should be kept in mind while reporting. And laboratory errors, of course, there are using the standard Bethesda assay in place of Nijmegen. This all could lead to false negative because of the lower titer being missed. Now, the most important part which I want to tell about the testing is the false negative results can be got when. It is very well known inhibitor test has to be done after a washout period. That is, recent treatment with factor and bypassing agents will give you false negative. But there is a solution to this. Now we have a modification in our test. You just heat the patient's plasma to 56 degrees for 30 minutes and centrifuge prior to testing. Now I want to highlight the importance of this test. So in the patient's blood, he comes to the clinic, he's bleeding, he has factor VIII inhibitors, but there is no past history of inhibitors, so the clinician gives him factor VIII to stop the bleed. Now, what happens in his plasma is you can very well see that the factor VIII which was infused is going to bind to the factor VIII inhibitors. You get a poor response to the factor VIII replacement therapy, and the clinician will write 2 factor VIII inhibitors. Now, this sample comes to us, a citrate blood, it is centrifuged and we get platelet poor plasma. The same platelet poor plasma is going to have this complex, that is the antibody along with factor VIII which was infused. And we very well know that each and every test has the combination of patient plasma with NPP. And the factor VIII inhibitors are supposed to bind to these factor VIII to factor VIII of NPP. Over here, since the factor VIII inhibitors is not free to neutralize the NPP factor VIII, it would give you a normal APTT or factor VIII levels, and you're going to get false inhibitor negative. Whereas, if you do this 56 degrees for 30 minutes incubation, the factor VIII degrades, but the antibody is intact. And then finally, the factor VIII inhibitor is free to neutralize the NPP factor VIII, and you will get a proper inhibitor positive. And thus, this step is very important in all labs to be carried out. So now, important unresolved issues, you have the inter-assay variability. There is a lack of appropriate standardization of the lower limit. There is a lack of definition of a negative antibody titer. and you have LA interference in all clot-based assay. This shows the interlaboratory variation when it comes to factor VIII inhibitors. Now, quickly going through one interesting finding, that is, as I specified that factor VIII inhibitors are time and temperature dependent, but having done many inhibitor camps, around 6,000 to 7,000 samples, we got few samples where we found immediate acting inhibitors. That is, the 0R mix itself is not at all correcting. This is generally seen in acquired hemophilia or factor IX inhibitors, but we have found it in congenital hemophilia. Why I highlight this? It is because in these samples, your 1R, 2R is going to come negative, and your Bethesda is going to show very weird results. Now, tomorrow in the workshop, you'll be seeing the Bethesda assay readings. They are supposed to be parallel. They are supposed to be properly reducing as the dilution takes place. But you can see in an immediate acting, they come non-parallel readings. So, again, one more thing which I wanted to highlight is we had a severe case of hemophilia patient. He has passed inhibitor positive, 12 Bethesda, 21. So a very well-known case of inhibitor positive. He was currently posted for surgery and inhibitor was supposed to be tested. And when asked the patients, he said he was only transfused with FEBA 1 month ago. The lab report, we continuously got it Nijmegen Bethesda negative. We thought it was a laboratory error. We again retested. We asked for a new sample. Despite of that, the inhibitor test was coming negative. But if you see the APTT also was showing shortened when he was not given factor VIII. So what was this? When we called the patient back again and checked his file, 1 month back, along with FEBA, he was given emicizumab. Now, this is a very important drug nowadays, which many of our patients are taking. And thus, all the laboratory people and the clinicians should be aware that emicizumab is a drug which normalizes APTT even in subtherapeutical emicizumab concentrations. Now, generally, when they are on prophylaxis, there is no monitoring required. But suddenly, if this patient starts bleeding or is posted for a surgery, but obviously you need the inhibitor status, this is when it is a problem because one stage, your Bethesda, so you cannot do your APTT, the one stage factor assay, Bethesda, they all come normal in this patient. What you have to remember is you have to do factor VIII chromogenic test using bovine components if you want the true factor VIII levels and inhibitor. And even most important is that clinicians should notify the laboratory about the current emicizumab treatment as well as any injection taken 6 to 9 months prior. This also affects the tests. So quickly going through 2 reports, that is what is wrong, what is right. So you can see this is one report and the APTT is of the patient is 47.1 and the immediate mix is 52.5. The inhibitor levels is coming negative. So when I do a Bethesda, you can see it is non-parallel readings. So what is this report? Is it a negative report or is it a positive report? So this is what I called about immediate mixing, that is immediate acting inhibitors. In such cases, we do report it as immediate acting inhibitors present and Bethesda cannot be given because of the non-linear readings. Second report, this is again a post-factor VIII transfused sample. You can see the mixing is normal over here and our 1R, 2R is negative. So do we stop over here? Is this fine? No, we went ahead with a Bethesda assay. It was 2.1 Bethesda units. Why is this happening? Again, it is because it was a post-factor VIII transfused sample and 56 degrees Celsius heat modification was not done over there. So you can see how important your heat modification test is. Otherwise, it will give you false negative samples. The third test is now over here, it's not post-transfused, but we give a factor VIII inhibitor negative. The clinician feels that the patient is not properly responding. So does a recovery test. It comes 38%. What is wrong? We do a Bethesda 1.75%. Over here, what you realize is, yes, this is very well known. Your incubated mixed test, 1R, 2R, does miss out on 2 Bethesda units and below. So this has to be kept in mind while doing the 1R, 2R tests. Thank you.
Thank you so much, ma'am.
Ma'am, thank you so much for a very nice deliberation. Ma'am, I have a query, ma'am. Since most of us are doing online screening test only for inhibitor, So for these screening tests, could we just modify it further so that we don't miss out on those less than around 2 with BU unit inhibitor patients? Can something be done on those screening aspect that you would like to?
So I would want to stress on, if Bethesda is not being done, first of all, even for the 1 hour, 2 hour, you can do the heat modification step, okay, and do it with the NPP. This is one. Second thing is, what you can do is, if 2 Bethesda units is not being detected, just do a factor recovery test. Because one stage factor assay is done everywhere. So these two tests combined will help you answer the lower Bethesda.
Right. And another thing is that once, suppose we are not doing those BUs, we have not been able to do the Bethesda. So if the difference of immediate mix and the incubated mix, what is the cutoff point that would you like to take? Some say 6 seconds, some say 8 seconds, and you have written 5 to 10 seconds. And this exact, you would like to know, what difference we should consider as appropriate.
So in our laboratory, we take 5 seconds and more. We go ahead with the Bethesda after that.
Okay, ma'am. So that
yeah.
So, thank you, ma'am. Actually, these are the problems we were facing when we had this field test and we had done for 17 patients. So this very borderline, this 5-second difference and 6-second difference. So that puts you in quite a dilemma. And what has happened is that we had missed out because one patient went to CMC Bello recently and had missed out we had reported inhibitor is negative, but it turned out to be 2BU, but he might have had taken another exposure because he went there after 2 months. So but we did really miss out. Thank you.
Yeah.
We can now just go for the lunch.
And I request Vipin sir to kindly accept the token of appreciation from the society for Rucha ma'am. Thank you so much, ma'am, for joining us online.
Thank you so much.
Ma'am, be there for the felicitation part, ma'am.
Okay.
So, Rucha, on your behalf, I am accepting it.
Yes, please do.
Thank you, Rucha.
Thank you so much.
Thank you, ma'am. I request everyone to have lunch and come back early for Chandrakala ma'am's lecture within 20 minutes.
हे कसं करायचं
जितने भी इनका वो डेजिग्नेशन उनको प्रेस के लिए लगेगा मतलब सपोज ये whatever जो भी है पर गिवन एक काम करो ना सभी एक ही जगह से करें मोस्टली क्योंकि अगर सब एक जगह से तो मैं बता देती और अगर सब अलग है तो फिर सबका अलग है ये बात नहीं कई हमसे दुनिया को ध्यान दे बस the speakers from DSMC, KM and NIIH Mumbai focused. ऐसा लगता है नहीं वो तो है ना मैंने ना गलती सुन नहीं क्वेश्चन ये वाला this paper from focus one yeah
Thank you.
Welcome back all from the lunch session. Now we'll begin the session, which is on the recent advances in hemophilia management by Dr. S. Chandrakala ma'am. And to chair this session, I invite Dr. Pradeep Pazare, Associate Professor, Department of Pediatrics.
Good afternoon, everybody. I welcome you all after the post-lunch session. Actually, Chandrakala madam doesn't require any introduction. We had her a very nice talk in the morning with the very first session. She is DM, MD DM and fellowship in leukemia and bone marrow transplant. And she's her designation is Professor, Department of Clinical Hematology at SAIT Medical and KM Hospital, Mumbai. She has an esteemed professional in the field of clinical hematology, holding an MD and a DM. She has further specialized in, with a fellowship in leukemia and bone marrow transplant. Currently, she graces the position of professor in the Department of Clinical Hematology at GS Medical College and KM Hospital, Mumbai. Her extensive qualifications and expertise make her an invaluable asset to the medical community. Ma'am, please welcome for your comments.
On management of hemophilia, and that was mainly factor 8 and factor 9. And I should also told that patient requires twice or thrice injections. And now I'm going to talk on the recent advances where the patient can get once in 10 days to once in 2 weeks to once in a month injection. So that is the recent advances we are having in the management of hemophilia patients. Okay. So this is the recent advances. Actually, we can see initially we were only having the factor concentrates, and then we had plasma, only blood and plasma we were using. And then when I was resident, we were mainly using the plasma and cryoprecipitate, and then the factors came and the recombinant factors came. Then comes the extended half-life factors. Normally, the factors which we are using at present, they're called standard half-life factors, SHL, standard half-life factors. And now the recent advance is extended half-life factor, EHL, extended half-life factors are available now. And the next one is non-factor therapies and gene therapy. And these are the recent advances in the management of hemophilia patients. So what are the challenges we face with factor 8 and factor 9 injection is the patient is intravenous injection. It's a pediatric patient. You have to give twice a week injection, 8 injections per month, and almost 96 injections per year. That is just twice a week prophylaxis you're giving. How many times you're going to prick the pediatric patient? Like once, 96 times you're going to prick in a year. The children will not be compliant to the therapy. And even with that, are we going to get a zero bleeding? No. With so much of injections, we are not getting the zero bleeding because they tend to bleed with these factors also. And cost of the treatment is also very high. And the challenge is again, inhibitor development. You give factor 8, it's a foreign protein, and they develop antibodies against it, and the factor becomes ineffective. So that is the disadvantage of factor 8 or the factor 9. And joint morbidity is still there, and the hemostatic effect of bypassing agents when they develop inhibitors is not as good as factor 8 or the factor 9. So I mentioned about prophylaxis, we have to maintain the factor level more than 1%. But is that sufficient to do all the activities? You can see here in this graph, see, this is the target level which you want to like perform. Somebody sitting on a computer whole day, that's enough actually, 3 to 5% is enough. So kids are running around all the time. So whether this 1% factor is enough to prevent the bleeding on this patient. So these are the levels of factor we require for the different activities. Intensity of activity increases and you require higher level of factors. So how should we aim for these levels of factor? So we need a long acting factors. So again, the barriers of the prophylaxis is the patient-related factors, treatment-related factors, social factors, and so that is the reason. Main is they cannot get so much of IV injections because of the multiple problems that the patient doesn't get prophylactic treatment for a longer time. So what do we need to improve our care in hemophilia patients is longer half-life. Instead of 8 hours, do we have which has got 100 hours of half-life, or 28 days, or 30 days of half-life. We have got anything like 4 to 5 years they can live with one injection. So anything such type of treatment is there that we have to explore. Less frequent injections, high trough levels. You give one injection, patient will be okay for 10 days with such a high level of factor. They don't require further treatment. And decreased chance of inhibitors, decreased chances of transmission-transmitted disease. If anything like subcutaneous injection, that's a boon, no? So like they can get subcutaneous pen. See, insulin has got every day they prick with a pen, and that is available to hemophilia patients also nowadays. So if you have a pen-like thing, that is really, really very nice for the management of these patients. So the first advances, the recent advances is extended half-life factor, extended half-life factors. So how can we extend the half-life factors which already we have? There are some technologies which has been used. So this coming to this picture. So there are some pegylated products. If you are in oncology, if you treat any oncology patient, there is something called pegylated molecules, pegylated chemotherapy molecules, where they act for a longer time with less side effects. That is the advantage of this pegylation. So your pegylated protein is attached to normal factor 8. You can see here, this is the normal factor 8 or the factor 9. You are attaching the pegylated molecule to this, and because it is a pegylation, there is a hydrophilic bond is around this happens, and it is less prone to enzyme degradation, and even the renal clearance is also less. So that is the mechanism of how pegylation increases the half-life in factor 8 of the factor. Any drug will increase the half-life with pegylation. There is something else also called factor 8 or factor 9 is bound to this IgG. See, IgG, what's the half-life? Albumin are the IgG, immunoglobulin. So if pediatricians and medicine people should know, the half-life of IgG or albumin is almost about 2 to 3 weeks. So you bind the factor 8 or the factor 9 to IgG or the albumin, and it gets recirculated in the body. So that is how the recycling happens, and the half-life of the factors increases. So these are the two technologies where the half-life of the factor is increased. So normal standard of factor 8 has got a half-life of about 12 hours, and extended half-life factor has got half-life of 14 to 19 hours. So why only this much as level factor 8 half-life is increased? Because factor 8 is always bound to VWF. So the half-life of factors is depend on the VWF actually, So that is the reason VWF levels goes down, the factor 8, like whatever you do pegylation also. So the half-life is only that much. Now recently in about 3 months back, there was a molecule which has got a VWF, factor 8 and pegylation. That half-life has increased by almost 36 hours. So that is recently approved by US FDA. So that's a new technology which is available for the hemophilia A. And see the change in hemophilia B. When we had a half-life actually 18 to 24 hours, with the new technologies, the half-life has increased to 100 hours. It's 4 to 5 times. So what is the meaning of half-life is when you give any factor factor, after about 24 hours, it becomes off, and then after 24 hours, it becomes off. So it's every time actually in 5 half-lives, the levels becomes 0%. So when you give 100 hours, the patient can get a very less frequent injections. That is the advantage of these factors. So when you have factor 8 extended half-life factors, the number of injections is reduced by 30%, whereas if you have a factor 9 extended half-life, the number of injections is reduced by 60%. So initially I told 96 injections they used to get. If you reduce by about the 40 injections, they can get the better prophylactic therapy with these new treatment options. So these are all the studies which has been done in new one molecules, extended half-life factors. You can see the dose actually here. It's about once in 14 days. So this is every 14 days you can give this injection. So when we have to give once in every like twice a week, it's now we are giving every 14 days we are giving this injection. So these are all the advantages. Somebody has got difficult IV access, poor adherence, that can all be improved with the extended half-life factor 8 or the factor 9 concentrate. So there are new, that is about the newer molecules of factor 8 and factor 9. There is something called as non-factor therapies or the rebalancing therapies. So I'll see. Normally what happens is, when the patient has got a less factor 8 and factor 9, the patient will bleed. No? Less factor 8 and less factor 9, the patient will have bleeding. If they have less protein C, and you must be seeing patient of thrombosis, less protein C and protein S at the antithrombin 3, they clot. So what you are making in these newer molecules is, you knock off some of the anticoagulants, means you reduce antithrombin 3 levels, you reduce protein C levels, you reduce protein S levels. So you balance it off so that the patient will not have a bleeding. So you make, when this is less, you make also this also less. So that is the principle of your rebalancing therapies. Same thing I've shown here. So this is a normal hemostatic therapy. Normally, normal human beings has, this is the way it's balanced. Both procoagulants and the coagulation inhibitors, they are balanced actually. It's balanced actually. So when this is less, the patient will bleed. And when this is less, the patient will have clot. And you make both of them restore the balance, and then patient will have a normal hemostasis maintained. So this is the principle of newer drugs in the hemophilia. So these are all some of the non-factor therapies in the clinical trials. Only these two drugs are approved for clinical use. This long list is increasing, and the list of drugs, a lot of clinical trials are in India also, no? Like phase 3 trials, or phase 1, phase 2, phase 3 trials are there in India also. So just to show an example of again rebalancing therapies, this is the molecule which we have. At present, we have this emicizumab which is approved. Emicizumab is a monoclonal antibody. I'll tell you in detail about. It is second generation monoclonal antibody which is in clinical trial, phase 3 clinical trial. And concizumab is approved for hemophilia B with inhibitors by US FDA. India, it's still not available. It's a pen. It's a pen. Every day you have to prick once with the pen. Actually, that is it's as simple as this. And fluticasone is in phase 3 clinical trials. It is decreased the antithrombin 3 levels. That's how it works, no? So in the next maybe 1 decade, a lot of molecules are going to approved for the management of hemophilia patients. So again, I showed you in the morning this picture. This is a pediatric patient. Twins, both the twins are hemophilics. Both the twins are hemophilia A patient. One of the twins post IV injection had to under compartment syndrome and surgery, and parents are terrified of IV injection. They want something else for the child, actually, So maintaining both the kids is very, very difficult for them. So at that time, what are the options of treatment we have is this one. So emicizumab is normally mechanism of action is factor 8 binds to 9A and 10, and the coagulation cascade forms the clot formation. Similar to that, emicizumab is a bispecific monoclonal antibody. Bispecific is it binds to factor 9A and factor 10, and it acts like a factor 8 and it activates the coagulation cascade. So it's actually factor 8 mimetic or bispecific monoclonal antibody. That is a mechanism of emicizumab. So advantages of emicizumab you can see here. It can be given for hemophilia A without inhibitors. With inhibitors also you can give, without inhibitors also you can give. It is subcutaneous injection. And a longer half-life, weekly to monthly dosing we can give it. And the chance of developing inhibitors is very, very, very less. There are hardly any cases, few case reports of inhibitor development to the emicizumab. That is the advantage of emicizumab. So what is the efficacy of emicizumab? And it's where it's approved. It's approved only for the prophylactic therapy. You cannot give, somebody comes with a bleed, you cannot give emicizumab. It has to be given as a prophylactic therapy to prevent the bleeding for hemophilia A, with or without inhibitors, all pediatric, adults, anybody who can give, irrespective of whether inhibitors are there, not there. Actually, that is the, and the half-life is 4 to 5 weeks, administered by weekly subcutaneous injection, and it is not neutralized by factor 8 antibodies. And this is the dose. The recommended dose is, loading dose is 3 mg per kg once a week, followed by You can give 6 milligram per kg once a month. Initially 96 injection reduced to 40. Now it's reduced to almost about 12 to 16 injections per month, that to subcutaneous injection. So that is the efficacy of these new drugs of emicizumab, which can be given as a subcutaneous injection. So where all you can give? So you can give in abdomen, thigh, or even the lateral part of upper arm you can give. And this is how you give injection. Emicizumab injection can be given to these patients. Efficacy, this all the multiple trials which has been done, adults, pediatrics, everywhere the trial has been done, and see the efficacy. What is the number I mentioned here? This number of patients did not had a bleeding during the entire clinical trial. So the almost about 60 to 70% of the patient did not have any bleeding. So any hemophilia on this treatment, 70% of the patients do not bleed. That is really, really very nice. Zero bleeding. Normally, hemophilia patients bleed at least about 3 to 4 times in a month. For the medical students who don't know hemophilia, 3 to 4 times in a month they bleed. And when they got this injection, they had zero bleeding. That is the efficacy of this drug. And again, multiple trials. Actually, I mentioned again, this is the efficacy of this many number of patients had a zero bleeding, and this many number of patients had only 3 bleeding. So almost 100% patients had less than 3 bleeding in this clinical trial. And you can see here, as the patient every year, when the joints becomes better and better, the bleeding rate reduces. So you can see here, when the patient is on the 169 to 192 weeks, 100% of the patient had a zero bleeding. So that is the efficacy of this new molecule. And target joint is also resolved in almost all the patients of emicizumab. So this is the KM. This is experience from KM hospital. When we give emicizumab to our patients, you can see here the patient's clotting time is reduced and number of patients on emicizumab had a zero bleeding. So this patient, they did not bleed when they were on this drug, and some of the patients call it as a miracle drug. Actually, when the patients, the parents were explaining that my child can jump up and down, but they don't bleed nowadays. They're more active. So that is how they feel with this new drug. The other drug I explained about concizumab. Concizumab is a tissue factor pathway inhibitor. So once the coagulation cascade is activated, clot forms and clot dissolves because of the tissue factor pathway inhibitor. So concizumab is an inhibitor to the tissue factor pathway. So that's how this molecule works. And this has to be given every day. And it is a pen actually. Pen is available and we can use this as a it can be given for hemophilia A, B, with inhibitors, without inhibitors. See, even if you don't have anything like a diagnosis, factor 8 or factor 9, you don't have doubt. So this molecule can be given as a prophylactic therapy. All 4 conditions this molecule can be given. So the clinical trials may happen in other disorders also, but as of now, it's approved for only hemophilia B with inhibitors. But it can be used in all conditions. A, B without inhibitors or with inhibitors can be used this drug. Multiple clinical trials, and that drug has shown very good efficacy, like emicizumab. You can see the patients on emicizumab had a very zero bleeding. Is almost 60% of the patient did not had any bleeding when they were on concizumab drug. So that is the efficacy of this clinical trial. And these are all the molecules which are in the clinical trial: concizumab, mastatinib. So these are all anti-TF molecules. There are multiple molecules in the phase 1, 2, and 3 clinical trials. I told you one more molecule called futistiron. Futistiron is, it decreases the antithrombin 3 levels in the body, and that's how this is from the. This was presented by Dr. Alok Srivastava from CMC Vellore in ASH meeting, and this is the efficacy of futistiron drug. On futistiron, the patients actually the percent of bleed reduction was 89%, and the target joint, almost everything is reduced. Actually, the patient who had zero bleeding also is much higher when they are in this drug. So that is the. This is also subcutaneous injection, once a month injection. This is also once a month injection. So gene therapy is approved for hemophilia A and B. So that is the advantages. See, once you give one injection of gene therapy, the factor levels are maintained. So at 1 year also the factor levels are maintained up to 50 to 60%. That is that's once you give injection, the patients are responding up to 4 years. And you can see up to actually you have 208 weeks. The levels are increased very, very high in the initial 1 year, and it's reduced, but it's stable at this point of time. And this is the same thing which has been mentioned. The patients on gene therapy had a significant reduction in the bleeding. And this hemophilia B, again, the gene therapy, I can see the factor level has increased. Normally, they will have less than 1%. When you give gene therapy, the factor level has increased up to 40% and is stable at 26%. So here, the month 4, month 5, month 6, and up to 4 years they have done, the levels are maintained at 26% with the gene therapy. But the cost, this is the cost of gene therapy, $3.5 million. So this is not possible for our patient unless we have something like Make in India product. So I always tell patients, don't worry about gene therapy. We have got lot of other molecules. When you get once a month injection, you have got zero bleeding rate is 90%. So that is also enough for us to actually, rather than dreaming for gene therapy. It's not a curative, but as of now, the data is available for up to 4 to 5 years, where the patient level factor levels are maintained. Both hemophilia A and hemophilia B, gene therapy is approved. Hemophilia A, the gene therapy was approved about 3 months back. Hemophilia B, the gene therapy was approved last year. So now it's available in the US, but India it's not available. US it's available for the treatment options. So initially what we had is only factor VIII, multiple times patient had a peak level, trough levels. So they used to have a better life, again bleed. So that is a factor VIII levels, and with extended half-life factors, the patient had levels were high, good levels, factor VIII was there. And with non-factor therapies, the levels are much, much higher. So when you are on emicizumab, the levels almost reaches to 15 to 20%. And when you are gene therapy, the levels are much, much better, almost more than 20%. So we are moving towards the lot of peaks and troughs to constant stable levels. And here is almost like one injection with almost to the tune of 4 years. The patient is not requiring any new treatment. So that is the advantage of newer molecules in hemophilia patients. So to summarize, treatment of hemophilia has shown a lot of recent advances in the last decade, but still prophylaxis is the only treatment option which can change the natural history. So in that, maybe new molecules can be used as a prophylaxis. Extended half-life factors will increase the half-life by 4 to 5 times. And zero bleeding is reality now. When I told in the first lecture, zero bleeding was a dream. Now it's a reality. So you can still patients can have zero bleeding through the newer therapies, rebalancing therapies like fluticasone or ecosumab are reality now, and it can be used in some of our patients. When it's maybe in next 1 or 2 years, it's going to come in India also, and it might get approved from Indian Drug Control General of India also. And gene therapy is approved for hemophilia A and B. The cost is very, very high. We cannot afford it. So in the next decade, we'll have multiple molecules. We have got a second generation monoclonal antibody called MIM8. The almost phase 3 clinical trial going on in India also. Maybe in 2025, that drug also is going to get approved. So it's the future of hemophilia is very bright with many, many new molecules in the pipeline. Thank you, and happy to answer any questions.
Thank you very much, ma'am. Very nice talk on the recent advances in management of hemophilia. It's a really an eye-opener from the new extended half-life products to rebalancing therapy to the various new drugs. The one thing just I want to know, the concizumab, and this is available in Mumbai?
No, it's not available in Mumbai. It is actually recently got approved for US FDA. India, it's still not approved. They have presented the data. It's not available actually. It was available as a clinical trial. Some of the patients on clinical trial.
Because there were studies, no? It was from the clinical trial.
Clinical trial. So clinical trial as well, but it's the only molecule which has got very less of life, but it's not available yet.
So what is the cost of this extended half-life?
Extended half-life factors is now the plasma-derived the recombinant factors cost about 6 to 10 rupees per unit. Extended half-life factors depending on if factor 8 or factor 9. If it's factor 8, the tender rate in some of the states is almost about 16 to 20 rupees per unit.
Okay.
But factor 9 is little costlier actually. Factor 9 half-life is very, very extended actually. So it's about 500 units cost about 50,000 rupees.
But it's available in market.
Yeah, it's available. Factor 8 extended half-life is 2 molecules are available. That's called adenovate. And the second one is called the Novo Nordisk. Novo 8 extended half-life factor is available. Esperoct is available. And factor 9 extended half-life factor is called Rifixia. So it's also available in the market.
What about the PEG combination?
Pegylated molecule. Pegylated one is available through Hemophilia Federation of India. WFH is giving us pegylated is this one. What I told you, Novo Nordisk is pegylated. Rifixia and Esperoct is pegylated molecules.
Okay.
It's pegylated. We have got FC fusion molecules, which is through WFH donation. FC fusion molecules. So there are we don't have that market. FC fusion molecules are not marketed in India. Only pegylated molecules are marketed in India.
But soon in near future, we will have all these drugs.
Yes. See,
It's a new
new-
ray of hope of ray.
CME was launched in India almost about 5 years back. 2015 it was launched. No? So in the Indian market is a boom. So a lot of new molecules are launched simultaneously to US and India. Maybe few months delay, but it's not delayed. Like in the past, they used to delay it for years, but don't delay because highest number of hemophilia patients are there in India.
Thank you very much.
Yeah.
Any questions from the audience?
Thank you, sir. Thank you, ma'am. Now I request Dr. Pradeep Pazare, sir, to felicitate Chandrakala ma'am by a token. Now, moving forward, the next topic for today's session is dental management in patients with hemophilia and allied bleeding disorder by Nanda Pai. And I would like to call Dr. Shinoy, sir, to chair this session. Yes. Project. So that is the mic. So there is the mic.
Good afternoon. It's a pleasure to have been invited for this CME on hemophilia. And more interesting and important is that our colleague, our fellow maxillofacial surgeon, who's a very popular person in our fraternity, and someone
Not as popular as you, Rama.
Thank you so much. But we know Dr. Nanda Pai in our fraternity, who does wonderful work, and she's going to tell us about how to manage hemophilia and allied bleeding disorders with special reference to the dental management. This is a problem that we always keep referring the patients either to pediatrics or to the medicine department to get a clearance from them. And there's just something that I want to put forth amongst all the medical people over here. There is a little dichotomy about what has to be done, not just hemophilia, but certain patients with bleeding disorders, about what exact the protocol that has to be followed.
Yes.
And I'm sure that Dr. Nanda Pai is going to deal with it in great detail, and we'll all benefit from that. So the stage is yours, Dr. Nanda.
Yeah. Thank you, Dr. Rama, for those kind words. Good afternoon, everybody. I'm going to speak on dental management in patients with hemophilia and allied bleeding disorders. Dental problems for a hemophiliac are of the least concern because they have so many other problems in the body, the joints and all, I can understand. 10 years down the line, when I started managing these patients, they just would refuse treatment. They would just come, take care of the bleeding part and walk off. But when I started in 2012, that was the case. We are in 2023. And now they ask for treatment. They ask for aesthetic treatment. They ask for replacement of teeth. And I just have to tell them the treatment and they agree to it. In the department now, this may be good. This may be true. I can understand what Rama is saying because you guys work in a dental college. There are a lot of other departments. Whereas I work in a dentistry department in a medical college. So what the hematologist does is just refers the patient to dental department. The patient comes to me seeking me. And I'm known as the hemophilia madam there. So they just come to the OPD, hemophilia madam kidhar hai, and it's pointed to me. Then I decide, the course, whether she needs extraction or needs a root canal or whatever. So that's me. I'm an oral and maxillofacial surgeon from Nair Hospital Dental College. Currently, I'm professor and head Department of Dentistry, KEM Hospital. This is KEM Hospital, 1926 ka building hai, heritage building. But my department is newly renovated since the last 2 years. It looks very nice, a very nice place to work. We have music running and all. I'm saying this because once the patient enters here, half his mind is, he's looking around and the pain is taken care of. And so does the hemophilia patient. This started in 2012. Not that I was not treating patients of hemophilia before 2012, but this changed my outlook towards management of these kind of patients. This patient had come at about 3 o'clock in the afternoon with a huge clot, referred from Nasik. All the way he had traveled from Nasik for 5 hours. Sorry, I don't have a photograph of that huge clot in the mouth. It was very scary. Those days, we would not take so many photographs. Now, moment patient walks in, the residents are first with the phone rather than looking at the patient. So I don't have that. But this was a life-changing experience for me because the patient's father just touched my feet and told me, Madam, isko bachao, mere bete ko bachao. So then that got me thinking, how am I the one to save the child? But what happens in government colleges, 3 o'clock, everything starts shutting down. And the mamas and all, to move them, it's very difficult. But somehow I got him admitted, and after about 10 days, I think it was Ganpati time. And we managed to, his hemoglobin had gone down quite low, but we managed to treat him. That's him now. A month back, he's come back again. He keeps in touch with me. That is the bond that we have with these kind of patients. He said, I have finished my ITI course. I'm doing well, ma'am. He touched my feet, seeking my blessings. So this is the start, 2012. A lot of theory has been done on hemophilias. I'm not getting there. Dental bleeding we see very commonly. As a dental surgeon, we can be the one to diagnose this disease many a times. We are doing a study on that, on the patient's oral hygiene status in the kids, and 30-40% of times hemophilia has been diagnosed when the patient is shedding his primary teeth. So KEM statistics, there are about 1,300 odd patients, and me in my department, I have done about 500 to 520 patients. These are the patients I'm talking about. Treatment, every patient over a period of his life comes to me at least 5, 6, 10 times, maybe every time he loses a tooth, he's there. So my patient numbers would have gone up to 1,000. And other rare diseases also we have seen. Glanzmann's thrombosthenia, I've seen 4 cases so far. The oldest case that I've treated is 73 years old, the youngest being 1 month. And inhibitor positive patients, we have treated about 34. Patients are referred from all over India, mostly from all districts of Maharashtra. This slide I've put in because this disease is not only prevalent in the lower strata of society, but we have a lot of doctors, dentists, politicians, lawyers who come and visit us. And they have been refused treatment even in the private, even in the 5-star kind of hospitals, and they come to us for treatment. So this is what I would typically see. This is the kind of patient that would walk into my OPD. When a mother or a parent sees something like that, a large clot, blood oozing out, it is a very scary sight for any parent. So what would I do when a patient comes? So there are 2 types of treatment. I first take care of control the bleeding, and then I would think of what is the cause. So how would I control? We would first clean the area with a wet gauze, and I typically dip that gauze in whatever local anesthetic that we use, 1 in 2 lakh with adrenaline and an antifibrinolytic agent like a tranexamic acid or epsilon aminocryptonic acid. Pack it, keep it for 15 minutes, make the patient sit out, recheck. Meanwhile, he applies ice, give him a few instructions, and then send him off to the hematologist. This is what I would commonly use. And then I would think about what else to do. From just about managing the bleeding, we have now gone into other therapies, oral prophylaxis. We do a lot of single sitting root canals now. We take up the pediatric patients under GA. We have got a fantastic pediatric anesthetic team who takes care of them so well. So now I have got a full-fledged department looking only at hemophilia patients. There is a proper protocol that we have found now. Initially, it was all haphazard. Now, once the patient walks in, we know exactly what to do. patient is checked up, we always advise dental OPG. Once the OPG is advised, the plan is ready as to what you have to do for the patient. Not that once the patient is on the chair, then you decide what needs to be done. Once we decide the plan, we send it to the hematology department. They do their test, especially the inhibitor test. Then we give a proper appointment. We tell the hematologist that we are going to treat this patient so and so date. Pre-op factor is always most of the time given. Procedure is done. We always use vicryl sutures. We keep the patient waiting for an hour, check for post-op bleeding. If there is no bleeding, the patient goes home. Otherwise, he's sent back to hematology. He waits there in daycare. If post-op is required, factor replacement is given. If bleeding is too much, of course, he's admitted. For me, follow-up is very, very important. If the patient bleeds, he comes back the next day, or he comes back after 3-4 days, and he's given a number. He's given the dental OPD number. He has to call. If he doesn't call, believe you me, I call up the patient and we record all the photos and tell them that it will be used for educational purposes. These are the drugs. For pain, I just use paracetamol or etorecoxib. The others I have not much experience with. So now this is the new thing that I've started. After every surgical extraction, I would start a PCM drip right there on the chair. This is a new thing that we started, helps the patient a lot. Of course, factor replacement, Dr. Chandrakala has spoken a lot about it. This is, you know how to calculate the dose. The doses are calculated by the hematologist. The best part is I don't interfere in their treatment and they don't interfere in our treatment. So that boundaries we've got, she tells me what to do, how much factor to give. And when I tell her he will need a post-op factor, they give it. FIBA is mostly used for inhibitor positive patients. Patients on prophylaxis, a lot has been said about prophylaxis. Two things I would like to say here is, when I do the extraction in patients on prophylaxis, I find them absolutely normal. She said the patient, zero bleeding, yeah, as close to zero bleeding. And we schedule the treatment or the surgery on the day of prophylaxis. So the dosage, you don't miss the factor. This is the comprehensive care. Let's start with my cases now. This is what I would commonly see. A child, a 9-11-year-old child who's losing his primary dentition, large clot. Either you apply jelly or I would infiltrate that area, remove the clot, remove the tooth. And now I've started using what is known as Tisil fibrin glue, very commonly used. It is available in our stores readily. And I would use that. And the next day you can see that there is wonderful hemostasis achieved. You can see the erupting tooth there. Case 2, this is again routinely done in the department. These are routine cases that I see almost alternate days. Third molar extraction. The third molar has dug into the second molar. So that tooth, the endodontist treats with root canal. I would do the surgery. We use Surgicel, pack every socket with Surgicel, and we use horizontal mattress sutures. And of course, that PCM drip is always given. And this is the protocol that the hematologist department on the left side, hematology would send me something like that. What to give on the day of the surgery, what to give the second day if there is bleeding, and so on and so forth. For 5 days protocol, they have written, beautifully written and given it to me. Third case is a trauma case, a large clot seen. Once I remove the clot, there is a small CLW. That is what is missed by the patient. This CLW, had he put a pack there, wouldn't have caused such a big clot. They missed that. And then we have sutured that, and there was a fracture. Ideally, this would have required extraction of that canine. But knowing that it's a hemophilia patient, we weigh the pros and cons. Should he go in for an extensive surgery? No, so we just put a splint to the teeth, and he has healed beautifully well, and this is 5 years down the line. This patient was referred to us from Buldana, hemophilia A, inhibitor positive, epileptic. He had a fall, he slit his tongue. He was admitted with us for about 25 days. We had to go in and suture and resuture and use Tisil and use cautery. But finally, after a lot of FIBA, and so what I mean to say is the treatment and the care requires a lot of patience. a lot of follow-up with the patient. You can't be impatient with these patients and need to do what needs to be done. So finally, he went back, and he's the one who regularly calls us up to. Case 5, this engineering student was beaten up for some, there was a family feud. So between the father and his brother or something like that. So the son was caught up in that. He was beaten up very badly. His floor of the mouth had a huge hematoma. He was going into Ludwig's. In fact, he was on border of Ludwig's. His tongue was raised, slurred speech, difficulty in swallowing. We waited for about 5 to 6 days. He was treated with a lot of factor replacements. And then he had a fracture right condyle and a parasymphysis. So here, if it was a normal patient, I would have simply opened up that area, plated the tooth, plated the mandible. But considering it's hemophilia, patient did not consent, of course. And I think something which can be managed conservatively, especially in these medically compromised patients, medico-legal cases, I think should be managed conservatively. So he couldn't occlude his teeth. Then we put him on arch bars, got him elastic tractions, and that's him with a perfect occlusion. Again, medico-legal case, boy beaten up, mobile central incisors, fix him up, and he's on prophylaxis. So whenever he comes on prophylaxis, he follows up with us. Pseudotumors. Pseudotumors are very common in the long bones, not so much in the mandible. We have seen about 3 cases as of now. This case, 9-year-old boy was hit by a cricket ball. You know, cricket is a crazy sport in India. And we had posted him for curettage actually, but he's a Muslim. It was Ramzan time. He refused any surgical intervention. They took discharge again, medical advice, went back home. But this swelling was increasing. The mother comes back and begs us, Madam, kuch karo, kuch karo. So we and Chandrakala, we spoke about it, and we started him on factor replacement therapy twice a week for about 7 months. And he healed up so beautifully. All his teeth started straightening up, and now he's doing very well. So actually it was a blessing in disguise. Another case that we have, he's also healed well, not so well. He is inhibitor positive, and he is on emicizumab now. This we have published. We do this is a cyst in the anterior maxilla. She is a receptionist in a hotel. So she wanted to look very good. She needs to smile a lot. We curated the cyst, packed it with bone powder, and we gave her a nice smile also. We do a lot of these scalings. My residents do that. These things can really bleed, but if they are done well with factor replacements, they heal very well. This is a case of factor 1 deficiency, very, very rare. Again, we've used TISIL. So I use a lot of TISIL nowadays. We are doing a study on that. I've submitted it to the EC, and we've just finished analyzing it. The results are very, very positive in this. What do I do for spontaneous bleeds? I suture them. Only use Vicryl so that I don't have to remove the sutures again, absorbable sutures. Cautery helps me a lot. Very stubborn, spot bleedings. In these cases, I don't even give factor replacements. Frenum, frenum bleeds in small kids, very, very difficult to treat. Use TISIL and it stops. We do this jugaad. If there are 2 patients, then I would use 1 TISIL. It comes with 4 syringes and use it for both the patients because it's very, very expensive. So this is TISIL. It's a fibrin glue. You have to prepare it about 20 minutes before. It can last for about 4 hours. So if I know the patient is coming, I prepare it like that and it is used. Again, as rarest of rare pseudotumor in von Willebrand's disease. She had a fall, and initially the swelling was small. So Dr. Chandrakala had decided that we will treat her with factor replacement. But then I think they did some hot water fomentation. So there was a chance that it would perforate into the oral cavity. So we had to take her up under GA. We did that. There was intraop also massive bleeding. You can see the mental nerve that we have separated. I used Tisil, I used Flosil. We packed the cavity and she took a long time to heal. But afterwards, and we are following her up, she is on emicizumab also now. So this too we have published. We have published a paper on factor 13, which is the problem with dental is there is not much of literature that you can go back and read and treat. So I myself, have done a lot of trial and errors, and now we have got into the habit of nicely doing them in a systematic manner. These are the ongoing researches, of course, that we have. As I said, fibrin sealant use, I've got about 66 patients that I've treated, and we are doing the oral hygiene status in prophylaxis kits. Routinely, Trisil is used for any small trauma, erupting teeth. I have done a Glanzmann's, and the Baxter company had given me something to use, Flosil, again for severe bleeding, very good to use. It is pre-mixed, you don't have to mix this. So, are there any problems? Yes, lot of problems. Lack of manpower. Hemophilia is not the only thing I do. I am HOD, so the lot of admin issues. Another problem that I have is the distance between hematology and my department is about 20 minutes. So I lose that much of time. By the time the patient goes there, registers, take the factor, and it is best that you take the factor and start the treatment immediately. So what we have done now is we've these patients on prophylaxis, the father is giving, and we immediately start the treatment. And platelets also, we have just started this last week. We have done these two things. I think this is working very well for me. So we are just, wherever we can, we'll replace the factor in the department itself on the chair. This I have put because this is the cost that we incur per patient if he is inhibitor positive. So whatever treatment we do, we better do it, perfectly. So is everything so easy? Factor dalo, daat nikalo, and everything is fine? No. Even after 10 to 12 years of treatment, I have treated a case a month back, maybe not a month, 3 months back, which was a nightmare. A simple tooth extraction, very simple. I finished the extract. It was if you can see the upper right, it was a root piece. It came out in 5 minutes. In fact, the patient even told me, "Madam, ho gaya, kuch pata hi nahi chala." That time, that struck a bell ki isko kuch hone wala hai abhi. And third day, he comes with a huge swelling. He opens his mouth and there is no active bleeding, but the blood is just gone through all the spaces. Okay, maxilla, I can understand. It has gone over the buccinator and it has come into the mandible. Not only that, it has gone into his infraorbital space, it has gone into his supraorbital space, and it has gone into his conjunctiva. That is when, I called up Chandrakala. I said, "What's happening?" She said, "Let's give him Novo 7. And, everything, thank God, everything healed up. So we do land up into problems. All is not rosy, always. And this fellow comes back to me last week and he tells me, "Madam, abhi sab acha hai, I want to replace the tooth." I said, "No way, I'm not touching you again." So this is the Akshada's sister. I have to thank her. She is my point of contact between hematology department and dentistry department. Many a times I don't get Chandrakala. I understand she's very, very busy. So are the residents. Everybody is so busy. I have to just pick up the phone. She knows which patient is coming. I pick up, she said, "Madam, Ashraf hai to na?" She knows already Ashraf is coming. I tell her all that, you break the line, take him. So she is a boon to the department. My team, I have newly got a very young pedodontist, Dr. Bhagyashree Deshmukh. We take up all our pediatric cases under anesthesia now. These are emergency, and we can also do beautiful aesthetic work now. This is Dr. Shenoy. She is an endodontist. Single sitting root canals we have started. From extractions, we have now gone to saving the tooth. We use rubber dams. For those who don't know what root canal is, we put those files. This can be extremely traumatic, sometimes can cause hematomas. That's why we always do these procedures also under factor cover. 40% correction is done for these patients. I've put some of my instruments. Every dental instrument can cause trauma to the patient. Simple examination. You use the probe, it can just bleed. All our drills, fast moving drills, everything, you should know how to use them, how slowly to do, be as atraumatic as possible. Suction tips, scalar tips, everything can be a risk to the patient. So this class of patients, finally, I would say, are much neglected. We should have more centers who dedicate dental care to these patients. It is their right. It is their right to have good quality of life, because the mouth is the gateway to good nutrition. We teach them all about oral hygiene, especially the kids on prophylaxis. We have seen marked improvement. We have our residents doing that with the brush and the models. Their hygiene has really improved. So the efforts have paid off. We tell them about mouthwashes. It's all about teamwork within our faculty. This is when the World Federation of Hemophilia visited KEM, especially visited my department, my staff. We are forming guidelines for dental care now. I was part of it. Masterclass was held in AIMS Delhi. I always make it a point to visit the Hemophilia Day celebration on the 17th, give them a small talk there. KEM is, I think, only the second institute to have this multidisciplinary approach. We had an opening for that. We were all there. I have to thank my staff, my residents, the pediatric surgeons, and of course, Dr. Chandrakala. She is always there. Whenever I call her, she'll say, "Aap karo, hum log hai." This is my team, a team of young doctors. And if you see, it is mainly women there. It's all about women power. I have to, my non-teaching staff, I don't know, somehow all the hemophilia patients turn up at 3:30 when they are about to close the department. But when I say hemophilia patient, all reopen all the boxes, so that is the instruction given to them. I'm very, very passionate about treating this class of patient. I have a lot of empathy. They need empathy. And that is why, that is what I have. We have done Christmas celebrations. So what is a take-home message? That the treatment plan should always be ready. Work with the hematologist. I think our egos will not work. So that is what I was telling, that I, being in the Department of Dentistry, patient is referred to me. If it is referred to a dental college, we have seen the patient keeps roaming around the whole day. He goes from examination, then if it is pediatrics, then would pediatrics do it or would endo do it? And, so I think that is why maybe we are successful in treating so many patients. Always schedule the procedure in the first half so we can do the follow-up in the second half. Be as traumatic. They say don't give blocks. I cannot avoid nerve blocks. What I can do is I use a very fine needle, 27 gauge, and just give a single prick. Be very gentle. Use all these. Fibrin sealant has been a real boon for me. Horizontal mattress sutures. Follow-ups are a must. And be empathetic to them. Thank you so much.
Thank you, Nanda, for a wonderful talk. It was extremely informative, and believe me,
Really?
I've never seen so many cases in my life like what you shown. Even in my own unit over here, we don't get a lot of cases of hemophilia, but we get patients with those who are on aspirin or warfarin or something. So I'm sure that we are better prepared in in case if we get such cases. And as rightly you said, they come at 3. They don't come at 3. They come on a Saturday night or a Sunday morning when nothing is there.
I have myself gone and treated patient on holidays.
Yes.
On 26 Jan, 5 o'clock, I get a call and I was, my God, ek din chutti milta hai. But if you care for these patients, you have to do that. The problem with me is I have no help.
Yeah,
and
I can understand. One in your last slide, what I noticed is you have written 40%, 60%, and 100% depending on the
type of treatment.
Now, in which case would you apply 40%?
40% for single sitting root canals. Many a times they say root canals you don't need, but somehow I wouldn't take that risk. So even if it is a root canal, Swati would do it, my endodontist. But so that is the protocol. When I tell them surgery, it is 100%.
Even for extractions?
No, when I say surgical extractions or cysts.
Suppose just routine extraction.
Routine extraction, 40 is enough.
40.
Yeah, 40, 60. Yes,
Okay.
yeah, that I forgot to mention. Everybody post-op after 12 hours we start, right? We start on tranexamic acid. So that's antibiotic, tranexamic acid, Dolo 650 is the thing.
That Mohammedan patient you showed
Mhm.
ballooned up.
Ballooned up.
Could it be a case of,
Could be, Ram. Yeah.
pterygoid plexus? I mean, because, I had
We've
one
seen that.
case
Mhm.
who was a,
There was not a drop in the mouth. Not a drop. Inhibitor positive, yeah. But he is, I would, Muslim patients, and he was little aggressive next day,
Yeah,
third,
you should
fourth
have.
day. He came, madam, kya hua? And now he's telling me, मुझे दांत बिठाना है. I said, आपका दांत मुझे बहुत भारी पड़ गया. बहुत expensive.
So, no, what usually happens is that I get a lot of cases from cardiac hospitals close by, not hemophilia patient. So invariably, see, there is a chance that you might
Maybe.
damage the pterygoid
I
plexus.
may be gone with the needle, you mean? I would have
Yeah,
gone
that could
deeper.
be.
But I usually aspirate. Maybe I am looking for answers. Really, I don't know what happened with
See,
him.
you're a dental unit in a medical college.
Yeah.
We have other departments too, and usually what happens is that in a patient, there's just, just for knowledge sake, some department they give a PSA block and the patient comes to oral surgery. 7 days later, like that patient with the the ecchymosis that you see, and then the patient's relatives they get why they kya kar diya aapne?
Maybe in the conference we can have it open to discussion. It is. I really don't know what happened. I don't know why it has gone into the anterior mandible.
Maybe it's just kind of
Finding
because of gravity it finds its way into the tissue planes.
that I've never seen.
That could be one of the reasons. I
And
mean,
it
that
was-
is because there's no other explanation.
It's gone into the eye. It's gone into the conjunctiva. Finally, in
Yeah.
but I can
Very-
understand.
Very dangerous looking thing.
It is, and every day, I used to wait कि आज क्या लेके आता है, and invariably he would walk in 1 o'clock.
32 years back, we had a case of a 1 milligram pseudotumor, and at that time we were just groping in the dark.
Absolutely, even now.
Absolutely. I mean, I just don't know what happened to the patient when I was a resident, and we used to. Now, I donated blood at that time.
You should have Chandrakala.
Yeah, I know. So what happened is that I happened to donate blood. The patient was operated for this pseudotumor. In the evening, he bled. He was taken up for re-exploration.
They just won't
The
stop.
next morning, since I was the only resident on duty, I bled myself, got the blood because at that time,
Yeah.
only the HOD.
Difficult.
Well, if that helped to prevent HIV or whatever. So I have given that fresh blood. The only other fresher blood that I could remember was in Amar Akbar Anthony. So this was the only case, it can't be fresher than that. Anyway, excellent presentation.
Really. Thank you so much.
Question?
Yeah.
Any other question? Actually, as you're aware, we are going to have a CME here.
Yes.
On Sunday. So most of my unit people are working.
Yeah,
on-
busy there. I
So
understand.
I'm sorry they could not join.
No problem. Thank you. Thanks for having me.
Thank you so much.
Thank you, ma'am, for the superb lecture. I request Dr. Shenoy, sir, to felicitate ma'am with a memento. Next, I would like to invite Dr. Shwetal Pawar, ma'am, for her talk on role of radiation synovectomy for hemophilic arthropathy. The chairperson for this session is Dr. Anju Kadu.
Good evening. With this, we are coming to a very important talk which would be delivered by Shwetal ma'am. She's an associate professor in charge of Department of Nuclear Medicine from St. GS Medical College in KM Hospital, Mumbai.
She's had, to her credit, the Fellowship of Pediatric Nuclear Medicine, ICH, UCL and UK. As we have already spoken about synovectomy in Sir's talk, Mohanty Sir's talk, and Madam would be elaborating on the radioactive aspects, and she'll be guiding us through this important topic. Over to you, Madam.
Well, thank you for the kind introduction, and I thank the SKP Essence and the Lata Mangeshkar Hospital, NKPC, and the Lata Mangeshkar, and also the local, Hemophilia Society. Well, I have been part of the hemophilia care since 2015. So, whenever there is possibility of local treatment for a joint arthropathy, so where there is a role of nuclear medicine, wherein we are using the radioactive materials. Now, how are these radioactive materials being used is the question. So there is a lot of fear amongst everybody when we talk about radioactive materials as to how are we going to, use this radioactive material. Is it safe for human use? If we are going to inject it into the joint, what are the complications? What is the radiation hazard? Because there is a lot of misunderstanding and rather more of propagation and radiation related issues to be propagated. Propagation is more important. So I think even if it is a very smaller procedure, very simple procedure, which can be done using again a multidisciplinary approach. So we will look at exact indications. How are we going to work that out and logistically? Because if this has to be a twinning experience and it has to be replicated here, how would that be logistically worked out? I think that is more important for you people to know as to how will that work out. When we know that there are various options for synovectomies, operative, steroids, chemical synovectomy, and obviously the radiation synovectomy. I think Dr. Mohanty has already explained quite well about chemical synovectomy, and I see that Dr. Kadu has already done a few cases. But I think because of the scarcity of availability of these multiple injections, radiation synovectomy has helped better. Now, how would that work out better? I will be sharing my experience. The only hitch since we started this program in 2015, there was a gap of about 3-4 years because we did not have availability of radioactive material. Okay, the main use the article or the substance that we're going to use for the intra-articular injection was not available. But since last 3 years, it is produced in India. It is available from our own BARC's subsidiary or institute, which is called as BRIT. So there are two types of such chemicals or radioactive pharmaceutical is the right word I would say are available now, which can very well be used. They are available all across the country. It's just that you need to be aware of it. You need to have those setups and then you can actually go ahead with it. So radiation synovectomy is something how this would look like. So, this is a knee joint where the radioactive material is injected and an image is taken using a gamma camera. Okay. Now, what we do is, in addition to that, we do a CT scan so that exactly we are able to map out how is the distribution of the radioactive material within the joint. Now, this is very, very important because it is going to give us the follow-up and the effectivity of this treatment. If the patient is going to come back saying that I did not have a good effect of it. So we go back and we look at the distribution. If there is a very well distribution within the joint space, joint cavity, we are expecting towards a better result. Okay. So we have learned our own way as to which are the patients which are to be selected better, which are the patients where you can give better prognosis. And in our experience, we have treated as young as even a child of 8 years. So we have even injected into a pediatric patient of almost 8 years of age. So now we have categorized, we have SOPs, we have right, identification of radiopharmaceutical and even patient selection. So let's see how are we going to know about all this. So let's start with the basic concept. How does this work? So now that we are going to talk about radiation synovectomy is a localized radiation using intraarticular injection of radioactive material which emits beta radiation. Okay, now when we go back to our physics knowledge, we know that there was alpha, beta, gamma. Okay, so alpha has got a very shortest path length and it has got a very high impact. Beta will travel a few millimeters of distance and it will have a local radiation deposition which will directly lead to a cell killing. So in this entire process, there are two ways of mechanism of action. So the first one is a direct cell killing by the beta radiation. And the second one is there is formation of free radicals. Okay, so they keep on having, eliciting an inflammatory process. And then there is which continues for a few weeks or other, months. And then there is eventually fibrosis. So there is a double-edged sword, which is, trying to kill or trying to reduce or impact the thickened synovium. So there is deposition of this radioactive material. So the star, representative models are the radioactive materials which gets absorbed onto the thickened synovial inner lining. So where they will sit, they will irradiate by emitting beta particles, and also eventually it will lead to direct cell killing and overall fibrosis. So over the years or over the time, there is fibrosis of this thickened synovium. So even if it is, not most of the time, even it is seen on MRI, but even if it is not seen functionally, there is fibrosis which leads to less of repeated cycle of bleeding. So this is what we are looking at. So the current radiopharmaceuticals which are available with us, so these names might be a little difficult for you to know, but these are all products available, made in India, available in India. So there is a cyclical way how it is available. Okay, so if somebody has to technically manage these things, so these are available from Bhabha Atomic Research Center, our own central government agency, which are available once a month. So each of these is available once a month. So what we do is we club the patients. Okay, and we club the patients so that we make it even financially viable for them, and it is easy for for logistic wise also for us to give those injections, because these injections are given intra-articularly in a very aseptic, considering all the aseptic precautions. So technically we are actually converting, these injections are given in nuclear medicine department. Because why we are giving it nuclear medicine department? Because the radioactive related safety procedures can be followed up. There is a complete immediate scanning possible since we have machines within the department, and then the patients can be mobilized to the wards. There is no need to technically admit these patients. Okay, the only reason why we are admitting the patients is because they are covered up with the factors after 12 hours. Okay, all these patients come from everywhere across the India. So to pull them, to give them that factor, to observe them, and also when they are discharged back, they are given a protocol of mobilization by the occupational therapist. And that is why the patients are kept. Otherwise, it is a OPD procedure. Okay, so it can very well be done. If you do not have a nuclear medicine department within your hospital, it can be done. You can have a collaboration with, I can give you a department. I took out a department list of nuclear medicine even in Nagpur. So if somebody is interested who can give it, you can do all the procedure there in the department. Scanning can be done. The patient, if you want to, if they are local, they can go back home. If they are fine, you can bring them to a hospital and, keep them. Only precaution is in the post-procedure, the joint has to be immobilized minimum for 24 to 48 hours. This is to avoid the seepage of the isotope out of the joint, and then there is a good localization of that particular isotope within the joint cavity, and that's the reason we are immobilizing. The other advantage of doing this is that we are treating 2-3 joints of the same patients in the same sitting. So the same factor which is utilized can be utilized for treating 3 joints, 2 joints. So there is a very good utilization of the factor also, deficient factor, which is given to the patient before the procedure and also after the procedure. So just to tell you in brief, this is yttrium 90 hydroxyapatite. The first one is P32 related colloid, phosphate colloid, and the last one is a lutetium 177 hydroxyapatite. So these are colloidal particles which do not, once injected intra-articularly, do not seep out of the joint because they are colloidal. they will remain within the joint. We have not seen a single episode or single patient where it has gone outside of the joint and has irradiated or given radiation to the other organs. So, they're completely safe. They do not have any radiation hazard to the patients or the relatives or other people in and around, because beta particle only travels few millimeter, which is sufficient for the thickened synovium to be irradiated, and it will not have radiation effect in the people around, or that's a fear. It's a fear. It's a very genuine fear for others who are treating, or patients around it, or relatives around the patient. So it is absolutely safe. Now, when are the patients where you do not want to do it? Okay, obviously pregnancy, breastfeeding, if it is a female, if there is a local infection, obviously it is strictly no. And if there are any signs that the isotope might seep out of the joint. So if there is any rupture structure like a Baker's cyst or any other, intra-articular connection, which is likely to cause leakage of the radiopharmaceutical, it is strict no. Relative is obviously if there is a lot of extensive joint instability with bone destruction, there is a lot of cartilage loss, and obviously it is not a good patient, because it will definitely not have a good effect of the radiation synovectomy. Now, as we are approaching these radiation synovectomy procedures, in which patients will it really help? So we know that patients who are chronically bleeding. Now, how do we decide this? So the patients who are repeatedly bleeding with minimum of 3 episodes in last 6 months are the one that we are classifying it as chronically bleeding. And these are the patients whom we are selecting for synovectomy. You have to select a joint for which you have to demonstrate that there is a thickened synovium. So we are doing either ultrasound, but MRI is always better because it gives a lot of additional information with respect to cartilage, underlying bone, and even this synovial status. So the exact pouch-wise, clearly thickness of the synovium has to be demonstrated, because the synovium thickness with more than 2 to 3 millimeter is the right patient wherein you can consider giving them radiation synovectomy, because if it is lesser than that, obviously the radiation will go to the underlying cartilage and it will not be needed. It will not be so effective. So to ablate, we need to have minimum thickness of the synovium of about 2 to 3 millimeter minimum, which will have a good effect in these particular patients. It is better to give in patients in early synovial arthrosis patients, because if it is very advanced arthritis, obviously the joint space is reduced, the joints are very dry, it will not even spread in the entire joint, and it will not even have an adequate effect because the joint is already significantly distracted. So early patients or mild or moderate, synovial arthropathy is the right time where you can consider these patients for synovectomy. Now, which radiopharmaceutical? For larger joints, we are using yttrium because obviously it is a strong beta particle with a strong energy, and so the joints like knee and even for shoulder, we are considering it for yttrium. And lutetium is a soft beta. It is used for all pediatric patients' knee joints and all other medium-sized joints. Pre-investigation, obviously, the factor level and the inhibitor status has to be mandatorily done in addition to other investigations, because obviously the cover of the factor or the inhibitor is to be considered. Now, performing a procedure is what we are doing is it has to be done in a very nicely technically expert hand, because the radiopharmaceutical localization within the joint is the most important thing. If it is, if there is leakage or deposition of the pharmaceutical along the track, there will be radiation necrosis, there will be infection. So technically it has to be done in a very good hand. So right now here in our setup, it has been injected by the orthopedic surgeon, because a lot of times the approach towards the joint, knee joint is still easy to inject, but sometimes, in a full, joint that has got some deformity, arthropathy, sometimes the approach has to be modified. So that modification is done best with the hands, in the expert hands. That is the reason orthopedic surgeon is the right person to inject these. These are, done in the nuclear medicine department without any ultrasound guidance. So since these are experts, they know how to inject. So the injection is very, very crucial. And the deposition of this radiopharmaceutical along the injection tract has to be avoided. So the technique is taught to the, orthopedic surgeon in a nice way, so that there is no seepage outside the joint. And the follow-up is very, very important. Why? Because A lot of times patients have a myth that once I have taken injection, my bleeding will be stopped immediately. No. Since it is a radiation involved, it will cause a radiation-induced synovitis in the initial first few weeks. So in the first few weeks, there are high chances of these patients having bleeding because the radiation itself is inducing an additional inflammation in addition to the bleeding that the patient has. So in the first, so we very strictly give a very standing instruction to the patient that in the first 2 to 3 months, they are likely to have bleeds. Okay. So they are supposed to give compressions or report it to the nearest hemophilia care center so that if required, they are given factors. Otherwise, the response assessment of the joint is actually done at end of 6 months because we want even the inflammatory process to completely settle down and then only the assessment is done. The number of injections of radioactive material, so far we have only injected once in every joint and we have seen a very good result. But at the max, 2 injections can be given in particular one joint for that particular patient. Whereas when we talk about chemical synovectomy, we have to give at least 6 injections to have an optimum effect, whereas here only 1 injection is enough. Now, when we are talking about the cost of these radiopharmaceuticals, so the yttrium will cost about 4,000 per joint and lutetium will cost about 5,000 rupees per joint for the radiopharmaceutical cost. Obviously, if it is in a private setup, there will be some additional cost, but this is the radiopharmaceutical cost. And I think most of the patients are able to afford this cost because it is a single injections, which quite often, if technically done good, will serve the purpose. Now, this is the World Hemophilia Federation's recommendations where, the synovectomy is considered only for the recurrent joint patients and which can be subjected to the radiation synovectomy. It is not considered in the earlier algorithm where other treatments are still being considered with the conservative managements. Now, as I said earlier, that hemophilic arthropathy, this is an arthroscopic view of the knee joint where there is a villous formation of the thickened synovium. So as I have already mentioned, would be just re-emphasizing the same things that you have to select the target joint properly. You have to demonstrate the synovium and obviously avoid high advanced arthropathy patients. Again, for us, it is a team effort because the hematology department is the one who actually is the first and the occupational therapy are the first screening points where they decide which patients are to be selected. Obviously, the factor correction and even all those doses, other inhibitor investigations are also done at that screening level. Orthopedics will also will assess the patient and actually do the procedure. And we are the one who are arranging for the radiopharmaceutical, doing the scannings and, are managing the logistics and also following up. Follow-up is done, I think, by all the departments. So the approaching knee joint is very, very important. As I said, since it is a technically demanding procedure, it is better that it is done in right expert hands. And after which there is splinting and even the scanning of the of this particular joint. Now, this particular patients will have a look at a few images. Where in this particular patient, there is obviously a thickened synovium. Now, there is a protocol that we have MRI wherein particular segmental regions, synovial thickness is measured pre-procedure and post-procedure. So there is a very clear comparison of the thicknesses, which is done in the suprapatellar, infrapatellar, mediolateral, and even in the popliteal region for knee joint. So similarly, there are specific areas decided for every joint. So there is a very clear comparison of these synovial thicknesses. Even the joint entire status is assessed for this particular patient. Like here, there is a thickness of the posterior and anterior, which is measured. And also there is fluid within the joint. Again, while doing a procedure, the joint is aspirated, then the radioactive material is put in. It is even saline is put in so that it spreads. There is initial movement of the joint done so that there is a complete nice spread of the isotope within the joint and then it is splinted. Okay, and with the splint, if obviously there is no metallic thing, we can directly scan with the splint. And only I think for the ankle, they use a splint, which has to be removed for scanning. Otherwise, we are doing CT and there is something called as SPECT, which is a nuclear medicine imaging. So if you see the colorful area is a radiopharmaceutical, which is localized within the joint and the rest of the is the CT scan. So it gives a nice map to us as to how much is the spread of the radiopharmaceutical within the joint cavity. So this is a good spread. This is another joint where we have injected lutetium in the ankle joint, wherein the thicknesses in the anterior and posterior part of the joint is very clearly mapped on the MRI. And you can see a very good spread of the radiopharmaceutical. So this colorful region is the spread. Now there is something called as a technical term, which is a partial volume effect, where there is a lot of isotope at a concentrated position. So it is going out of the joint, but technically it is not going out of the joint. So this is within the joint cavity. Okay, and which is spread within across the entire joint. Now, if we see a very focal 1 point localization, we are sure we understand that this patient may not have an appropriate, effect of this treatment. This is another patient with a shoulder joint where there is a thickness measured in various pockets, and the localization. Now, see here, the localization is more in the subcoracoid region, in the upper part of the shoulder joint. There was no good seepage because the joint space was very, very much reduced. So there are various factors which affect the, the joint status, the injection technique, even the, internal villi formation within the joint of the synovium, which may also, have a restriction of the spread of the radiopharmaceutical. So these are the way that we are making it very clearly sure as to how is the spread of this radiopharmaceutical. This can very well done be in the nuclear medicine department. Those experts know how to scan this. And with the help of the CT, it is even better that we are able to exactly map out the entire joint spread. We used to also do, this, I think Dr. Mohanty has also shown that we used to give RBC scans earlier to exactly demonstrate the synovial synovitis, which is an inflammation which has cleared out in the post-synovectomy status. So these are the few examples which we had done as a pilot project, but I think this is no more now required. We are not doing it. We are only following up them with MRI. Now, this is a patient where there is a post-radiation synovectomy MRI done at 6 months' time. And you can see that the effusion is also reduced, and even there is a clear fibrosis seen at multiple levels, and there is a reduction in the thickness of these single synovium. So even if there is not reduction in the thickness, we have seen that clinically the patient improves significantly. So by way of reduction in the bleeding episodes, there is improvement in the joint function, and obviously there is reduction in the factor requirement. So this was an old paper wherein they had assessed uterine synovectomy, wherein they had actually demonstrated this in all the joints, knees, elbows, and ankles, where there was reduction in the factor requirement, reduction in the bleeding episodes after synovectomy. Now, this is another publication of our own Dr. Mohanty, where he has actually clearly compared the chemical synovectomy with the radiation synovectomy and the surgical synovectomy and the open synovectomy. So it is very clearly said that the radiation synovectomy may be slightly costlier than the chemical synovectomy, but it is definitely well accepted. The infection rate is very, very low. The effects of it are seen very, very good. And that is why it is preferred. That is what was the conclusion of this entire discussion in this particular article. It can very well be, here it is said that for the children you have to be very meticulous. Yes, but since we have availability of lutetium, we are able to even give it in children because it is a soft beta. So we are avoiding any exposure or any radiation to the growth plate or underlying cartilage for these pachus, so that long term they do not have issues. So that availability is also there in India. So with this boon in last 3 years, I think we are able to treat many more patients. So how do we assess the entire response assessment? So there is a significant bleeding reduction to about 78% in our subset of patients. And the reduction is there in the pain, there is improved joint function, and also obviously eventually the reduction in the factor. So this was another patient study elaborating the same thing. But in addition to hemophilia, they had even had other patients which were assessed. But in the hemophilia, how they had assessed the post-treatment, the patients followed up, but done on the clinical improvement by radiology, obviously UAG or MRI, but MRI scores better because obviously you are able to assess the other functions of the joint also. joint mobility. Obviously, the occupational therapy or the physiotherapy department would do that assessment pre and post, will guide them for exercises because that will also strengthen the muscular, function of those particular joints, and obviously reduce the function. So in overall requirement, as I said earlier, that the results that will affect the is obviously how do we select the joint, technique, and we have to assess the response after 6 months. If it quite often patients call us and tell us, नहीं मैडम पहले 2-3 महीने में बहुत bleed हो रहा है, बहुत bleed हो रहा है. But yes, we have to tell them that yes, it is going to bleed because it is undergoing a process of synovitis, which is radiation induced. So the response assessment is always done at 6 months onwards. And in hemophilia, as I said earlier, we have got a very good response of positive response in almost minimum of 79% of the patients. So we have a small take-home message is that we require maximum 2 injections. We have not given 2 injections yet to any patients, but I think CMC Vellore subset had given 2 injections in a few patients. But we have so far seen very good results. We are nearing almost century of our number. We could have actually crossed it, but there was, scarcity of the problem with the availability of the radiopharmaceutical. It is a simple OPD-based procedure, and it can treat multiple joints in one setting with one single dose of factor. So you're saving on a lot of other logistics and cost. The complications are very, very less if you are using a proper technique, and obviously the results are good in all ways. So now if you plan to start a synovectomy, obviously, being a team effort, what you basically need to trap is the nuclear medicine department, which fortunately nowadays there are 6 departments in Nagpur. So, it is right, it is better since the Atomic Energy Regulatory Board has got some laid out requirements for use of radioactive materials. So it is better that it is injected and done in the nuclear medicine department to avoid all those logistical problems. Since it is an OPD procedure, it can very well be mobilizing patients wouldn't be a problem. Only thing is factor where you would like to give that, logistically you can work out. But if it is planned, thought and visioned, it is not a difficult procedure to achieve or difficult technique to achieve. So this is a very good treatment options for a localized single joint treatment and will work wonder. Thank you.
Thank you so much, ma'am. Since actually, when I had witnessed the radioactive synovectomy in CMC, they were talking about giving steroids into the joint post-procedure.
We don't.
So is it still recommended?
No. We are not giving. We had thought in the beginning when we started, but we are not giving. Rather, giving factor is a better, factor coverage is, I think, a better. I think Dr. Chandrakala can answer this regarding factor.
Prior and post. See, we give factor prior and post. Actually, the steroid injection is to mainly reduce the inflammation and to reduce the pain. See, if you reduce the inflammation, the main point of giving the radiation synovectomy is to create an inflammation. When you give steroids, we thought actually how much we are contradicting, like inflammation is going to come down, so that we don't give steroids in our center. Factor we give it for 48 hours, and then we give prophylaxis for about 2 weeks, along with physiotherapy.
Yes, and cold compression. It's a very simple technique, but even the joint is given full cold compression before injection. Like when the patient comes to nuclear medicine department, we start giving cold compressions. Even after giving injections, once the injection is secure, even the bandage is put, before putting the final splint, cold compression is given. So whatever pain or acute local site inflammation, which may cause an additional pain to the patient is reduced by those cold compression. We also advise if the patient goes back home and he still has pain or feels that joint is bleeding, become warm. I think cold compression works better. We have not so far ever used steroids.
And then immobilization, they have made a splint actually. They only makeshift splint in KM hospital. Dr. Kirti might show it actually, they only be there all the time actually, to the patient, keep the splint and immobilization. So those things are taken by Kirti.
In our center, the splint is removed after 48 hours. The occupational therapies actually gives them a proper format of the slow mobilization and later on follows them up with the gradual increasing mobilization and the exercises. So that protocol is followed, in a way so that And the patients are admitted for that. They are not admitted for synovectomy.
When you start mobilization, just after giving radio synovectomy or later?
No. The mobilization is started after 48 hours. Till then, it is kept immobilized so that
It is printed.
it is splinted.
Thank you.
The joint is splinted, and then the mobilization is also very, very gradual. I think that part will be told by occupational therapists. Yes, because they are the one who are slowly mobilizing the joints after 48 hours.
Thank you, ma'am. I request Dr. Anju, ma'am, to felicitate our speaker. Moving forward to the last session, which is a virtual talk on the topic of hemophilia and OT exercises by Dr. Kirti Patil, ma'am. I request Dr. Deepak Asia, sir, and Dr. Abhinav, sir, to chair the session.
Yeah. Dr. Kirti Patil, senior occupational therapist. She is involved in providing comprehensive care for hemophilic patient. She is also giving workshops, conducting CMEs for therapists all over India.
Ma'am, please unmute yourself.
Your voice is not coming, ma'am.
You can just reconnect with the audio thing. Ma'am, can you just speak something so that we are able to
Ma'am, please
check?
speak. You can start your presentation. I think problem is solved.
I think नीचे वो बंद है ना
हाँ.
हाँ, unmute करना पड़ेगा. Ma'am, are you there?
Kirti ma'am, please speak now.
Kirti ma'am, can you please log in again? Ma'am, can you please log in again?
Kirti ma'am, can you join with the mobile?
Connecting.
Okay, sir. Now.
Yeah.
Hello.
Ma'am, we are able to hear you.
Fine, that's great then. Without any further ado, we'll just start.
Yeah.
So, good afternoon, everyone. And myself, I'm Dr. Kirti Patel. I'm occupational therapist working with hemophilia for the last 15 years at ISTC Center, KEM. So first of all, I want to thank WFH Twinning Program Committee for the approval of this project, and specifically Dr. Bipin and Dr. Anju Kadu for arranging this online CME. So since morning, we have been listening about what is hemophilia, its types, and the treatment management of it. So just in brief, I'll just go through this. Hemophilia is an X-linked heritable coagulopathy with all over prevalence of 1 in 10,000 individuals. At our center, at our daycare center, we have specifically 2 types of hemophilia: factor 8 deficiency, that is hemophilia A, and factor 9 deficiency, hemophilia B. Many times we have treated VWD bleeding disorder also. It's very important for a therapist to know the severity of the disease. First and foremost, when we are treating any patient, it's very important from our point, because the patient comes to a daycare center, take the factors and go away. We have to educate him about the importance of exercises, maintaining his joint integrity, and we should also educate him about the severity or what kind of factor he's taking, how much units factor he's taking, so that anywhere, any center he is going, he should be able to answer that. So this mostly at our center, we see hemophilia A less than 1%, that is severe hemophilia, because they have developed their target joints already. Moderate and mild hemophilic mostly come when there is a physical injury or any surgical intervention has been done for them.
Now let's come to the most common bleeding joint and muscles. At our centers, we have mostly target joints we see is the knee joint, elbow joint, and the ankle joints. And the most common muscle bleeds we see is the iliopsoas muscle, forearm muscle, and gastrocnemius muscle. Of course, there can be bleeds anywhere except these target joints. So now the purpose of talking about the therapeutic is that what is the relationship between joint bleed and inactivity. Most of the times patient come to the center, take the factors, goes away because he's maybe not from the local center, he's coming from other states or other districts. So it's very important to explain them that whenever there is a bleed, there is a deterioration of joint surface, maybe he went to go with synovitis, there is pain, then again he goes into rest, then there is a deformity forming, and this is a chain reaction which is always forming. Ultimately, then the patient comes with a very bad joint, and then it becomes very difficult, or maybe we have to go for an orthopedic intervention when we are left, we are not having the option of a conservative management. So yes, movement or exercise in hemophilia is the very essential part, because if in the non-bleeding phase, when the patient is not bleeding or when the patient is on prophylaxis and we are regularly mobilizing the joints, what we are doing is maintaining the joint integrity. There will be fewer bleeds. There will be a good functional recovery, good lifestyle. He will be engaged in his school. The school regularity will be there. His performance will be improved. So it is very important to educate the patient first, tell him the importance of exercises, and then start with any category, may it be for target joint, muscle, or synovitis. So now this talk will be mainly focusing on our goals of occupational therapy at the center. Our goals are mainly to relieve the pain using mainly modalities of cryoprecipitate, cryotherapy, prevention of deformity, preservation of joint function. Doing this, we want to improvise on the range of motion. We want to bring the normal muscle length. We want to avoid the recurrence of bleed, and this all will help into independence in ADL work and leisure activity. So now whenever a patient comes to us, there are mainly a broad spectrum of patient who comes to us. First is a patient with an on-demand bleed, and second would be a patient who's on prophylaxis. So first we will talk about the on-demand bleeds. So whenever a patient comes to us, first he comes to a hematologist, get himself clinically assessed, and then CFCs are given. Then when he comes to us, we first do the primary clinical examination. So when I mean primary and secondary clinical examination, this part every therapist has to keep in mind, because the patient will always come, we will be a point of contact every time the patient comes to daycare center, not only when he is bleeding, but also when he is into off bleeding phase. So primary evaluation will have, we have to do his complete medical history. We have to take the history, how the bleed has caused. Mainly a child will give a history of sitting for long hours or writing 3 hours paper and coming with an elbow bleed or any physical abuse. Or an adult who is working on a desktop maybe come with a history of sitting for 6 to 8 hours and then turning up into iliopsoas bleed. So whenever there is an acute bleed, the basic inspection like swelling, wasting, pain, crepitus, range of motion using goniometry, pain on the visual analog scale, manual muscle testing and sensation, baseline evaluation has to be done. HGHS is the score we do. I think this slide is not very clear. HGHS is a hemophilia joint health score, which is not, which is usually done to check the status or the status of the specific joint, that is the target joint, specifically knee, elbow, and ankle. So, yeah, but HGHS has to be done only when the patient is off bleed phase after 2 weeks. Whenever there is an acute bleed, HGHS scale is not recommended. So after 2 weeks of bleed, when you want to do the reassessment of the joint, HGHS and FISH scale, that is the functional independence score for hemophilia. These are the 2 scales we are using at our center. And the clinical examination is done. In the later phase, that is the subjective phase, we also do the speed, gait analysis, limb length, posture, coordination, and overall fitness. For fitness, we do 6-minute walk test of each and every patient. The second part of the evaluation, that is the secondary evaluation, is very important because that is going to give you an idea about how a joint is moving towards chronicity or maybe deformity, or is it going into contracture. We should have a history of number of bleeds he has, number of infusions he has taken, whether he is going into whether he has developed any inhibitors, or if he is developing any contracture or any other complications like pseudotumor. Now, this talk will mainly, I will talk mainly about the joint bleed, muscle bleed, and arthropathies. So when you are talking about joint bleeds, these are the main knee, ankle, and elbow are the three main joints which are frequently bleeded and which are frequently seen in our daycare center. So specifically, it is characterized by range of reduced range of motion. There is pain, and there is palpable swelling and warmth over the skin. Mostly, it is in the first 2 decades of life. Most of the time, these children will come to us. So, of course, the patients who are not on prophylaxis, I'm talking these are all joint bleeds who are coming on demand to the center. So very early joint bleed is recognized with the tightness of the joint. There is a pain, so the patient will have an flexion attitude here. For example, on the knee, he will keep in the fixed flexed deformity. Or if it is in the elbow, he will always keep the joint in the flexion attitude. There is muscle spasm, and even after giving CFCs or even after the patient is in rest, sometimes it is observed that there are re-bleeds which are happening. So we need to monitor these re-bleeds for next 72 hours also. So what we do at our center is the patients who are staying nearby, we ask them to follow up after 72 hours of the bleed, and then consequently we start with the rehab protocol. Also, for the prophylaxis patients, we have done 2 programs. One is training the trainer, that is training the mothers for giving infusions, and training the mothers to start with the first aid of management of bleeds. Like if at home they are giving prophylaxis, and if there is a bleed, there is some physical injury, and if the patient is causing bleed, our center is comparatively central to the most of the patients at Mumbai, but the patients who are far off, for them, we train the mothers. We tell them what first aid has to be given. That, like most of the therapists must be aware of right, that is rest, icing, compression, elevation, and then we elaborate the elevation to exercise also. Very important when we are talking about joint bleeds, we should know what is a target joint. So like in a joint, when there is 3 or more consecutive bleeds in a period of last 6 months, then we label that joint as a target joint. Mostly the target joint are again elbow, knee, and ankle. So now we'll talk about how after CFCs and after a bleed has subsided, how the protocol goes. I will just brief up because in detail workshops will be held next year for the therapists exclusively. So like these are the day-wise protocol. With day 1 we start with RICE. RICE is the for the full form for RICE is rest, icing, compression, and elevation. Recently we have started with police also. We have replaced R, that is rest, with preventive, and OL, that is optimal loading. We have observed that when we ask the patient to keep the joint in a resting position for a longer time, he keeps it in a flexion attitude, and then we have a problems of contracture and deformity development. So we have to educate the patient about optimal loading also. Of course, with RICE and police, we factor corrections are given. Then after 2 or 3 days, when the swelling and pain has subsided, we start with the isometric exercises. Sometimes when we know that it is not a joint in which synovium is developing, we start with pain management modalities. We mostly at our center, we use ultrasound therapy. Okay, ultrasound therapy we give for continuous 5 days, and then we stop it. Kids below 5 years, we try to avoid using the ultrasound modality. And in patients who are developing synovitis, we try to avoid using ultrasound therapy. Then by 4 to 5 days, after 4 to 5 days, multi-angle isometric in pain-free range and PNF techniques can be started. Within a week, 3 exercises can be started. Of course, by that time, the non-affected joints can be over-strengthened. You can start the patient make walk with walking aids. Like if there is an iliopsoas bleed, you have to make the patient understand that he has to use a crutch. See, it is very easy for us to tell them to use a walking aid or everything. These are all young boys, teenager boys, school-going boys. So they don't prefer to use, they have a social stigma to use all these cane crutches. So education and preventive measure, that is the main goal of therapists, to explain them this. Okay, because this is going to avoid any kind of further bleeds. Then after a week or so, when the bleed has subsided, got into a subacute phase, we can start with the progressive to resistive exercises and weight bearing exercises. There are things by which we can actually avoid the target joint, that if the bleeds are treated early and completely, this can minimize the risk of developing synovitis. Regular exercise has to be incorporated. Whenever the patient has target joint, we see to it for a week of 4 to 6 weeks, we try to keep them on prophylaxis and try to mobilize them, try to do the strengthening, because they have developed so much of muscle wasting, and there is hardly any joint space left. So along with manual traction and strengthening protocol, we try to give them regular exercises. Education of patient and family, very important. I had been stressing on the education part on and off, because in last 15 years, what I have observed is if a patient comes to you, you give the protocol, you give the factor, and he goes away. Again, he is going to come to you back and forth, maybe with a more deformities or contracture in the future. So it is very important that you explain them the importance of exercise, the importance of exercise when he is on prophylaxis or when he is in non-bleeding phase. When he is not bleeding, you have to ask them to do regular strengthening protocol. You can ask them to do swimming or supervised cycling. Supervised is I will tag it very well, because we just tell them how do cycling बहुत अच्छा होता है करने के लिए, but then they'll end up having bleed while doing cycling also. Educate the parent about identifying the bleeds early. The more early the bleeds are identified, the patient comes to us to the daycare center as early as possible. It is more treatable, and we can avoid the formation of synovitis or any other deformities. Implementation of the RISE measures as soon as the bleed is identified. As I said, that we have trained the mothers for the RISE techniques. Protection of the joints. We make a lot of splints at our center. Even we have designed cuffs for elbows and knee joints specifically, so that our kids can use them at school regularly. It will not assure you that you will not have a bleed, but at least give the protection to the joint, because they are going to a normal school where there are normal kids, and then they land up having a physical injury at the school. So at least they are using those cuffs, and it is giving a proprioception that I have to be careful. I have to take care of my joint at the school also. Restoration of motion strength proprioception at the pre-bleed level as soon as possible after each bleed. So like sometimes what we do, we make a chart, we make a protocol, we write down the home programs, the patients who are staying far off, and then we call them on weekly basis, or maybe once in a month, so that that protocol is followed up. And then later on, when we reassess the joint, we know what is the status. Early aggressive management and adequate post-bleed rehabilitation of bleeds can delay or even prevent the synovitis bleed cycle. As you must have seen in the previous slide also, there is a bleed, there is rest, again inactivity, and the bleed phase is going to, the vicious cycle is going to continue. You have to break the cycle by doing regular exercises. So I'll be showing more of a pictures here also, like this is a knee triple deformity, which was this patient had come to us from Dhule. And we have this kind of material, serial static correction splint we make at our center. This is like a low thermoplastic moldable material, and this all molding and splint, tailor-made splints we are doing at our department itself. So serial static correction means weekly or in 15 days, whenever the patient comes to us, along with the joint mobilization protocol, the splint remolding is done at our center. Again, this patient specifically had fixed flexion deformity. So for this particularly patient, we had used a turnbuckle splint. Like this is a static progressive splint in which the component of the angle component can be increased at a alternate day, or maybe it decide. But then it is very important that all these splint patient, whoever comes with, whoever we are giving the splint, follow up with us regularly. ऐसा नहीं splint दे दिया and then they just forget about it, because the angle has to be changed regularly, monitor, and then as we give the stretching, as the range improves, we have to remold the splints. This patient specifically had contracture deformity, flexion deformity of the elbow. Again, the low cost serial static splint was given, and over a period of 6 to 8 weeks, we have seen a improvement in his ranges along with ROM and muscle strengthening protocol. So now the question is how to choose what kind of intervention has to be given when the patient will go for a surgical intervention and when we have to do a conservative management. So when there is a contracture above 60 degrees and there is no involvement of any other secondary joint, end field is reasonable, and if the patient is following up to us to you on a regular basis, and if you see that there is at least 5 degrees a week improvement or 10 degrees in 2 weeks, then you know for sure that this patient can be managed non-operatively. But when there is a flexion contracture of more than 60 degrees and then there is a failure of conservative management more than 2 weeks, then of course we will go for an operative management. So in operative management, I think Sir Mohanty sir must have discussed about the extra-articular soft tissue release, then elbow synovectomy, osteotomies, and in the later phase maybe joint replacement also. The second part is synovitis. Dr. Shwetal madam had just elaborately explained about the synovitis, what kind of work it's been done at KM hospital. So mainly the guidelines for our management, that the rehab management, is we are the coordinators for this patient. We screen the patient. We do a HGHS. We see if the joint is a target joint. As I explained, if the patient is giving you a history of more than 3 bleeds in a consecutive month, then you know for sure that he is going into synovitis. Then we send the patient to orthopedic surgeon, an MRI is done, the synovium thickening is measured, then he is registered at the nuclear medicine. So basically this is all teamwork, what has been happening. Whenever the injections are, whenever the injections come, we coordinate with the patient. Patient is seen that if his inhibitor status is done, his HGHS fish scores are being done, he is thoroughly evaluated, because after the radioactive synovectomy is done, it is completely the responsibility of the therapist to have a very good follow-up with the patient. We have follow-up of the patient from Rajasthan, UP, Goa, everywhere. They come to us every 3 months. They come to Mohanty sir every 6 months. The MRI is done. We see the radiological changes also. We see the joint HGHS score and the fish score also. Of course, when the synovectomy, radioactive synovectomy is done, the patient is kept on prophylaxis at our center for 2 weeks. In that week, we make sure that the patient visit to our center. Whenever the factor infusion is done, immediately after the prophylaxis is given, he is mobilized then and there at the center, and a good home protocol is being given to him. And we see to it that a regular follow-up is done after those 2 weeks also. If we are not going for radioactive synovectomy, and if if there are no resources for radioactive synovectomy, first you can maybe coordinate with the hematologist, ask them to keep the patient for 6 to 8 weeks of prophylaxis, start with the rehab protocol, and then of course what I have mentioned for rice therapy and then splintage, and gradually you go. Even after 6 to 8 weeks of rehabilitation under prophylaxis, it is not improved, then the patient can be sent for radioactive synovectomy. So this is in general what we had talked about: acute hemarthrosis, chronic synovitis, and arthropathy. Coming to muscle hematoma, most commonly we can see muscle hematoma in skeletal and smooth muscles. Mostly the patient will come with pain, swelling, reduced ROM. Two things, basic things what we need to do is do a physical examination and send him for a ultrasonography, which will give us the defined collection in the area. Specifically, if there is a iliopsoas bleed, this is typical iliopsoas bleed, but the patient will come to you with hip knee flexion. Mostly it is sometime misdiagnosed with appendicitis, or there is a pain in the abdomen. The patient is walking, and if you see him in a standing posture, he is absolutely all right. But then when we make him supine, there is a hip knee flexion, which is typically observed. When the knee is extended, you will see a kyphosis in his spine. Commonest site are iliopsoas, gastrocnemius, and forearm muscles. So these are the three typical bleeds, which muscle bleed which come to our center. And this is the typical iliopsoas muscle bleed, how it will be seen. What happens in iliopsoas muscle bleed is the iliopsoas muscle is involved. The knee is not at all involved, but because the patient is keeping himself in hip knee flexion, the hamstrings get tight, and then we have to deal with the hip and the knee. So I always ask the patient to, when the pain subsides slowly, when he has taken the CFCs, go into sideline position, keep the knee extended to whatever position. So every 2 hours, you have to make it a point that he goes into sideline position, so that at least you will spare the knee. Or else it is observed that the hamstrings goes into tightness. So I'll just discuss about iliopsoas bleed rehabilitation. First, adequate factor replacement has to be done. We advise complete bed rest till the pain or the flexion contractor starts resolving. Maintain general mobility and stand of the unaffected limb. We can start with the partial weight bearing on the crutches, and then gradually go for a full weight bearing. Active mobilization and gentle stretching can be started. We also give ultrasound on the iliopsoas muscle and cryotherapy every 2 hours. Ultrasound once in a day. Ultrasound muscles not on the iliopsoas but the paraspinal muscles, because it has been observed that the iliopsoas muscle, they keep on contracting, and the paraspinal muscles also go into contractions. Then positioning, if deformity does not heal, then we start with the skin traction. So this is the type of skin traction we have designed at our center. This is very low cost skin traction. So if you can see, appreciate there, along with the skin traction, below the knee, we have kept a posterior knee guard, so that whenever you are doing the stretching and maintaining that stretch, the joint very well sits on the joint, on the splint, and there is no elicited pain, and then the patient can maintain the traction for a longer time. In the skin traction, we will not increase the weight of the traction, but we will increase the time. Like for day one, if we start with 5 to 10 minutes, see, 5 to 10 minutes sounds very easy, but it is very difficult for the patient to maintain in 5 minutes also. So every 2 hours, we ask them to do icing. We tell them to do basic stretching within the pain limit, and then we put the traction every 2 hours. So day one, we start with 5 to 10 minutes, and then gradually increase to 4 hours. We keep the traction till we achieve the full extension of the hip and the knee joint. And then this is typical forearm bleed. You must have seen in VICs also, sometimes fasciotomy has to be also done. But sometimes when the CFCs are given or prophylaxis are given, so stretching, ultrasound and static progressive splint also helps in this kind of bleeds, forearm bleeds. Then there are calf bleeds. So for calf bleeds also we have observed that there is a gastrocnemius tightness or there is TA tightness. So to avoid that, we can ask the patient to keep BKFDS or you say L-spleen in the resting position and then gradually wean it off as the bleed subsides. In muscle bleed, it is observed that sometimes there is nerves are also involved. There is a sensory loss. Like in iliopsoas bleed, there is femoral nerve entrapment. So you know that the patellar jugs are diminished, quadriceps muscles are weak, or in the tibial nerve is affected in gastrocnemius, or in the forearm muscle, forearm bleed, the median of the ulnar nerve is affected. So if that is the situation, most of the time when the bleed subsides, the compression is released, proper factors are given, the nerve comes back, the working of the nerve comes back to its original thing.
Kirti Madam, can you please cut slides? We are falling short of time.
Yes, I am almost done. These are the kind of cups we give at our center, protective cups. The last slide is about the last picture is about the headgear which we have given to our kids who have head injuries. Most of the time for patients on prophylaxis, imicizumab or Hemlibra or ITI, we try to give them group therapy. So whenever they come to take the CFCs, we give them group therapy and then gradually increase the protocol. So this is our team, multi-specialty team at our center and our kids PWH. So thank you.
Thank you, Kirti Madam. Very nice presentation, and almost all the part of the OT is covered in your presentation. It's a very good presentation. One thing I would like to ask you, which sports activity you would like to prescribe to the patient?
At our center, mostly we tell them if the patient is on prophylaxis and if there are no target joints formed yet, then early we tell them to start with swimming, that to alternate days earlier. And then maybe he can go for cycling. But outdoor contact, but
thank you very much.
Prophylaxis and newer drugs, it will be magical for them. Maybe they will go into other kind of sports activities also.
Swimming will be in the middle of the swimming pool, I think, not on the corner edges of the swimming.
No, because we have patients who have done diving and then come with a bleed. So we have to be very careful. We have to give a letter to the swimming coaching, the swimming coach, and then do things. Even we have to give a letter to the school authorities also about giving punishments, physical punishment or giving physical, not giving them PT lectures for a longer time.
Any question from audience?
Ma'am, I want to ask you that how do you treat the chronic joints which have been bleeding so long and now they are in a contracted state?
I think that I have for the target joint, we have already discussed. Like if it is possible, if your center has that resource of prophylaxis, then we keep the patient on prophylaxis for 2 to 3 weeks, whatever possible. And then under prophylaxis, start with the gradual mobilization, because we had observed that without factor coverage, sometimes they may bleed. If you try to stretch the joint, if you try to give them splint, if you try to give basic RM exercises also. So it is better if they are under prophylaxis and do the rehabilitative part.
Thank you, ma'am.
Thank you, Kirti ma'am. I now request Dr. Deepak Asia sir and Dr. Abhinav sir to give a memento to Dr. Kirti Patil. I request Shwetal ma'am to please collect it on her behalf. Okay. Yeah, Chandrakala ma'am, please come forward. Please come forward.
Can have a final group photo.
I now request Dr. Bipin sir to give a memento to Mr. Saurabh Nalamwar. Thank you. Today we had a very excellent series of lectures by our esteemed faculty from KEM Mumbai, who enlightened us on every aspect of hemophilia. I now request Dr. Anju ma'am to give a vote of thanks.
On behalf of Lata Mangeshkar NKP Sims College, Dental College, BSPM of Dental College, College of Physiotherapy, and on behalf of Hemophilia Society Nagpur chapter, I would like to extend thank you to each and everyone who's made this event a wonderful event. And there's so much of learn from this event. So we are on for benefit of those who have not been able to attend and has not been able to be a part of it. We have an online session, an online streaming which was done. So it is accessible after the session is over. So we would be sharing link with you all. You can share this link amongst everyone and make more people be aware of so many things that is happening in hemophilia. I would like to, I have a long list to thank people from. So first and foremost, I would like to thank Mr. Prik Malwa, the president of HFI, who has made this possible that such a beautiful program and encouraging training is happening in Nagpur, Lata Mangeshkar. Secondly, I would like to thank the RCC chairperson, Mr. Valsiramji, VP Development, Mr. Ramu Gutkarji, and of course, Mr. Saurabh, who has come all the way from Pune to be a part of this event. I would like to extend a warm thank and special thank to our Dean Sir, who's been so very encouraging and helped us put up this program. And most importantly, the KEM Hospital, each and every one. Most importantly, Chandrakala Madam. And say, whenever I see her, it's always inspirational, her beautiful and magnanimous smile, and she always encourages you to do well. Bipin Sir, I have been calling him up now, days, nights, sir, what this, what that. Sir has been very supportive. I would like to really recognize Nandapai Madam, and for her first interaction with her was on online CME, and it was very enlightening. And Shwetal Ma'am, it's an honor to see you here. And all the faculties, especially Kirti. Kirti has been, so very dedicatedly, she explained everything in a beautiful way. And I'm really admire your dedication. And I would like to thank all the chairpersons and everybody from behalf of our college and everyone who is involved, whose name I have not taken. I would like to really thank all of them from the bottom of my heart. And especially all my office bearers and all a young guy who's come, who's a hemophilic who just joined MBBS. With this, I would like to take the opportunity of thanking my MOCs, Kiran Madam and Rupal Madam. I request Chandrakala Madam to kindly give them a token of planter from my side.
Fantastic job, actually. All the
With this, we close this program. And on behalf of Hemophilia Society, Nagpur chapter, Dr. Ayushri Deshmukh, and I, as secretary, will close the CME now. Thank you so much all for being there.
हाँ लाइट ऑन कर देता हूँ.